Now, I would like to welcome for the opening remarks two of the leading pulmonologists of India who need no introduction, Dr. Randeep Guleria sir and Dr. Deepak Talwar sir. Thank you so much.
Thank you and good morning to everybody. First of all, let me take this opportunity to congratulate Dr. Deepak Talwar and his team for PACS 2026, which is going to be an academic feast for all of us. And we're starting the conference with today's summit on biologicals. I think it's very, very important for all of us who are practicing to really understand the paradigm shift that is happening as far as T2-driven inflammation in chronic respiratory disease is concerned. I'm not only talking about asthma, it's moving on to COPD, it's moving on to other diseases like EGPA. And therefore, for all of us who are practicing medicine, it becomes imperative for us to understand how do we use these biologicals in today's practice and how can they change the life course of these patients with chronic respiratory diseases. And to really understand a lot about that, we have this workshop which is looking at biologicals in respiratory diseases, focusing a lot on asthma, but I'm sure there would be discussions on COPD, on EGPA, and how do we place them, and what is the future as far as these biologicals are concerned, as we learn more and more about them and as more and newer biologicals come into the market. So really, to understand all of this, especially for us, because cost also becomes an issue, and being able to choose the right patient also becomes an issue, we have this summit and we have international speakers, and I think we're grateful to the American College of Chest Physicians for co-hosting this summit. And we will now start. I'll ask Dr. Talwar to give his brief comments.
Good morning, everyone, and thank you for being here. Another edition of PACS, and of course, upscaling our skills is what is required. And what a better way to begin than this, which is Biologic Summit. Both of us standing here today has a long memory of biologicals when in 2008, we started omalizumab. And I know a couple of people sitting here also were there at that point of time. I think we were just about 30 people all across India who were sensitized to biologicals. And it was very difficult to understand that it can be such an expensive medication for disease like asthma. It was a tough call at that time. Today, I think 18 years down the line, we have done this journey in way we can say that at least significantly improving the outcomes in the patients of severe asthma. But we have a lot to learn. And there we have definitely people who are more experienced, not only in handling them, but also as the new ones come in, how to incorporate into our practice, which is very challenging at the moment, and we are going to cover that today. And we have excellent international and national faculties to debate and go on this way. And we will start the proceedings now with the first speaker.
Yes, before we do that, I'd like to invite on the stage the chairpersons for the sessions, Professor Rajinder Singh and Professor S.K. Bhadia, to kindly come onto the stage. And the expert panelist is Dr. Hari Krishnan and Dr. Basant Hazarika. The PACS moderator for the first session is Professor Naveed Nazir Shah. So I would request all of them if they could come on to the stage. First session, session 1, is basically trying to understand the pathophysiology and how do these biologicals act. So it's targetable pathophysiology, mechanisms in asthma, and we have an expert speaker, Professor Michael Wishner, who will be talking on this topic, giving us an overview and understanding of what is the pathophysiology as far as these biologicals are concerned. So without wasting much time, I would advise, I'd ask
Can you have a slide of Professor Roland Bull? Good morning, Professor Bull.
Good morning.
Yes.
So, Dr. Michael Wessner is the first speaker.
Which is the first speaker? Okay, so the first speaker is... Okay. Okay, so first speaker is Professor Michael Wexler. Can we have his slide, please?
So Professor Wessler is the Professor of Medicine, National Jewish Health, Denver, USA. He's Director, Cohen Family Asthma Institute. He's an internationally recognized expert in severe asthma, COPD, eosinophilic lung disease, and biological therapies, being the principal investigator for over 60 clinical trials and author of more than 390 peer-reviewed publications. He has led research in multiple breakthrough biologicals, including benralizumab, dupilumab, mepolizumab, tezepelumab, and decimumab. Associate editor of CHEST and member of several leading international respiratory medicine task force. So over to you, Professor Michael Wexler, for your talk as the first session. Thank you.
Thank you. Can you see my slides?
Good morning, Michael Wexler. Nice to have you. Where we had discussed EGPA a couple of months ago, and it's a pleasure to have you again.
Great. Well, thank you so much for having me, and good morning to everybody. I'm sorry we're not in person all together, but I look forward to hopefully coming to India one day. I was asked to speak about targetable pathophysiologic mechanisms in asthma and to talk about both type 2 and non-type 2 inflammation present in the future. And so I'll try my best to speak about all these topics in a limited amount of time. We could spend a few days talking about them for sure. These are my disclosures. So as you all know, asthma is common, it's heterogeneous, it's highly prevalent, it affects 340 million people worldwide. And you mentioned before that it affects maybe the severe asthma is about 3 to 4% in India, but I think it's probably a little bit more than that, and we often don't detect severe asthma. And these patients tend to have more exacerbations, more symptoms, and they also have a substantial impact on quality of life. The way we recognize people with severe asthma is by having more frequent symptoms, but also by presence of exacerbations, emergency room visits, hospitalizations, missed work or school, and the negative impact it has on quality of life and long-term decrease in lung function. We also have come to recognize that oral corticosteroids have significant detrimental effects, and yet approximately half of patients with severe asthma receive either intermittent or long-term oral corticosteroids. And there's a cumulative burden of oral corticosteroids that has an impact on patients with cataracts, glaucoma, osteoporosis, infections, hypertension, and depression, anxiety, and more. And each prescription of oral corticosteroids results in a cumulative burden, particularly people who have 3 or 4 prescriptions per year. We see this in terms of all of these adverse events that these patients have, whether it's metabolic or cardiovascular or bone-related or mood disorders. The GINA guidelines have advocated for a stepwise approach for the management of asthma. And as you know, the GINA guidelines get updated every year. In most of the world, you follow the top algorithm with as needed low doses of inhaled steroid and formoterol, escalating to low doses of maintenance inhaled steroid formoterol, increasing the dose to medium dose of inhaled steroid formoterol. And then in step 5 is when we start to add on other therapies like long-acting anti-muscarinic agents and biologic therapies, whether it's anti-IgE, anti-IL-5, anti-IL-4, anti-TSLP. It is important, and on the left-hand side of the slide, I just want to highlight the key components of the importance of confirming a diagnosis, evaluating comorbidities, addressing inhaler technique, and also evaluating lung function and patients' preferences or goals. But it's really what I'm going to focus on is the biologics in step 5. And it's these biologic therapies that have really revolutionized our management of patients with severe asthma. So the first question I'll pose is, when do I consider biologics for severe asthma? Clearly, it's for people who have poor control, who have daily symptoms despite inhaled steroids and long-acting beta agonists, where people who have interference with daily activities, interference with sleep, chronic oral corticosteroid use, or at least 2 exacerbations a year. In some places, really biologics are only considered for 4 exacerbations a year. But if you have 2 exacerbations in a year, that puts you at increased risk of bad outcomes down the road. So one of our goals is to try to evaluate these patients. But before starting biologics, I do exactly what the guidelines say. I make sure that it is asthma. I maximize therapy, and usually with triple combination therapy. I confirm adherence and inhaler technique, and you'd be surprised what the level of adherence is in our patients. It's usually no more than 50 to 60%, sometimes because of cost, sometimes because they don't have access, sometimes just because of human nature. And then it's really critical to evaluate and address complicating comorbidities, whether it's sinus disease, reflux, aspiration, sleep apnea, vocal cord dysfunction. All of these comorbidities are commonly associated with severe asthma. And people with severe asthma, at least 30-40% of chronic rhinosinusitis. But the reason I'm showing the slide is to recognize also that there are more rare diseases like eosinophilic granulomatosis with polyangiitis, like allergic bronchopulmonary aspergillosis that need to be excluded in our patients as well, and also just address all of these comorbidities. But if asthma is confirmed, and if you've maximized therapy and optimized adherence, and you've addressed all the comorbidities, then, and really only then, should you consider a biologic. But the first question you should be asking about choosing a biologic is, what type of asthma is it? And when I say what type of asthma, I'm talking about type 2 or non-type 2 asthma. Type 2 asthma is asthma that's mediated by Th2 cells and innate lymphoid or ILC2 cells. And it's identified by the presence of type 2 biomarkers, including eosinophils, exhaled nitric oxide, sputum eosinophils, or asthma that's driven by allergens. And it's asthma that is mediated by IL-4, IL-5, and IL-13. If you have absence of these, then we generally consider you to have non-type 2 asthma. And there's a debate about the existence of non-type 2 asthma, whether it's just asthma that has low biomarkers because of inhaled or systemic corticosteroids, or whether it's asthma that's mediated by comorbidities like reflux or aspiration. We know that people who are at risk are those who have the highest biomarkers. And this is an important concept that Simon Couillard and Ian Pavard brought forth a few years ago, which is, who is at risk for an asthma attack? And the first question you should ask is, did the person have an asthma attack in the last year? And if the answer is yes, if you go on to the right-hand side, you should ask, did the patient have 2 or more clinical risk factors? If the answer is yes, they're at more risk for having worsening asthma. But then you also want to evaluate whether they are asthma genus step 1 and 2, step 3, 4, or step 5. And people who are on higher doses of inhaled steroid LABA are at higher risk. The last thing you should do is evaluate their biomarkers. Each row here, it corresponds to an elevated nitric oxide, greater than 50 in the top row, 25 to 50 in the middle row, and less than 25 in the bottom rows of each section. And in each column refers to elevations in eosinophils, less than 150, 150 to 300, or greater than 300. So of all of the risk factors, the people who are at risk are people who have had an asthma attack in the prior year, people who have 2 or more other clinical risk factors, people who are genus step 5, and people who have high eosinophils and high nitric oxide. So it's important to think about all of these clinical risk factors and biomarkers when you see your patients with severe asthma. Those risk factors are poor symptom control, low lung function, bad adherence, reliever overuse, history of ICU admission, comorbidities, and environmental exposures. These are the people who are at risk, coupled with high eosinophils and high nitric oxide. And David Price has shown almost over a decade ago now that people with high eosinophils have the greatest risk of exacerbations. They have the greatest risk for acute respiratory events. They have the greatest risk for having poor asthma control, and they have the greatest risk for having low lung function as well. So it's incumbent upon you to check eosinophils, to check exhaled nitric oxide. Once you've done all of that work, you have to ask, what are your biologic options? And when we think about all the pathways that are involved, it's important to think about the pathophysiology of type 2 inflammation and non-type 2 inflammation. Type 2 inflammation usually starts at the airway epithelium, where different stimuli, whether they are allergens or irritants or pollutants, will stimulate production of alarmins, epithelial cytokines like TSLP, thymic stromal lymphopoietin, IL-25, and IL-33. TSLP in particular stimulates Th2 cells and ILC2 cells to produce interleukin 4, 5, and 13, with interleukin 4 stimulating B cells to produce IgE that can act on mast cells in the presence of different aeroallergens that will result in the release of histamines, prostaglandins, and leukotrienes. IL-5 is a key cytokine that's involved in the maturation, proliferation, and activation of eosinophils. And interleukin 13 is involved in mucus production, nitric oxide production, and airway hyperresponsiveness. So we have therapies now that target TSLP, that target IgE, that target IL-4 and 13, and that target IL-5. Another important epithelial cytokine is interleukin 33, and we're developing targeted strategies to target IL-33, both in asthma as well as in COPD. To date, we don't have good therapies for non-type 2 asthma, which is usually mediated by neutrophils, Th1 cells, and Th17 cells, particularly in response to exposure to microbes, viruses, pollutants, and different irritants. So we have good therapies for type 2 inflammation, but not such good ones at this point for non-type 2 inflammation. To date, we have anti-Ig with omalizumab, anti-IL-5 with mepolizumab, reslizumab, benralizumab, anti-IL-4 with dupilumab, and then more recently we've had development of tezepelumab, anti-TSLP, and also anti-IL-5 therapy with depemokimab. So those are the 7 biologics that are currently available in the United States and in many other parts of the world. What can we achieve with these biologics? Well, we've shown that we can reduce exacerbations, we can reduce steroid dose, we can reduce side effects, we can improve symptoms and quality of life, and we can have a significant impact, even potentially resulting in remission or disease modification to prevent asthma over the long term. As you know, blocking eosinophils with anti-IL-5 therapies has become a key part of our strategy in management of patients with asthma. And we've utilized either benralizumab to bind the IL-5 receptor or mepolizumab and reslizumab to bind up IL-5. Depemokimab also is an ultra-long-acting anti-IL-5 therapy that also binds IL-5. Mepolizumab was first approved in the United States over 10 years ago, based on the studies by Hector Ortega and Elizabeth Bell that showed that anti-IL-5 therapy with mepolizumab could reduce exacerbations by 50%. There was a modest effect in lung function, but there was an effect in terms of facilitating glucocorticoid withdrawal while still reducing oral glucocorticoids, 50% reduction in steroid dose, 50% reduction in exacerbations. These studies were key in terms of leading to the approval of mepolizumab. Reslizumab is administered intravenously based on body weight, and it too resulted in significant reduction in exacerbations as well as improvement in lung function, but it's administered intravenously and oftentimes doesn't get utilized as much because it's not as easy to administer in most practices. Benralizumab is an anti-IL-5 receptor therapy that reduced exacerbations anywhere from 28 to 51% depending on the different arms of these studies. But one of the key benefits of benralizumab is that after the first 3 doses, it can be administered every 8 weeks. It also results in almost complete depletion of eosinophils through an antibody-dependent cell-mediated cytotoxic activity. Dupilumab, that blocks interleukin-4 and interleukin-13 at the IL-4 receptor, has been shown to be effective in a variety of different entities, not just asthma, but atopic dermatitis, chronic rhinosinusitis with nasal polyps, prurigo nodularis, and also even eosinophilic COPD. It can be administered subcutaneously every 2 weeks with 200 milligrams or 300 milligrams, and it works particularly well in people who have high eosinophil counts or high nitric oxide levels. And it's been shown to be quite effective in terms of reducing exacerbations. It's been shown to be effective over the long term as well. Tezepelumab, that blocks TSLP in adults with uncontrolled asthma, has been shown to be effective in a broad group of patients with a few different dosings. And in the pivotal study, the phase 2 study, actually, it resulted in a 70% reduction in exacerbations when given on a monthly basis with the 210 milligram dosing. But what was most interesting was that it seemed to be effective in people with high eosinophils and low eosinophils, with people with high nitric oxide and low nitric oxide, in people who were allergic and had a high Th2 status, and people who had a low Th2 status. This led to the pivotal Navigator trial, which demonstrated that tezepelumab could reduce exacerbations by 56% in an overall population. But what was most dramatic was that it reduced exacerbations even in patients who had less than 300 eosinophils and even less than 150 eosinophils. It worked in the overall population, over 300, less than 300. And what was most striking was the effect in people with eosinophil counts of less than 150, a 39% reduction in exacerbations in that patient population. All different stratums of eosinophils was effective, and similarly, high nitric oxide, low nitric oxide, as well as people who were allergic or non-allergic. It was also shown to have benefits over a 2-year period of time with sustained reduction in exacerbations, as well as sustained reduction in hospitalizations and emergency room visits by as much as 79% compared to placebo. So who could benefit from tezepelumab? It seemed that the patients enrolled in the trial who were on inhaled steroid LABA, high EOs, low EOs, high FeNO, low FeNO, allergic, non-allergic, as well as people with airway hyperresponsiveness and non-responders to other biologics, including oral steroid-dependent patients. And we recently published a new study called the Sunrise trial, which demonstrated that tezepelumab was also effective in facilitating corticosteroid withdrawal. When you look across all of these different therapies that I just showed you, you see about a 50% plus reduction in exacerbations and improvements in terms of oral steroid reduction, quality of life, and FEV1 is improved as well. So how do we choose the best biologic? You have to do an extensive workup. You have to phenotype and endotype your patients. You want to check IgE levels, nitric oxide levels, eosinophil levels in the sputum or the blood. And there are other biomarkers that are still in development, including periostin and DPP4, which still have not really risen to the efficacy and importance level as the other biomarkers. But we know that approximately 2/3 of patients have type 2 asthma, and there's some overlap. Over about half of patients have a mixed phenotype with both eosinophilic and allergic asthma. There are some patients who have purely eosinophilic or purely allergic asthma, and those patients might benefit from a more targeted approach. So the first step is assessing the biomarkers. Is there a dominant biomarker? And then you can also ask, are there other type 2 comorbidities that you can treat, such as chronic sinusitis, atopic dermatitis, or EGPA? And does the patient have airway hyperresponsiveness? Tezepelumab in particular has been shown to reduce airway hyperresponsiveness in a few different trials, but there's also good data with dupilumab in terms of reducing airway hyperresponsiveness, whether it's with methacholine or with mannitol. And then you should use shared decision-making and talk to your patients with regard to dosing frequency. Sometimes there are cost issues, particularly in the United States. And then if the patient responded to a biologic, great. If not, you could consider switching. And many patients don't respond to biologics. Most do, but if you choose the right biologic, you should do okay. But of patients who switched biologic therapy, 78% had a favorable response after switching. Usually, again, it was because of ineffectiveness of the first biologic. But if you choose correctly, that number will go down. So we have a lot of different options. And I don't think you'll be criticized if you, for a patient with allergic and eosinophilic asthma, all the biologics works. Anti-Ig, IL-5, IL-4, anti-TSLP. And patients with allergic non-eosinophilic asthma, if they're non-eosinophilic, they're unlikely to respond to anti-IL-5, but the other biologics may work if they're allergic. Or if they're eosinophilic but non-allergic, they're less likely to respond to anti-IgE. One of the challenges, we don't have good head-to-head studies to date, but we're working on that. And there have been a few studies, anti-IL-4 against anti-Ig, for instance. What about non-type 2 asthma? Well, there we don't have a lot of options. Azithromycin has been shown to be effective. It reduces exacerbations by about 40% in adults and children. Bronchial thermoplasty, which was a procedure that involved deployment of a catheter and deliverance of heat to the airways, was an effective strategy, but it's no longer being developed by the company. And then tezepelumab is the only biologic that's currently available for those patients. You want to assess response in all of these patients and look at a variety of different outcomes, including exacerbations, symptoms, lung function, biomarkers. And then there are some people who are partial responders and complete or super responders. You also want to evaluate whether or not a patient gets into remission, whether they have sustained response. And that's one of the key outcomes that we look at. You can also evaluate with imaging. And it's been shown that if you give a biologic therapy, and here this is with benralizumab a few years ago, you can have a reduction in mucus plugging, for instance. You can have an improvement in ventilation. So that's another way to evaluate response. And then whether or not you can taper inhaled steroids or long-acting beta agonists, like in the Shamal study, which demonstrated that patients who came off of inhaled steroids, they had only a small increase in their exacerbation frequency. 8% versus 4% had an exacerbation, suggesting that it's safe for many patients to come off of inhaled steroids, but they might have a reduction in their lung function that may be heralded by exhaled nitric oxide rises. And then lastly, the question of remission is important. And you can evaluate remission by evaluating whether or not a patient has no symptoms or minimal symptoms, no exacerbations, stable lung function, and stabilization of biomarkers. The challenge is, however, that only up to 40% of people in different clinical trials have been able to achieve remission with all the different biologics. So we still have a shortcoming there. So you can then ask, well, is it good or bad? How are we doing with asthma? I think we're doing great. Some people might say the glass is half empty, but I think we're doing great. Some people might say, well, they're only reduced by 50%. Steroid reduction is only achieved by 50%. And many patients fail to achieve normal lung function, and that we need to do more. The good news is there are a lot of therapies in development. And if you look at this slide, you can see many of the different therapies that are in development, including IL-13 TSLP combinations, long-acting TSLP combinations, JAK inhibitors, BTK inhibitors, and many others. Just to give you a flavor, depemokimab is now approved in the United States. It's administered every 6 months. It's a long-acting anti-IL-5 that was approved, and as you can see on the right-hand side of the slide, reduced exacerbations by 50%. We've also studied anti-IL-33 therapy with itepekimab, which reduced exacerbations comparable to dupilumab, although less effective in combination with dupilumab. And then, and here are those data. Astegolimab is another anti-ST2 IL-33 receptor therapy that's been studied, which also reduced exacerbations in high eosinophil and low eosinophil patients. Other novel therapies, as I mentioned, include anti-TSLP IL-13 combinations, IL-4, 5, and 13, IL-4 TSLP, BTK inhibitors, OX40 ligand inhibitors, and other long-acting TSLP therapies like verekitug, which is administered every 3 to 6 months, reducing eosinophils, nitric oxide, and improving and reducing exacerbations. JAK inhibitors have been studied as well as CRTH2 antagonists. So the good news is that we have many choices now, and while choosing a biologic can be challenging, there are a lot of therapies that are in the pipeline. I showed you before the therapies that we have, but look at all the therapies we have in development. It's a good time to have bad asthma. One of our goals is to really offer an individualized approach. So I want to thank you for your attention. I look forward to the rest of the discussion throughout the evening. I managed to get through my slides, I think, in time, and I'd be happy to answer any questions that anybody has. Thank you so much. I can't hear anything if anybody is speaking.
Thank you, Professor Vishnu, for an excellent overview of the targetable drugs and how to choose the right biologicals, and also giving us a little bit of an overview of what the future has as far as biologicals are concerned. We'll have the question and answer session after the two sessions. We'll move on to session 2, which is basically by Professor Ronald Bull. The PACS moderator for this is Professor Dipender Rai. So I'd ask him also to come onto the stage. We'll have the question and answers after Professor Bull's talk. So can we have Professor Bull's biodata on the slide?
Can we have a CV slide of Professor Roland Bull?
So I think Professor Bull needs actually no introduction. He's been frequently here on PACS, but he is a senior professor of medicine and former head of pulmonary department at Mainz University Hospital, Germany, internationally recognized expert in asthma, COPD, allergy, and respiratory medicine. He's a member of GINA Scientific Committee and contributed to global asthma management guidelines. Senior author and contributor to German asthma, COPD, and immunotherapy guidelines, and is a visiting professor at leading international institutes, including Harvard Medical School. So it's indeed a pleasure to have Professor Bull back onto PACS. And without wasting much time, I'll ask him to give his talk on responders and non-responders to biologicals, which also becomes very, very important when we really look at how we are treating our patients.
One important thing about him is he's the driver. He's the driver for severe asthma in India, and how we have been using biologicals in the last almost about 14 years. He has been constantly guiding Indian physicians how to use it in more appropriate and perhaps where we balance the cost with its effectiveness. Thank you, Professor Roland Bull, and over to you.
Thank you very much for this very kind introduction, and good morning, dear colleagues. Welcome from Europe. It's my pleasure to be with you this morning, and thank you for having me. And I truly apologize for not being in India in person, but family vacation, so I'm truly sorry. The topic of my talk was just perfectly introduced by Mike Wexler. You now know what is at the moment available for patients with very severe asthma, what are the options regarding biologics, and let's now look into a little bit more detail what are potential responders and non-responders to biologics. Before we start, let me show you my potential for conflict of interest. As Deepak just mentioned, our center is involved in clinical trials of biologics for now many years. This is why we do interact with all the big names in the field you see here. You have already heard as I said, a very wonderful introduction. You already heard that asthma is a heterogeneous disease. And this is why, of course, not every biologic is the perfect choice for every patient. And this is why we have to have a more careful look too. As you also already heard, you have to have a little bit more careful look to decide which of the potential biologics are where will work best for which patient. And as you see on this slide already, it's important to also look at the clinical characteristics, at the phenotypes of our patients. And as you see here, these are the two dominant phenotypes in severe asthma. Allergic asthma on the left-hand side. This is mostly triggered by the learning, the adaptive immune system, in contrast to eosinophilic asthma, which is mainly a disease of the innate immune system, and you will hear a little bit more detail about it in a moment. You have also seen from Mike that we now have different biologics. We have anti-IgE, we have anti-IL-5 or receptor. The newest addition is a 6-month dosing interval drug, depemokimab. We have anti-IL-4 receptor, dupilumab, and we have anti-TSLP, the most upstream biologics. You have seen all the details. And looking at this full spectrum, it is very clear one size does not fit all. This is why it is important to think about which drug do I choose for which patient to optimize my chance that the patient will nicely respond and not being a non-responder. And in my opinion, you have to mainly consider 3 different aspects. Number one, what is the phenotype of my patient? As I said, for instance, is it allergic or rather non-allergic? Which biomarkers are elevated, and are there potential comorbidities which may have an impact on the response of my patient as well? This is why let's now go through these 3 different options. And as I already introduced, we have to differentiate, first of all, between allergic and eosinophilic asthma. Allergic asthma is triggered by allergies. You will hear in a second that these patients typically have allergen exposure-related symptoms. This phenotype is driven by both immunoglobulin E and cytokines. In contrast to non-allergic asthma, the so-called eosinophilic asthma, it's triggered by non-allergic triggers, mostly guided by innate lymphoid cells, by the innate immune system, also dominated by cytokines and eosinophils. And it's in most patients, it can be differentiated, but as you already heard from Mike, there are patients with an overlapping phenotype. If you develop allergic asthma during childhood or early adulthood, this does not prevent you from developing eosinophilic asthma later in life. Please also have a look at biomarkers, and as you heard, 3 biomarkers are important. Number 1, what are my eosinophils? Number 2 is nitric oxide in exhaled breath. FeNO, is it elevated? And or is the disease allergen driven? In this case, also have a look at allergy tests and specific IgE. You have already heard these biomarkers can be influenced both by treatment with systemic and higher doses of inhaled corticosteroids. This is why, in case your patient is on systemic steroids, it may be necessary to repeat these tests to get a better feeling. Is my patient truly, for instance, eosinophilic? Yes or no? And to help you with this, let me just show you something we usually do in Germany. This is a completely safe approach to identify patients with blood eosinophilia. This is what we also do in our center. If you have a patient very low eosinophils, but patient is on higher doses of all corticosteroids, what we do is we take a blood sample, let's say Monday morning, then we tell the patient tomorrow you won't take your cortisone tablet and come back on Wednesday. So just a 24-hour pause of the all corticosteroids. And as you see here, in these patients, you will always see an increase in blood eosinophils, even after a 24-hour pause of the all corticosteroids. In the past 20 or 30 years, we have never seen any severe side effects by just not taking a tablet for a single day. And this is not only an increase in the average blood eosinophils, as you see here, in all patients included in this trial, the eosinophil numbers will go up. So that's a very easy way to at least get a good feeling if your patient is eosinophilic. You can demask a relevant eosinophilia even in patients treated with all corticosteroids without, in my opinion, without a risk of major side effects. Then, as I said, it's important to differentiate between allergic or eosinophilic asthma to again choose the right biologic for the right patients. In this case, when did your symptoms start? The earlier the start, the higher the likelihood that you have an allergic asthma. The later symptoms start, the higher likelihood you have a rather eosinophilic asthma. Are there any trigger, like whenever I see the cat of my neighbor, I have a problem? This is, of course, is a strong indication that you have a more allergic asthma. Also, if you have nasal problems, nasal polyposis, chronic rhinosinusitis with nasal polyp, this is a rather strong indicator that you have rather eosinophilic asthma. Constantly higher blood eosinophils speak for eosinophilic asthma. Allergen sensitization, as I said, and based on these few questions that can be answered in a minute or two, you can then consider, is it rather a patient with allergic asthma? Then you can consider anti-IgE, anti-IL-4/13, dupilumab or tezepelumab, while if it's very dominant eosinophilic asthma, you should, of course, first consider drugs targeting interleukin-5 or the interleukin-5 receptor. Also, dupilumab or tezepelumab, of course, work very well, as you have seen in eosinophilic asthma. And based on these very few questions, based on the answers to these very few questions, based on the biomarkers you have evaluated, then here's the GINA recommendation. Then you have predictors of good or poor asthma response. Let's start with anti-IgE. The patient with a clear-cut allergic asthma, you can consider anti-IgE. You have also looked at the level of serum IgE. This influences the dose of omalizumab, and exacerbations in the last years, also childhood onset asthma and clearly allergen-driven symptoms. All these parameters, they predict a good response to a drug such as omalizumab. In contrast, as I said, anti-IL-5 or anti-IL-5 receptor, again, previous exacerbations, meaning severe asthma, high blood eosinophils. The higher the blood eosinophils, the more likelihood is a good response to anti-IL-5 or anti-IL-5 receptor. Also, as already mentioned, adult onset of asthma and nasal polyposis are good indicators and predictors of a good response to anti-IL-5 or anti-IL-5 receptor. Now, what about anti-IL-4 receptor, dupilumab? Again, higher blood eosinophils, and here also higher nitric oxide in exhaled breath, FeNO. The higher FeNO, the higher blood eosinophils, and also, is there nasal polyposis? Answers yes to these three questions also point to a good response to anti-IL-4. And then finally, anti-TSLP, as you heard, it works high upstream. This is why it works in both patients with high blood eosinophils, in patients with high FeNO, and also in patients with nasal polyposis. So just have a quick look at this slide. As you see, very few questions will help you to predict a good response to a biologic. And just as an example, and I can be brief here, you have seen this slide, depending on your answers to these questions, depending on biomarkers, eosinophils, FeNO, allergic status at baseline, you can see this patient has a higher or a lower likelihood to respond to a given drug. In this case, as an example, tezepelumab. And based on this, Guy Brissell 3 or 4 years ago and Elliot Israel just last year, they have developed an algorithm to help you choose the best biologic for the patient sitting in front of you. Let's start with severe asthma, not on daily oral corticosteroids. If eosinophils are very low, and also FeNO is very low, and if you have absolutely no signs of allergic asthma, the first step is you have to rethink. You have to rethink the diagnosis. If, however, you are absolutely sure this is still asthma, then potentially anti-IgE or anti-TSLP will work. If there is an increased FeNO level, slightly increased FeNO level, you could also consider dupilumab. But again, in patients with very, very low biomarkers, reconsider the diagnosis. Many patients will likely not very nicely respond to a biologic. In patients with more clear type 2 asthma, so eosinophils are elevated and also FeNO is elevated, then it's a good idea to also consider comorbidities. As you see here, if it's allergic, if there is a dermatology comorbidity, chronic spontaneous urticaria, atopic dermatitis may have an impact on which biologic you choose. Nasal polyposis, as I said, then you consider rather anti-IL-5 or tezepelumab drugs. And this is a most recent development. You see the data in a moment. You will hear about it later. If you have very high eosinophils, hypereosinophilic syndrome, or EGPA, we now have two approved drugs, benralizumab and mepolizumab. This is the most recent study, the Natron study, published just a few months ago, showing that in patients with hypereosinophilic syndrome, anti-IL-5 drugs, mepolizumab is already approved, and now also benralizumab is approved. Anti-IL-5 or anti-IL-5 receptor drugs have a very nice impact. What I find interesting, the dose approved with mepolizumab is 3 times the usual dose. For benra, we only need twice the dose we use in severe asthma. So even in patients with very high eosinophils and EGPA or hypereosinophilic syndrome, we now have a nice option. And now, and we already addressed this, what about patients with oral corticosteroid dependent asthma? Then consider, is it truly eosinophilic? Yes, in this case, you can go for anti-IL-5, anti-IL-5 receptor, TSLP, or tezepelumab or dupilumab. If no, at the moment, the only drug approved in such a case is dupilumab. So all these algorithms, they, in my opinion, nicely help you to choose the right drug for the right patient. And I can only underscore what Mike Wexler already told you. If there is no good response, and Gina recommends to check for response after 4 to 6 months. If there is no good response, then not only stop the present biologic, but please consider switching to another type 2 targeted biologic if there is a clear indication. In my opinion, every patient, if available, deserves a second chance. So if there is another drug which some predictors of good response or some comorbidities which point in the right direction, consider switching to a different drug. What, however, do we do if there is absolutely no response? And as I said, in such a case, please rethink the diagnosis of asthma. Let me just show you 2 or 3 examples. This is a patient, a 64-year-old non-smoker, 25-year history of dyspnea, multiple exacerbations, clear family history, however, completely type 2 low asthma. No blood eosinophils, no high FeNO levels, no history of allergies, and no response to biologics. What could you do? You could have a closer look. In this case, if you do a chest CT, you see there are clear signs of a severe emphysema. And if you measure serum alpha-1 antitrypsin, you do see this patient has a severe alpha-1 antitrypsin deficiency and was misdiagnosed as severe asthma. Likewise, just published in the New England Journal a couple of weeks ago, a 50-year-old lady with asthma, severe obesity, and she was treated for severe asthma with all the options available, yet no response. If you do a chest CT and you ask her to please exhale, what you see here, very clear bowing of the posterior wall of the trachea and main stem bronchi on expiration, more than 70% collapse as compared with inspiration. It's very clear the problem here is completely different. We have a severe obesity and not a severe asthma. And finally, this is one of our patients, 50 years old male, type 2 low asthma, colleagues in private practice, they tried all the biologics, no response. We did a chest CT. This patient has a clear bronchiectasis. And what I showed you, these three examples, is fully in line with data presented at the ATS meeting in Orlando just a couple of weeks ago. This is the topic, the hit list of potential diagnosis to consider in patients with refractory type 2 asthma, despite treatment with biologics. Always rethink, could it be COPD? Is there severe obesity, diabetes? You heard already from Mike, vocal cord dysfunctional, laryngeal hypersensitivity are also potential differential diagnosis to consider. Obstructive sleep apnea also points towards severe obesity, gastroesophageal reflux disease or bronchiectasis are other diseases to consider. All these diagnoses, they are predictors of a poor response to biologic and should make us rethink the diagnosis. And then finally, this is at first sight a little bit more complicated, but may also help us in choosing responders and differentiating them from non-responders. This is a very nice study looking at poor responders to benralizumab. The percentage in total was very low. If you do see suddenly after, let's say, a year, 2, 3, 4 years, nice response to benralizumab, if you suddenly see a rise in blood eosinophils, so previously eosinophil numbers were low, now they're going up, this may indicate that this patient developed anti-drug antibodies. This is a rare event, but it cannot be completely excluded. Also, if you do see a nice response to the drug, low blood ears, low FeNO, so the patient in principle is responding to the drug, yet still exacerbations, this can indicate chronic bacterial airway infection, for instance, bronchiectasis. And then, this is rare, but it also happens, you have a patient with a seeming type 2 high eosinophils, a seeming type 2 high asthma phenotype, you treat with anti-IL-5, anti-eosinophil drug, benralizumab, yet no very good response. EOS go down, but FeNO is still high. So this is a rare case of a patient with rather IL-13 and not IL-5 dominated asthma phenotype. In this case, benralizumab, as you see, very rare, but in this case, benralizumab may not be your preferred choice. So how do you look at responders and potential non-responders? As I said, the choice of the right biologics should be based on clinical, functional, and laboratory parameters and biomarkers, and also in more complicated cases based on imaging. Please evaluate treatment response after 4 to 6 months. As you already heard, a responder can be defined by all parameters that are relevant for the individual patients. Not every biologic works in every patient. One size does not fit all. If in doubt, stop and switch to another drug. In patients who nicely respond, treatment effects are long-term stable. You can achieve remission at least in 20 to 30% of patients, and it's important, as already also shown by Mike Wexler, you can reduce the overall level of treatment, but it is a good idea to maintain at least a low to medium dose of an inhaled corticosteroid. So to summarize, I think, and I like this very much, it was presented by Guy Brissell already 4 years ago. I like the ABCD approach to choose the right biologic for the right patient. Always consider age at asthma onset. Is there a clear-cut allergy? B, biomarkers, blood eosinophils, FeNO if available, serum total and allergen-specific IgE. Consider comorbidities and other coexisting conditions, and of course also consider cost. And finally, dosing frequency and the way to administer the drug, IV or in all, this is true only for Reslizumab, or sub-Q for all other drugs. These are, in my opinion, the key parameters that can nicely help you in choosing the right biologic for the right patients. Thank you for your attention. I look forward to your questions.
Thank you, Professor Bull, for an excellent overview on how to really look at responders and non-responders and focusing on the ABCD as far as deciding on which biological to give and which not to give. We have now time for both the question and answer session from the experts, but also I think we could combine this with the panel discussion on challenges and opportunities in severe asthma, where we could also take the question and answers as far as this is concerned. So I'll call the moderator for the panel discussion, for the question and answers and also for the panel discussion, Dr. BP Singh on the stage. And I'll also ask Dr. K. Satish to come onto the stage. And the panelists, Dr. Angira Das Gupta, Dr. Pratibha Singhal, and Dr. Arjun Khanna also to come onto the stage.
And if we have Dr. Deepti Gothi, Dr. P. Arjun, and Dr. K. Sahana, they can also join in the panelist here.
Dr. Vikas Marwa and Dr. Sahana. So we have an expert panelist, and we have our ACCP International Faculty, Professor Ronald Bull and Professor Vishnu also here as far as the panel discussion is concerned. First of all, I'd really like to ask if there's any questions that the panelist or the audience has from the international expert. Yes, you can use the mic if you can, someone can give the mic, and then we can start asking the panelists what question they have. Can we have the mic, please?
I think we can have the question from the audience to the international faculty as well as the Indian faculty, because the Indian problems are very, very unique.
So discussing both what is the international status and what we can do as far as our own country is concerned.
Thank you for those wonderful talks. I'm Dr. Sushmita from Kolkata. I just wanted to ask, and we get these patients quite often, what biologic would you choose if the patient had overlapping allergic, eosinophilic, and steroid-dependent phenotypes?
Professor Wessner, did you get the question?
Yeah. So the question was about overlapping allergic, eosinophilic, and steroid dependence?
Correct.
Yeah. So we have a few different options. So the standard thinking is for someone with allergic and eosinophilic, you would give a combination therapy, either something that targets TSLP or the IL-4/13. Those would be the two options. If the patient has allergic and eosinophilic, I think oftentimes that just using anti-IgE therapy won't be sufficient, and there's not really good data with steroid reduction with anti-IgE therapy alone. In terms of allergic and eosinophilic, for the eosinophilic component, anti-IL-5s are generally pretty effective. You may miss out on a component of the allergic disease because it's only targeting IL-5, but there are many patients who will respond nonetheless. The other potential option is anti-TSLP therapy. First of all, with anti-IL-5s, as I showed you, with both mepolizumab and benralizumab, there's been steroid reduction facilitated. With anti-TSLP therapy, you're targeting IL-4 mediated allergic asthma with IgE production, anti-IL-5 mediated eosinophilia, and IL-13 mediated mucus production and airway hyperresponsiveness and exhaled nitric oxide production. So that seemingly has the broadest effect. In the initial source trial, which I led, people who were given tezepelumab and who were steroid dependent, there was a 54% reduction in exacerbations. 54% of the patients were able to come off of their their systemic steroids. But the issue was that there was a significant placebo response, and 46% of patients in the placebo group were also able to taper their corticosteroids off. So we recently completed and published this year the Sunrise trial, which demonstrated that tezepelumab, similar to dupilumab, similar to mepolizumab and benralizumab, also significantly facilitates steroid withdrawal. And in that study, there was significant reduction. A large proportion of patients were able to come off steroids. So my two top choices would be either dupilumab or tezepelumab for the patient who has allergic and eosinophilic and who is steroid dependent.
I think Professor Michael Wax, I think I'll bring this point that we are all sitting here and we have experts like Naved, Dipender, and Dr. B.P. Singh and Dr. K. Satish, everybody is there. We have only two group of the biologics available, anti-IgE, which is omalizumab, or anti-IL-5, which is like mepolizumab, and then benralizumab. So we have only two options. So in such situations, because we did publish that 1/3 of patients are overlapped, how to choose between only when you have these two options? I think that would be the question.
Only when you have those two options? So I'll give my quick answer. I would probably give an anti-IL-5 because both mepolizumab and benralizumab have demonstrated efficacy in both the Elizabeth Bell study as well as the Param-Nair Zonda trial. Anti-IG has not been shown to effectively reduce systemic oral corticosteroids.
So before I ask our Indian panelist, Professor Bull, you wanted to say something.
Yes, I just wanted to say I agree with what Mike Wexler just said. If available, tezepelumab and dupilumab would be the perfect choice. I know you don't have these drugs. This is why my first choice would also be benralizumab or mepolizumab. And don't forget, there are additional strategies to sort of reduce exposure to allergens, and this should, of course, not be forgotten. This may help to increase the response to biologic treatment at all.
So I think we can ask the Indian panelists also what their experience would be and what they would do in such a situation. But before that, let me ask you a provocative question. Is there any role of combination therapy? Do you think there is data which may emerge that combination therapy targeting these two different, let's say, pathways would be useful in the future?
Yes. Are you asking me? If you're asking me, I can tell you that we've given combination biologic therapies to patients with refractory asthma. It's currently in review at one of the journals. And we've demonstrated good efficacy using combination therapy, but it's very expensive.
Yes, I think cost is the major issue. But if the cost comes down in the future, this would be one option that maybe in the type of patient that Sushmita was talking of could also be an option unless other drugs are available. Now for the Indian panelists, any comments they would have in terms of their own experience? A little bit louder.
Mic, just check the mic, please.
Dr. Vaishnav, did you get the question?
I did not hear it at all.
No, I couldn't hear it either.
I think you're wanting to know whether benralizumab, which really makes the eosinophil zero as compared to moplizumab, which of the two would be better?
The question was, is there a differential effect between benralizumab and meplizumab? There is a differential effect in terms of reduction in eosinophils, and there's a greater reduction in eosinophils with benralizumab. That's been shown consistently in a number of studies. In asthma, there's not been a head-to-head study. If you do cross-study comparisons, there's very little difference in terms of the overall efficacy in exacerbations in patients with asthma, not significant difference in terms of lung function. If a patient does have sinusitis comorbidity and you want to treat that, there is greater efficacy of meplizumab versus benralizumab in terms of management of chronic sinusitis with nasal polyps. However, the only head-to-head trial of biologics, the first head-to-head trial was in EGPA, in eosinophilic granulomatosis with polyangiitis. That was a study that I led and published in the New England Journal of Medicine, I think 2 years ago now, in which we compared benralizumab to meplizumab. In terms of getting patients into remission, there was no significant difference, about 2/3 of patients in both groups. However, there was a greater proportion of patients treated with benralizumab who were able to come off of oral corticosteroids. 41% versus 26% of patients treated with benralizumab versus meplizumab. So for that reason, I don't think there's a major difference, but there is a slight difference, both in terms of overall reduction in eosinophils and from that EGPA study, that for which I would probably recommend benralizumab or meplizumab, although I wouldn't fault anybody for using meplizumab.
You should, however, we were also discussing cost. You should, however, keep in mind that the cost of mepolizumab in such a case is higher because you need 3 times, at least in Europe, it's approved only 3 times the dose. Compared with benralizumab, it's approved for twice the dose. So there's a slight cost benefit also in favor of benralizumab.
Correct.
Right.
If we have Dr. Deepti Gothi here, can she come to the stage? Is she there?
May I ask?
Can I?
So I have 2 questions. The first is that you have mentioned in the slide that only 1/3 of the patients achieve remission after using the biologic. Whether if we reduce this biologic at earlier stage rather than waiting at this big 5 treatment, whether we can achieve the better remission and better change post the disease. And second, that TB is endemic in our country and there are lots of patients who have post-TB obstructive pulmonary as well as bronchial cases. And even in that, the TB biomarker is high. So whether we can use the biologic in that situation. And third on that, Dr. Nag mentioned that even in the pause of 24-hour oral corticosteroid, it leads to elevation of eosinophil. So those patients of severe asthma on maintenance oral corticosteroid, whether the eosinophil maybe falls to the lower side and that patient may not be eligible for the biologic, that could be due to the oral corticosteroid leading to reduction in eosinophil at less than 150.
Yeah. How many more questions do you have? Just those three?
You asked three questions, so if you ask
I'll-
one by
I'll-
one.
I'll give you the question one by one.
Yeah, Randeep, you
So
give
we'll
the
go with
question.
the first question.
Okay,
The
I
first.
remember the questions.
So let me just give you the questions one by one. The first question I think is that you mentioned that there is, so let's put it in a different manner. You mentioned there is mucus plugging, and airway remodeling we know happens in asthma. We wait till all of that happens before we start biologicals.
Yes.
If we look at the whole concept of rheumatoid arthritis and you start giving disease modifying agents early, do you think we should start looking at those patients who have the biomarkers positive and who have asthma which is progressing and you are feeling their features of mucus plugging, there is airway remodeling happening? Why not alter the course of asthma by starting biologicals early rather than waiting for them to develop severe asthma and then have more and more irreversible disease? I think that's
Yes,
Double
okay,
thumbs up.
That's the first question.
The question is basically, should we be trying to prevent the fire from happening rather than putting out the fire once it's happened?
Correct.
There's epidemiologic retrospective data from the International Severe Asthma Registry, which suggests that patients who utilized a biologic earlier on in their course of severe asthma had a greater benefit in terms of potentially achieving remission. What has not been shown yet is whether or not giving it to milder patients, patients who do not have frequent exacerbations, patients who are in step 3 or 4 rather than step 4 and 5, whether they might benefit in a prospective study. But there is a trial going on right now that is evaluating that. I believe that it makes sense to do that from a clinical perspective. The question becomes whether it makes sense from an economic perspective and whether patients who have milder disease are willing to take biologics as part of their treatment regimen. So in patients who have severe asthma, yes, you should start it sooner rather than later. Whether you should start in patients with mild to moderate disease, if there was no cost and if the biologics were administered once a year maybe, then that might have some benefit. We have to show that. That study is going on. I'll let Roland give his thoughts.
No, I fully agree. If you have a clear-cut patient with severe asthma, the earlier you start, the better the long-term outcome. This is very clear. If you have a patient with, let's say, moderate to severe disease with very high biomarkers, Ian Paywood would call it a hot patient. So yes, previous exacerbations, very high FeNO, very high eosinophils. If available and if affordable, you could consider a biologic, but we need more data to clearly say this will help.
So I think we're moving in that direction, but we need more data before we start doing that and be able to show that we are able to modify the course of the disease early rather than late. I think the second question was basically to Professor Bull regarding discontinuation of steroids for 24 hours and showing a rise in eosinophil. So should we wait for that, or could we start biologicals even if you had an eosinophil of less than 150?
There's no doubt. If you have an eosinophils less than 115, if it's a very clear-cut severe asthma, no problem to start a biologic. I showed you the data just because some insurance companies in Europe, they insist on clearly documenting an eosinophil-driven disease before you could prescribe an anti-eosinophil drug. And in such a case, it is very easy. If you stop the oral corticosteroid just for 1 day, you will see an increase in eosinophil numbers, and this clearly shows this disease is eosinophil-driven.
Okay. The third question was a little bit not related to asthma per se. It's basically more from our Indian context that we have a lot of patients who have tuberculosis and have a post-TB obstructive airway disease. And in some of them, they have high inflammatory markers. They could have eosinophilia, they could have FeNO levels being high, And I think the question was that is there a role or do you think one should look at biologicals in such a subset of patients? I don't think we have any data on this, but your thoughts on that?
I don't, there's very little risk of biologics in terms of reactivation of TB, as far as I know. In terms of the treatment of bronchiectasis in the context of either TB or even just asthma, there's been one study, I believe, with benralizumab, which demonstrated no significant benefit in terms of the bronchiectasis component. There was a recent trial, I don't know, Roland, if you know the details of that trial. I just know the sort of the top line results that benralizumab did not reduce exacerbations in patients with bronchiectasis associated with non-cystic fibrosis bronchiectasis, even in patients with eosinophilia.
Yeah, I fully agree. You have to separate two different cases. If it's a clear-cut severe asthma, irrespective of previous TB, no problem with biologics. We are not talking rheumatology. In rheumatology, you have a problem with reactivation of tuberculosis if you use anti-rheumatologic biologics. This is not the case in asthma. There is no specific danger. If, however, the patient has a problem because of previous TB and there may be severe structural changes in the lung, this will not indicate that biologics will help. So you have to separate between these two cases.
Yes, I think so.
Comments from the panelists?
Any comments from the panelists or
Yeah,
questions? Dr. Arjun Khanna.
Can I ask them a question, please? So in patients with COPD who have a Th2 phenotype, mepolizumab, which is a weaker blocker of the eosinophils, works and there is data. Why doesn't benralizumab work in patients with COPD when they have Th2 inflammation? It is a more potent anti-eosinophilic biologic, but why is the data all negative in COPD with Th2 inflammation?
Yeah, the data in COPD, by the way, there have been 4 mepolizumab trials and there have been 4 benralizumab trials. The first 2 mepolizumab trials did not show significant efficacy. All 4 benralizumab trials didn't show significant efficacy. And I would argue that even the 2 mepolizumab trials that did show efficacy, there was only a 20% reduction in exacerbations. In patients with COPD, eosinophils play some role, but they don't play a major role in the majority of patients. While in asthma, over 2/3 of patients have eosinophilia. In COPD, it's less than 1/3 of patients that have significant eosinophilia. So it isn't the eosinophilic component. It's possible that while they tried to exclude patients with eosinophilic asthma in those trials, it's probable that there were some patients who had some degree of eosinophilic asthma, even if they didn't report it. And so some of the trials have been positive, they've been weakly positive. And so I wouldn't, I personally don't use a significant mepolizumab in my COPD patients, even if they've got some degree of eosinophilia. I've been using dupilumab, which has an over 30% reduction in exacerbations in people who have eosinophilia, who are on triple combination therapy, and who have 2 exacerbations or more.
Yeah, again, I agree. Biologics in COPD work only in a small subpopulation of patients with a clear-cut eosinophilic, late onset eosinophilic component, and the different outcomes of all these COPD trials, they are mainly influenced by the selection of patients. The more patients with a clear-cut eosinophilic phenotype, the higher the response. If you have an innocent trial and you include the full spectrum of COPD patients, also emphysema and so on, you will see a much less response. So please have a very careful look at potential candidates with COPD.
Okay,
Dr. Satish, I think
we have a session on biologicals in COPD, so we can discuss that in more detail.
Dr. Satish, your comment.
It's working.
Okay, good morning everyone, and supposed to do a moderation. So I'll ask some of the panelists some
Yes,
questions
please, go ahead.
that we face in India. We have heard about the best centers in the world, Professor Bull's and Professor, myself, Westler's center. And I had the opportunity to visit and spend some time with Professor Bull in Mainz University, severe asthma. So the challenges that we have in India are too many. Like, for example, today's my patient is tomorrow, Randeep's patient or Deepak's patient. So we don't have a follow-up of these patients who come regularly to one particular setup. So it's very difficult for us to know what is their, status regarding asthma. And India has highest number of asthma in the world. Close to 33 million people have asthma in India. And equally disturbing is that, the mortality is also very high. So when we start looking at these patients with asthma in a structured way, follow up regularly with the treatment, adherence issues, the cost issues, it becomes really, challenging for all of us. So what kind of challenges we all face in our regular practice? Anyone want to say something from the panelists, Indian panelists? What challenges that we have
Dr. Arjun?
regarding the follow-up, regarding the patient, and how do we diagnose patients with severe asthma? We all know the definition of severe asthma, different from difficult to treat asthma. But I think, we have, challenges about the definition itself in our Indian setup.
So India's specific problems, India's specific
By the way, it
issues.
sounds like business is good.
So,
We are bringing India's specific issues, Michael.
Yeah, no, I said it sounds like business is good in India. You got a lot of asthma there.
Go ahead.
so the basic challenges that we face, number one is compliance with treatment. Number two, acceptance of inhalers, the inhaler technique, and exposure to all sorts of triggers, pollution and other things like that. So if you critically look into all this, we find that's very small subgroup of patients who really have what we call as severe asthma. Most of them fall into the difficult to treat group. And if we go by that algorithm, make sure that we get the diagnosis right, the patient is on the inhaler, it's adherent to it, the technique is correct, you look at the comorbidities, and address all the triggers and other things. Just a handful of patients really come to be really called as severe asthma. So we deal with a population of more of difficult to treat asthma rather than severe asthma.
So I think one of the challenges that we have in our country is that we need to be very careful about differentiating difficult to treat asthma from severe asthma, because compliance, inhaler technique, comorbidities are sometimes missed. And there is this knee-jerk reaction of going to biologicals without going through the proper protocol or algorithm in terms of seeing that this patient actually has severe asthma and not difficult to treat asthma.
So we have one question coming up from Dr. Rajbir Singh from the audience. I think mic has been provided for the question. In between, we will take it rather than, at the end. So we can
In the
go
meanwhile, just I have a one query, just for the Indian panelist. What is the minimum time after which you get the response? Like earliest response after just one injection or 2 or 3 months? And what is the longest duration after which you get the response from biologic? Like 2 doses of Mepali, you get the response, or 3 doses, 4 doses, 5 doses? So earliest and the latest response with the biologic.
So I think the question here is, when you start a biological, how do you say that this patient is a responder? How long should you wait to say he's a responder? The earliest time and the longest time, that's what you want to know. So if you start a biological, would you wait for 12 weeks, 6 months to say this patient is a responder or a non-responder?
All the patient have expectation that after a single dose, he or she has a dramatic response.
Gina has been mentioning it 4 to 6 months for the say the patient is responding or not.
Gina mentioned that you have to wait for up to the 12 months.
No, initial
So
response.
I think that question is coming here again, Professor Bull, that at 6 months, if you are not sure, you would like to wait for 12 months. That's what the the question is coming that, would you like or would you switch at that point of time?
There is no clear yes or no answer to this question. It depends on the individual patient. The large majority of patients will respond early. You hear about not more than 2 to 3 injections, they will tell you I'm much better. And what I do before I start a biologic, I always ask the patients, what are the 3 to 5 most challenging symptoms that make you feel bad? And after 4 to 6 months, I go back with this list and that you told me whenever you meet the cat of your neighbor, you told me when your wife puts on Chanel number 5, you immediately start having shortness of breath. Did all these symptoms improve? And if you get yes to most of your questions, you have a responder. Lung function is not always good enough, and you cannot look at exacerbations after 4 months. So you have to have a look at the individual patients. But if my patient tells me no response to A, no response to B, no response to C, I would stop after 6 months and consider switching to another biologic. There may be, however, a complicated patients where it's a good idea to continue for max 1 year. But if there is no response after 9 to 12 months, I always stop or switch.
I think that's fair enough, that find out the pain points in the patient and try to map them at 6 months. And if you get that good response, good. Otherwise, if you are in doubtful, you can actually, and especially in India, where you don't have choices to switch, you would definitely like to go a little longer. I think very precisely answered. We have questions from the audience for Dr. Rajbir Singh.
Well, it's obvious from the discussions we've had so far that choosing the right patient is of paramount importance in using the biologics. And the biologics that we have so far have been found to be most effective in type 2 asthma. But it is precisely this group in which we can expect inhaled steroids also to be effective. But on the other hand, we have chosen a subgroup where inhaled steroids are not effective and use this group to study the biologics, which is somewhat illogical. So in theory at least, if we are to use biologics in people who are actually responding to inhaled steroids, you can expect a very good response in this group of maybe mild or moderate asthmatics or even severe asthmatic who are currently responding very well to inhaled steroids. So if it is true that biologics would potentially replace inhaled steroids, then it would come down to a comparison of side effects and costs. And I think at the moment, the most important hurdle to our using biologics is possibly cost. And I think once the patent runs out, I suspect the cost would come crashing down. And I can already see Indian and Chinese pharmaceutical companies licking their lips and waiting in anticipation. What is your response to the cost being the main hurdle to the use of biologics?
I think if costs were the same as inhaled corticosteroids, there would be much greater use of biologic therapies, and they would probably be more effective. I'm not sure that all patients want to take an injection with great frequency. However, the other potential benefit are ultra long acting therapies that are administered every 6 months or more. And if we can offer patients a less expensive option that targets specific pathways and they don't need to be as adherent to their inhaled therapies, I think that would have a great benefit. That being said, we also know that vaccines, flu vaccine, RSV, COVID vaccines, are also effective at reducing exacerbations. And yet, a very small proportion of the population actually gets vaccinated. Those vaccines are not that expensive, and yet they're not being utilized as broadly as one would expect. So cost is a barrier, but it's not the only barrier. I'm curious what Roland has to say.
But cost is a major barrier in this country. I think so. I think, Professor Bull, you know that how big is an issue related to the cost.
In Europe, we now have the first biosimilar for omalizumab. The cost is about 1/3 less, but it's still very high. So cost will remain a barrier for the time being. But also I agree with Mike. I think in the future, more patients will be treated with biologics, more so with further decrease in cost. But always keep in mind, both inhaled and systemic corticosteroids have a very broad anti-inflammatory mechanism, while all these biologics are very specific. So there still is a subpopulation of patients where just one biologic will not be able to replace the full spectrum of action of systemic or inhaled corticosteroids. So for the future will be bright, yes, I agree, but we will need more clinical trials to potentially identify patients who will benefit only from a biologic compared with patients who need a biologic on top of an inhaled corticosteroid.
Dr. Harjit.
So just to carry forward that discussion on replacing inhaled steroids with early biologics, the question is, we have two studies. One is the Shamal trial, which showed that when you tend to withdraw inhaled steroids, the FEV1 does drop. And we have Sigma trials in the pediatric population, which showed that SOS use of inhaled steroids also leads to drop in FEV1, although it does control exacerbation. So we have data that if you don't use persistent low-dose ICS, the FEV1 drops in the long run. So besides the economics of it, I don't think we are at a stage we are supposed to replace ICS with biologics. These two drugs are complementary at best right now. So do you agree with that statement that early use of biologics might be counterproductive regardless of the economics of this therapy? That was my first question, and if I can take one more after that.
Okay, one question you have taken, so let's hear the answer, because I can see Jyoti also standing to ask a question just behind you.
Don't forget that the Shamal study, first of all, only a small subset of patients that was heralded by high nitric oxide had the decline in lung function. And those patients might benefit from an alternative biologic therapy that targets the IL-13 pathway that regulates nitric oxide production. Had they begin a different biologic, maybe they wouldn't necessarily have needed the inhaled corticosteroids to prevent the lung function decline. That being said, I do think that many patients still benefit, as Roland said a moment ago, from the broad anti-inflammatory effects of inhaled corticosteroids. I think it gets back to choosing the right biologic for the right patient. And so I think if you look at the biomarkers, IL-5 therapy, like benralizumab that was used in the Shamal study, those patients were in remission technically, but the benralizumab did not block the IL-13 pathway that may have resulted in increased mucus production, higher nitric oxide production. So it gets back to choosing the right therapy for the right patient. Maybe not for everybody, but that being said, there were a large proportion of patients who did fine on benralizumab alone once they achieved remission.
So I think we can go to the next question to Dr. Jyoti, because we have a line out there. We have already 3-4 waiting. Harjit, if the time permits, we'll definitely have your question. Yeah.
And
So
we
very
have
good.
some of the panelists also.
Yes.
So very good morning, sir. So I have a very practical question from my OPD. There is a young female of 27-year-old, and she has very severe asthma, eosinophilic asthma. So we have started benralizumab. After 6 doses of benralizumab, she became pregnant. So what should we do in that case? Should it continue?
I think very good question. In pregnancy, can you continue anti-IL-5s? Because we have only data for omalizumab. What about anti-IL-5? I think that's the question. Dr. Bull, can you take this question?
Yes. In Europe, in such a situation, we would stop benralizumab and switch this patient to systemic steroids for 6 to 9 months. And the minute the baby is born, we would go back to benralizumab. I'm not saying this because I think there will be side effects of benralizumab, but this is just a law issue. If there is any problem with the child, and you know there's a 3% risk that there will be a problem with a newborn child, then the insurance company will sue me for the rest of my life. This is why my hospital does not allow me to continue other drugs such as omalizumab, no problem, but all the other drugs I cannot continue.
Absolutely correct. This is exactly the dilemma. We cannot allow it because we do not have data. And if there is any malformation or anything happens in the pregnancy, it will be pushed on to the drugs. So we have no data to suggest any of these two drugs are safe. And we move on to the next question. Dr. Fatauddin.
Thank you. This is to either of Professor Roland Bull or Wechsler. How do you identify, which is rare, the corticosteroid resistance? And are we treating some corticosteroid resistance asthma with biologicals without actually identifying in clinical practice? Your experience. Both of you can answer. Thank you.
First of all, just to answer the last question first, sorry, I'm chomping a bit. I think if you have a discussion with the patient and evaluate the risks and the benefits, and you document that if a patient who has severe asthma, the risk to the mother is bad for the risk of the child, that there might be a benefit there. There was recently a consensus statement published by a group of experts, not myself, but I think Hitasha Rupani and colleagues, suggesting that there might be benefit in that regard. In terms of oral corticosteroids, to get to your question, you want to know what to do if someone is oral steroid dependent asthma. And, I think you need to do an extensive workup. When we see those patients in our clinic, we want to make sure that it truly is asthma and that you've excluded significant reflux, vocal cord dysfunction, aspiration, and other comorbidities. We do CT imaging, we do bronchoscopy, we do tailored barium swallow, we do esophagram, we do pH probes, we do laryngoscopy to try to evaluate all those things. If you've confirmed all those things aren't present, and the patient doesn't have adrenal insufficiency, then I think you can consider the patient to have steroid-dependent asthma.
I think very clearly said that before you say it is a steroid resistance, you need to do a lot of things to see why the steroids are resistant. I think that answers very well, Dr.
Myself, Dr. Neeraj Gupta. Dr. Michael, I was just going through your publication in CHEST last year, a series on severe asthma. How do I do it? Should I interpret that those patients who have got very high values of IgE, anti-IL-4 can be given to these patients?
Yes.
So that overlap group, which has got very high IgE, can that
along with high eosinophil counts?
So the overlap group, but IgE is very high. Dupilumab.
Dupilumab is not available.
But that's not available. But is that the choice? I think you showed that graph in which it was...
In your case series also of those 4 patients, you mentioned that anti-IL-4 is effective. Will be the choice.
So there are concerns with dupilumab in patients with hypereosinophilia. And patients with eosinophil counts greater than 1,500 were not included in the dupilumab trials. There were, if you look at the totality of the dupilumab trials, I published in the Journal of Allergy Clinical Immunology, there were 7 cases of hypereosinophilia that emerged. It's not unexpected because by blocking the IL-4 receptor, you're blocking eosinophil trafficking from the blood into the tissue. So the eosinophils will stay in the blood, and if a person is making a lot of eosinophils, the levels will rise. There are concerns that in people who have very high eosinophils, that number can go up and up and up, and I've seen it in the 3,000, 4,000, 5,000, and in some patients, in a small proportion of patients, those patients may have the eosinophils may get into the tissue and cause problems. So I generally advocate against giving dupilumab in patients with eosinophil counts over 1,000, and I would monitor it in anybody who's got higher eosinophil counts. Tezepelumab is a good option for those patients, or combinations of anti-IgE and anti-IL-5 are good for those patients.
So that brings the, Randeep, you asked the question, combining anti-IL-5 and an anti-IgE together, it's like, that's the question you opened. So is that like any trials to suggest that, or is there an experience? You want to take
There's
that?
experience.
So
we have experience that we hope will be published soon.
So there is data emerging of combination therapy, but we need more of it to really say that how effective it is. And like you rightly mentioned, cost is an issue. Although the cost of omalizumab has come down. Dr. Satish wanted to take this forward.
I just want to ask my panelists here, who are eagerly waiting to be asked some question. The ladies can take this question. What kind of phenotypes do you see in your practice? You know, whether it is what Professor Roland Bull
I think Angira is holding the mic to talk about eosinophils.
Eosinophilic, you know, and then allergic type. What kind of phenotypes, and do you follow the same rules? And then followed by any one of you can also take up. India is supposed to have helminthic infestation. Do you think it's a relative contraindication for some of the biologicals to give one
So
after
for
the
those
other?
who do not know, Dr. Angira is the one who's doing routinely sputum for eosinophils. So I think this question is very good for her, which has been asked. Yeah, Angira.
So, hello. I thank Dr. Talwar for the invitation. See, in asthma, like all good things in life, you have a rule of two. Either it's eosinophilic or it's not, and it responds to the IL-5 biologics or it does not. So very simple questions there, but the crux of the matter here is whether or not we are identifying the phenotypes, or for that matter, the correct endotype, and this is what is going to tell us whether a certain biologic is going to work or not. Eosinophils have been sorted out quite a bit. We know that if it's higher, more than 300 cells in the blood, then we use a anti-IL-5 biologic. But what if the anti-IL-5 biologic is not responding? Then what? We need to do further investigations, or we just tell the patient that your asthma is very severe, we do not know what to do. So the answer to this is obviously to do a sputum quantitative assay and confirm the diagnosis that it is actually an eosinophilic airway inflammatory disease.
So a person like Satish and me can only ask one question here. In your experience, how many patients have blood eosinophils less than 150 but show the sputum eosinophils 2% above?
More than 2%.
If that is like how much we are missing, I think that's the question, isn't it, Satish? If we don't do sputum eosinophils.
So there is no direct correlation between the blood eosinophil.
Your
and the
experience,
sputum.
your experience.
So there, I can show my data in some future talk. So if you have a raised blood eosinophil, it does not mean you are going to have a raised blood sputum eosinophils, and vice versa. And if I'm asked to put a number on that, I would probably put somewhere around 20 to 25%.
So maybe we can ask the international experts,
yes, I think,
Dr. Vishner and Dr. Bull, how much importance do you give on doing regular sputum eosinophils in your practice?
Or what are the conditions in which you will definitely ask for sputum eosinophil?
I don't routinely check sputum eosinophils. I think there are problems in terms of, in many places, not everywhere. I could say there are a few places in McMaster in Canada and at University of California, San Francisco. They do it well. But in most places, there are problems in terms of collection, there are problems in terms of processing, and there's problems in terms of interpretation and reading. And unless you do it consistently and have the same people do it with expertise, you're going to have a lot of variable results. In fact, as part of the United States National Institutes of Health Asthma Clinical Research Network. I was part of the Quality Control Committee, and we had 10 centers, expert centers, go and get trained how to do it. We found that their accuracy in terms of the final read and all those features was only 50%. So it was like flipping a coin. Now, if you see eosinophils, great, but it could be missed, and it can also, sometimes there's clumping of eosinophils, and that overestimates the number of eosinophils that are there. So it needs to be done in a systematic manner in people with experience.
So if you see them good, if you don't find...
I do more bronchoscopy with bronchoalveolar lavage to evaluate eosinophils at this point.
So Professor Bull, what is the situation like in Germany? So we heard in what happens in America, what happens in Germany? I know you do sputum eosinophils at your lab.
Yes, we do, but mostly only as part of clinical trials, if necessary, and in very, very selected patients, like the lady mentioned, where we are uncertain what is happening. But it's not easy to do. We don't have the capacity to do it in every patient. This is why I cannot give you any good numbers, simply because the overall number of patients we do induce sputum is very low.
Any kind of a hint you can give it to that if this is a patient whose blood eosinophils are less than 150 and sputum eosinophils will be able to help to define better? Any guide to people here?
If you have a patient with, even though blood eosinophils are low, with very high sputum eosinophils, and as Mike said, maybe you do a bronchoscopy and do a lavage, and you do see very high eosinophil numbers, then you can consider an anti-IL-5 drug. In such a case, this would be you have only anti-Ig or anti-IL-5, so if you have high eosinophil numbers in lavage or induced sputum, my preferred choice would rather be an anti-IL-5 than an anti-IgE drug.
Okay. Dr. Dipesh, you have a question?
My question is to both the international and the national faculties. In a severe allergic asthma, can we use biologicals to control asthma and simultaneously use an allergen immunotherapy to bring a long-term remission?
Okay.
Are there any data or, it's a...
Combination of biologicals with immunotherapy.
Yes. There's data supporting additive benefits.
Yeah.
And I just asked open evidence, which is sort of the AI, the prior question I asked, what proportion of patients with eosinophils less than 150 have sputum eosinophils? And the answer was, the exact proportion depends on the study, the cutoff used in the sputum eosinophil threshold. A precise figure for less than 150 is not well established. Available evidence suggests that up to 25% of patients with low blood eosinophils still have sputum eosinophilia, a phenomenon which is isolated sputum eosinophilia.
I think that's a very good number. Thank you very much. What it means is that 1 out of 4 can be actually picked up by doing a sputum eosinophil. That adds to your this thing. And Dr. Harjeet, please ask a very short question because otherwise we have to wind up this session.
So going to the other end of the spectrum, in carefully selected patients with eosinophilic severe asthma, there is almost a 20 to 30% population who don't do well with biologics. These are patients who are not doing well on ICS, they're not doing well on systemic steroids, and they're not doing well on biologics as well. What do you think is going on? Just eosinophilia and a biologic, they always do not convert into response. These are not T2 low patients, these are T2 high patients. Some of our patients of EGPA don't do well on benralizumab, even with a very high T2 signature. So what do you think is going on in these groups of patients and how can we approach them?
So simple question is that everything is right, the drug doesn't work.
So those are the
comments.
First, go ahead. I'll let Roland answer this one. I'm happy to answer as well.
No, Mike, go ahead. You already started.
No, all right. So I think that, first of all, a lot of times when a biologic isn't working, first of all, you have to really confirm that it's not working. Is it totally not working or is it only partially not working? If there's absolutely no response, you have to go back to the basics. You have to look at the biomarkers. What are the biomarkers? Have they changed? Did the eosinophil count come down? If the eosinophil count didn't come down with an anti-IL-5 therapy, you have to ask whether or not there's some other hypereosinophilic process that might respond to imatinib or some other anti-eosinophil strategy. Most of the time, though, I think the major issue and the reason that a person isn't responding is because of other comorbidities.
Got it.
Something respiration or bronchiectasis or something else.
So something hidden, which we haven't been able to pick it up, is the one which is constantly serving that. So with that, I think we'll take a last...
Or one other thing, or they might have a mechanism that is orthogonal to type 2 biologic therapy. They might have something else going on, and we haven't developed a drug yet for them.
Randeep?
Yeah, so I think Dr. Satish wants one last question.
Just one last question for my panelist who's waiting, who's not spoken. Just to ask you about, both the speakers, stressed and put up a slide on comorbidities and to rule out comorbidities before you really think about biologics. And in your practice, what comorbidities do you see, and how do you rule out before you really think about biologics
I think this question can be, Satish, what are the comorbidities we frequently miss?
Correct.
So common comorbidities like gastroesophageal reflux disease, we have to do endoscopy and rule out, and also like other comorbidities like obstructive sleep apnea, you can plan sleep studies. So most commonly patients with obesity and obstructive sleep apnea and gastroesophageal reflux disease come. And also the cost, when we counsel the patient, rule out all these and come to label them as severe asthma, it is very the highest challenge in our country is cost. So before doing all these tests, patient be not affordable. So these are common comorbidities which I face.
I think she brought in very beautifully that unidentified exposures, as well as gastroesophageal reflux and obstructive sleep apnea, because they may not be classically fitting into the picture of obstructive sleep apnea, because their sleep apnea is primarily related to the nasal issues, which might be completely overlooked and maybe one of a very significant comorbidity. Excellent comment. I think with that we can ask Randeep to close the session.
No, I think we've had a very interesting and very informative session. A lot of questions and doubts were cleared, and we had good interaction not only with the audience but the panelists. So I'd like to take this opportunity to thank the panelists and our international speakers for really clearing all the doubts that all the delegates had. We've run out of time and we need to move on to the next session.
Next session now.
So I'd like to thank the panelists and
Thank you very much. Thank you everyone. Excellent session on 2 lectures, and we carry on with the next 2 now. This part of the Biologics Summit is by PACS, and our first speaker for this, Randeep, will you introduce Professor Richard Russell?
So the first speaker who's going to be talking on approach to severe asthma and EGPA is Professor Richard Russell, who is basically the reader in respiratory medicine at King's College London. He's head Peter Grover Department of Immunobiology, King's College London, and a consultant and respiratory physician at the Leamington New Forest Hospital, UK. He's an internationally recognized expert in COPD, respiratory immunology, and precision respiratory medicine, and he also chairs or is the chairman of the British Thoracic Society and founding editor-in-chief of the International Journal of COPD. He's a lead pioneer in research in COPD exacerbation, biologicals, respiratory infections, and innovative therapeutic approach.
So, inviting our PACS moderator, Dr. Narsimhan, on the stage. We also request Dr. Neeraj Gupta, Dr. Sandeep Nair, Dr. Nishit Kumar, Dr. Lokesh Gota, Dr. S.K. Madhukar, and Dr. Shrikant Jua. Stage is all yours, Professor Richard Russell.
Good morning. Good morning, everybody. It's wonderful to be here in India. My second visit in 35 years. India has changed a little bit in that time. But it's wonderful to be back here and also feel very, very much at home in this wonderful country. I'm not going to apologize because I'm going to follow on from that last great discussion and actually try and put a little bit of more clarity around the management of straightforward, and this is going to sound crazy, severe asthma, and also EGPA in specific terms, okay? Because I think I come at this from a slightly different angle. I'm an airway doctor. I manage asthma in every aspect, from mild, moderate, severe. And I therefore also have to think about many of the comorbidities and the problems that were raised in that last question. So I'm going to break it down a little bit more for you, as well as talking about how we can manage this maybe better. You've heard a little bit about me. I'm a professor at King's College London and the director of the Peter Gora Department of Immunobiology. These are my disclosures. And I love speaking, sharing, and learning from all of you, so which is a great opportunity for today. I'm going to talk a little bit briefly about severe asthma, and I'm going to share with you a particular idea I have, which I think is going to change a little bit of what we do. The epidemiology, yes, and maybe the specifics, how that relates to the Indian subcontinent, and how we can maybe treat it, as well as, obviously, in the context of EGPA. The global burden of asthma is enormous, you know this. It is interesting where it is focused. It is exploding now in India. It is exploding now in China and in other countries because we're recognizing it, but also driven by changes in diet and lifestyle and those other things which are actually happening. And of course, there is massive problems with uncontrolled disease, with morbidity, mortality, of which what we define as severe asthma is a minority. And we need to be aware of that. We must not completely focus purely on that. However, and this is important, severe disease accounts for the vast majority of direct healthcare costs, particularly hospital admissions. And many of the interventions in the UK and in the Western world are designed at reducing admissions to hospital, because that's where cost is. And patients don't like going to hospital. We need to be aware of these asthma subtypes, and we've talked already about T2 disease with exacerbation-prone eosinophilic disease, but also there's people with very high burdens of symptoms, but maybe with low biomarkers, whether that's sputum, blood, or FeNO. Allergic asthma, we've talked about the high IgE burden, and how that's become obvious because of the role we've had of omalizumab over the last 20 years now. Although I suspect those things are often driven by other processes immunologically. And Mike hinted at the end about the people with persistent airways inflammation. I love testing sputum. I do it in our laboratory. Why? Because I'm looking for neutrophilic disease. Because if you find someone with persistent severe asthma, persistent exacerbations, and you found neutrophilic disease, you can treat in a different way. And of course, we have results from the AMAZES study looking at antibiotic therapy, which really works in a way. And then we have other diseases as well. Now, I find this unsatisfactory. And I think it's one of the things that's held us back is this definition of what severe asthma is, particularly when it comes to people who are dependent on oral steroids. Because that pulls in much complexity, which is hard. The psychological dependence on oral steroids, the chicken and egg phenomenon of comorbidities driven by oral steroids, which we then see later, particularly in adults. People have had childhood disease with multiple courses, and then the metabolic syndromes that follow. And I would suggest, and this is my thoughts, and I'm going to put this out there, and I've discussed this with Helen Riddell and others from GINA, that maybe we should look at asthma in a different way, about not uncontrolled, but controlled. And so maybe asthma should be defined as disease which is controlled with inhaled therapies. Certainly dual bronchodilators, maybe up to including triple therapies. Maybe we then have a disease which is defined as control through biologic therapies. And that is distinct from difficult asthma. And difficult asthma is difficult to control because it has the comorbidities and it has the other problems associated with it. And I wonder whether the future will be not a debate about necessarily whether we should or shouldn't use biologics, because I think we have that quite clear now, but is the treatments which we can use to achieve perfect control of asthma, whether it's inhaled, whether it's biologics, or whether it is actually difficult. And I think that is really important going forwards. But the burden's there already with steroid use, with lung function, with quality of life loss, with other morbidities. And of course, we have different treatments we use depending upon the different and underlying causes of the diseases. Whether it's severe allergic disease, we may use anti-Ig therapy. Whether it's eosinophilic, we use anti-IL-5 or anti-IL-4/13 inhibitors. Neutrophilics, particularly macrolide therapy, can be extremely effective, etc. And you can see how we maybe need to be looking at this. I want to come back to the patients, though. What we forget in these debates is the suffering and the problems our patients are having. This is an old study from David Price, which looked at what patients' concerns are, and this is still the same. Patients hate asthma attacks. COPD patients hate exacerbations. Patients want to be able to be active and do normal things. Patients hate oral steroids. And we need to improve and look at our patients' concerns as well. And we have people who die all the time now, still, of asthma exacerbations. And that is not acceptable. We need to push down on this. We mentioned comorbidities, and I think comorbidities are critical. If you take an asthma patient and provide them with an elemental diet, the asthma gets better. So how much of this is actually driven by external drivers of our immune system rather than just the exposure that we got in or the intrinsic factors of our patients? And you've already discussed the allergy drivers, the chronic rhinosinusitis. We've already discussed a little bit about reflux disease. And I want to focus on obesity. Obesity is a major factor. We used to think that fat cells were biologically inert. They're not. With higher levels of CRP, higher levels of type 2 disease. And interestingly, some of the most revolutionary changes I've seen in my patients are patients who've got obese, partly because of steroids, oral steroids, who've then lost the weight. Their asthma has gone away. And I think that's really important to maybe think about those comorbidities as well before we perhaps dive into more complex and more expensive treatments. And then finally, depression and anxiety. Much of the work I started doing back in the actually early 90s was looking at things like cognitive behavioral therapy in these patients. These patients have depression and anxiety. Do we address that? No. We should, because again, that will improve outcomes in our severe asthma population. Of course, we need to look at phenotype, and these are two sputum tests from patients, one with a high symptom burden, one with a low symptom burden, one who is going to intensive care, driven by eosinophils. And of course, we have to understand these phenotypes and specifically treat these phenotypes. And you know that if we use a simple phenotype test such as sputum, and this is an old study done by Ruth Green looking at following treatments with sputum tests versus normal guidelines, you get better outcomes. So using phenotypes is exactly correct. And this has led to the ideas now, and this is from some work from Leicester of Ian Pavord and Pranav Haldar, looking at how we maybe should look at symptoms and eosinophilic inflammation in two different ways. And you have people who are concordant and people who are discordant, either with lots of inflammation but low symptoms, or lots of symptoms but no inflammation. The people with inflammation are at risk of exacerbation and mortality. And of course, we maybe want to treat in a different way because they do have different phenotypes. And this maybe lead to a different way of expressing and understanding the diseases in these patients between the inflammation and the airways dysfunction and therefore the focus. Of course, you've already seen this data that mepolizumab does have a role. Anti-IL-5 therapies in eosinophilic severe asthma is effective. There's no question about that whatsoever. And this has led various groups, but particularly the treatable traits approach, led by Alvar Augusti and Pavord, that has led to us being focused on how we can say, this is the trait of the patient and we need to treat it. And I would strongly recommend, if you have an opportunity, please do read this Lancet Commission from a few years ago now, but it's still driving forwards change in our thinking about asthma and how we define asthma. So the new approach is looking at symptoms and looking at inflammation and looking at how we can then, this idea as was mentioned by Roland, the patients who are hot, the hot, with high symptoms and high inflammation particularly, can really help us then focus on what we're trying to do and how we treat it. Clinical trials, though, now really not only need to understand efficacy and safety, but we also need to understand who is effective and who we are targeting. And we often don't ask that very well. Blood eosinophils are extremely powerful, and whether you look at mepolizumab or benralizumab, you can see there's a direct link between levels of response and levels of blood eosinophils. So they really are important and helpful for us. And you can see that we can use pheno, for example, particularly with dupilumab. So different biologics need different phenotype characteristics, both to predict response, but also then to follow response going forwards. And I'm going to finish this first section by talking about newer phenotypes, maybe. Look at mucus plugging, new phenotypes based upon imaging, maybe physiology, which can really help us with mucus scores, which will actually also predict response, particularly to drugs like the anti-IL-4/13 inhibitors. And we're seeing that in asthma and also in COPD. So this is where we're going with the new disease. And we're understanding slowly the pathways of the biologic therapies where they can potentially help us in severe asthma, or in asthma, that can actually then help drive new changes in our treatments and our understandings. Of course, it's not just about IL-5. It's not just about eosinophils. It's not just about atopic and allergy. There's infection, cough, smoking is important. And of course, there are then the psychological or the breathing pattern disorders, the anxiety, the depression, and I've already mentioned the obesity. And a comprehensive, difficult asthma service should have access to all of these things. And I'm going to put the case that I think it's a little bit different from just a biologically sensitive patient, which I think a little bit easier and different. Adherence is critical. Non-adherence is a problem in severe asthma, and we need to address that. It's been hinted at this morning, but it's the elephant in the room. Do our patients take their treatment? Do they know how to take their inhalers? Do they comply? The answer is very often no, and so we need to address that as well. And then finally, of course, macrolides in the right people are extremely effective, so please do not forget those as well. So let's talk about EGPA. What about EGPA as a specific issue? It's really exciting as a respiratory physician to be able to deal with a disease which maybe crosses over into other problems. What we're trying to avoid here, which is really important, is end organ damage, because then it's too late. There are prodromal phases, there's then also an eosinophilic phase, and then there's the vasculitic phase. We often see the patients in the prodrome phase and miss it. But then we develop an eosinophilic problem, and then we perhaps do detect it and pick it up. And we want to avoid the vasculitic phase if we possibly can, because that's where the damage is occurring. This may be days to years in the prodrome with some upper respiratory tract symptoms, some sinusitis, some weight loss and arthralgia. And these may then also progress slowly over time, with many not preferring. Of course, this is a systemic problem, not just a pure airways problem. And so it's complicated. And how we diagnose the condition is as a syndrome. With asthma, yes, with eosinophilia, plus other things that we find with two of those, whether it's a biopsy or whether it's ANCA positive, whether it's sinonasal disease as well. Not simple. And I think this also involves us involving our rheumatological colleagues and being close and being very critical to look for these end organ or these other multi-system disorders that we can find with EGPA. I'm just going to put this up there that if you ever do want to look at this, and I say that again, the LS monograph is really important because it tells you how to assess and how to manage your patients. These are the routine tests that we do in our laboratories or in our clinics to look at the bloods workup as well as the imaging workup, the physiological workup, including extra things, including nerve biopsies and skin biopsies that may need to be done. It's associated with increased levels of eosinophil protein, and you can measure ECP, for example, and galectin-10. And interestingly, when the patients get better, the levels of these markers go down. Not in routine practice yet, but certainly could be coming to really help us going forwards. So how do we treat this condition? And I hesitate because Mike has led two of the very big studies which have looked at the treatments of EGPA with biologic therapies. But what's really interesting in this, because we're looking at lung disease, many of these people are ANCA negative. ANCA is a very poor marker to not only diagnose but predict response to this treatment. I'll show you some more of that data. But you can see less than 10% of patients in this study with proven EGPA were actually ANCA positive. What results do we get? Well, we can see, but they did have a very high level of comorbidities. 50% of patients had neurological disease, sinusitis disease, and renal disease. We have to work with colleagues to do this better. And you can see that the drugs work. Using an in the right patients, the anti-eosinophil approach really does work, with improvements in remission rates, with improvements in steroid use, with improvements in clinical outcomes, and a reduction in relapse. So these patients do actually very well. Mike hinted in that last session that there was this study, the Mandara study, which compared benralizumab versus mepolizumab in EGPA. Again, the same groups of patients treated over time, and showed that actually eosinophil counts go down a little further, a little bit quicker with benralizumab because of its mechanism of action. But also, there was no change in the levels of clinical remission, but significant numbers of patients, more with benralizumab, eliminated the oral steroids, and there were lower relapse rates. If you looked over time, these are the people who continued treatment. They actually had less of a relapse going forwards with lower levels of eosinophils as well. So this was really very helpful to understand that both drugs work in the initial phase, but maybe benralizumab has some benefits in the longer phase to reduce the oral steroids, to reduce the remission rates, and the other problems that are being seen in these EGPA patients. In the center where I work now, led by David Jackson and Alex Nanza, we've now followed over time the long-term effectiveness of this treatment in EGPA, and I'm very grateful for David for providing me with some of this data, looking at patients in the real world going forwards who've got EGPA. Again, their levels of ANCA levels were particularly low, and we have compared in this group ANCA positive with ANCA negative patients. Is this vasculitis phase really important from the lung point of view? You can see also they received other therapies, including azathioprine, mycophenolate, and others in the past. Well, what we found, very importantly, was that the eosinophil levels were actually similar. The ANCA-positive patients were slightly lower in some ways, but they had very similar doses of oral steroids in the patients going forward, with similar levels of comorbidities as well. So what did we find? There was no difference in the outcomes of the patients, whether they're ANCA positive or ANCA negative in this study, such that clearly the eosinophil and the asthma components that were driving the disease that we were picking up was really important. And a literature review of this showed very clearly again that actually the remission status that we see is independent of ANCA. So just be careful how we interpret that ANCA. Look for the comorbidities, look for the skin disease, look for the neurological disease. But ANCA doesn't perhaps really help us very, very well. But perhaps FeNO does. And interestingly, the FeNO levels change over time, with actually it being a biomarker potentially of relapse. And we saw that FeNO was increased in some of the patients who then relapsed. This is a practical and useful thing to actually follow perhaps in these patients. So maybe some hints there how we can perhaps do this a little bit better. And this has led to now new guidelines, how we should manage EGPA and how we should detect EGPA. And we certainly, working very closely with the rheumatologists, have produced this together such that rheumatologists don't ignore the airways component and we don't ignore the vasculitis component. So please do look at these new guidelines. We must consider EGPA in people with asthma, rhinosinusitis, and eosinophils. An ANCA check can be really helpful, but think about the comorbidities. 50% will have renal disease, skin disease, and other problems. We must change our paradigm. And I think this is quite useful for understanding of asthma, because we consider a vasculitis almost like a cancer, that we need to induce remission and prevent relapse. Do we really think about that in asthma, in COPD? Not so much, but maybe we should. And so taking this very active, proactive approach to aggressive treatment driven by rheumatologists who are used to early treatment of joint disease, for example, may be really helping us change our mindsets in our airways disease treatment. We need to use anti-IL-5 therapies, yes, and of course, if there's life-threatening comorbidities, use of cyclophosphamide or rituximab and other treatments may well be helpful. And there are flowcharts in this guidance which really helps us go through how we detect, how we treat patients depending upon the potential severity of what they have going forwards. And this is straightforward to do, and I'm not going to particularly run through it now, other than the fact that they are being quite aggressive to induce remission. Really important to understand as a concept. So these are now recommendations, and this is the reimbursement we have now for example, benralizumab, how we should be using it in our patients with EGPA. And NICE is a really useful thing, again, to look at how we can manage our patients better in a cost-effective manner. So I'm going to conclude. Severe asthma is heterogeneous. Severe asthma is a problem. And I think we maybe need to separate severe asthma into biologically sensitive and difficult. EGPA itself is a complex heterogeneous disease. The eosinophil is a driver of this process and is a great target to use, particularly in the pre-vasculitic end organ disease stage. Very helpful and works. Benralizumab works very well and should be initiated and induces remission and prevents relapse, which I think is really important. But of course, many don't achieve that, 1/3. And so we need to be looking at maybe combination therapies, other cytotoxic therapies, which may really be helpful because these patients will develop end organ damage, which will be irreversible. And working together with people maybe with a different mindset, with a different lens, looking at the whole patient may really be helpful. This is all wrapped up very nicely in this ERS monograph, and Mike and David penned this and edited this. Please do have a read of it. It's very clear, very straightforward, and also please do look at the British Society of Rheumatology guidelines. Thank you for listening.
Thank you very much for an excellent overview on the topic of severe asthma and on EGPA. EGPA is a challenging disease, and many of us really diagnose it when the patient has actually had small vessel vasculitis and end organ damage. We need to be more aggressive in suspecting it early and being able to treat it early to prevent the end organ damage. We have now time for a panel discussion.
Professor Narasimhan is there.
Professor Narasimhan, you could start the panel discussion.
So I strongly believe that all these severe asthmatics, severe eosinophilic asthmas are asthmas that are not properly treated at an early phase. That brings to the question whether we should expose these patients to biologics early enough. Suppose you find an eosinophil that's pretty high, say 20 or 30, he is referred to you as you're a consultant, he has come to you for help. You have found eosinophils, he has been tried everything by a consultant physician and also a pulmonologist. At that stage, should we think that we should step up our inhaler dosage and see whether he responds or not, or we should expose the guy to the biologics at that stage itself? Because I think most of these severe eosinophilic asthmas are asthmas that have not been properly addressed to at an initial stage. I think I'd like to add this question.
That's a really great point. And it was mentioned briefly in the last discussion. We have a real lack of evidence about this early initiation, in this pushing forward and earlier. And of course, as treatments become cheaper and more available, we have some more Me Too-like drugs, we will be asking, I hope we'll be asking these questions, because it is critical. If we compare what we do in respiratory disease with rheumatology, when I learned in medicine, we looked at joints and hands which were destroyed with inflammatory arthritis and particularly rheumatoid disease. Now that's not the case, because as soon as a patient presents with any pain, they have a screening test of blood tests, and if these tests are positive, they get biologic therapy in rheumatology, which stops this disease progression. We need to be taking this proactive approach, which is why I mentioned, I think the asthma world is changing, and the COPD world to a degree, that we need to be taking more of a proactive, aggressive approach to inhaler-controlled disease with inhaled therapies, and if they're not controlled, maybe considering them for biologic therapy, which is different to severe disease and difficult disease, which again has comorbidities involved. The aggressive looking for EGPA is clearly very important, but the numbers are quite small. So I would absolutely agree. We really do need to push forward to an earlier aggressive diagnosis. This will be in primary care, looking at blood tests, looking at inflammation, and being absolutely critical to push down on symptoms and on attacks, and have a zero tolerance for those diseases. Yeah.
Yeah, please go.
Deepak, your thoughts on that? Because the reason why I'm asking is, we are now going towards the concept of remission in bronchial asthma. If we had to achieve remission of bronchial asthma where the patient can remain off inhalers, steroid inhalers for 3 or 4 months, if you expose the guy to biologics early enough, I think we have achieved part of our, at least the thought process of remission. What's your concept on this remission, early use of biologics in bronchial asthma? I asked because the Indian medicine, I want to ask
So
you too.
this is a very provocative question, and I have been asked this number of times, and I have only one answer, that if one injection is at the cost of one inhaler, why not?
And I think the other issue is, if you are able to show that the treatment can decrease admissions, then you could justify the cost to some extent. And I have one other question for Professor Russell. You stressed a lot on adherence as not being followed a lot. Do you think the addition of biologicals could address that issue?
So this is the critical thing. It comes back to what Deepak just said. You know, once you have got, if we have with our longer acting therapies now coming, one injection will be fantastic in that way.
Correct.
This is a really great question because the current studies looking at long-term control, looking at the patients who become less adherent with their inhalers, we detect increasing levels of inflammation and then potentially therefore increased risk of future attack. So our data would suggest you really do need to stay both on your inhalers and a biologic. However, that's in a particular population, that's in a severe population. And it may well be that in a milder population, an earlier population, a biologic alone may be satisfactory. We don't know that, and we need to be careful how we say that, because of course they may well be perfectly treated with an inhaled therapy as well. But if as Deepak said, if the inhaler costs the same as the injection, it makes sense as long as the efficacy is the same.
So tomorrow, tell me, all of you are sitting here. If you have an injection which is to be given once a year, which costs 12 inhalers in the year to the patient, and he says, I want that, would you say no? Would you say that it's biologic, I don't want to give you? Why no? It's a question of adherence, correct? It is a question of control, it is correct. But at the end of the day, who is the user? If he is not ready to use it and he is going to be non-compliant, then if this can improve the compliance, it will make a difference. I think everybody will ask that, how can it improve the compliance? Have you seen the rheumatology practice? Everybody takes rituximab once in 6 months and done. They are happy. If this situation comes tomorrow, I think we need to keep our minds open, eyes open, and of course brains open also.
So I think we're moving in that direction. We're having now biologicals available which would be once in 6 months. And if we have something like that and it is cost effective and it really does decrease the, modify the disease progression and also decrease the cost of admission because of exacerbation, maybe that's the future. So looking at reluctance for biologicals to acceptance of biologicals probably as an alternate to the current standard of treatment that we follow, which is the inhaled treatment, may be something that we may see in the future. Any comments from the panelists?
I think the point is very clear, sir. The patient definitely wants he doesn't want to have exacerbations and he doesn't want to use residual inhaler. These are the two demands from the patient that we see routinely. So if that biologicals, whatever we are discussing on this point, if that one shot per 6 months is not leaving the patient to use residual inhaler, or he is not getting any exacerbation, I think patient is 100% happy. in taking one shot in 6 months maybe.
Lokesh, for your experience, I will ask the same question and remold it a little bit. I think the beautiful slide which Professor Russell showed, you have severe asthma, you have eosinophilia, these patients are on steroids, and they have some atypical presentations. These are EGPA patients. How much are we missing in this heap of severe asthma? Because we did publish 24 cases because we discovered it only because of that. And they were all ANCA, not all 70% were ANCA negative. And the concept in our mind is, if ANCA is negative, this is not EGPA. I think that is something which has shown, the data shown by Professor Russell was great, where only 10% was positive in ANCA. Actually, that is, I think, mind-blowing to consider that ANCA is not a screening test at all for EGPA. So what is your take? Because you also run a severe asthma clinic.
Yes, sir. See, like you mentioned, unlike GPA, it's very, very common in India. But EGPA, to diagnose, one should have high suspicion because there is no standardized markers, blood tests to say that EGPA, like you said, it's less than 30% positive in various MPO antibodies. So when there is no vasculitis symptoms like foot drop or wrist drop, the patient has only asthma and allergic rhinitis, which is very, very common. And the patient is not responding to the regular medications, but they respond well to the OCS. That's where EGPA get masked. So to diagnose EGPA, one should have very, very high suspicion. And once these patients, like in one of our discussion, we were having discussion, once you start these patients on biologic, Mepoli or Benrali, usually these severe asthma patients, they do well on biologics. But once you step down to Benrali once in 8 weeks, then again the relapse comes back. That means where in EGPA, where we have to give Benrali every month, unlike in severe asthma. So maybe that is also one suspicion where we might be missing EGPA in severe asthmatics. So one should have very high suspicion because there is lack of standardization, unlike in other diseases. So along with clinical, these are more of clinical criteria more than blood markers in this case.
So I think he's made the point very clear that really need to think beyond the box, go beyond it. And Dr. Madhukar, the beautiful, I think, one slide which Professor Russell showed, that if your patient has severe asthma, patient is on steroids, patient requiring it, not getting good control, and eosinophil count more than 1,000. Is that a right direction even in India, considering that you come from a state where we feel the eosinophil counts like 1,000 is in every person? So what is your experience? Because you also do so much of severe asthma work.
Absolutely. I mean, over the last 8 months, I've diagnosed 6 patients with EGPA. So I would say it's uncommon, but definitely not rare. How do I approach it to the diagnosis as you are talking about? So in 2 ways. There are 2 situations when my mind will start thinking of EGPA. The first is any patients with asthma, whether it's severe or not, asthma with eosinophilia more than 1,000, and rhinosinusitis. So when this triad is there, I would start thinking of EGPA or suspecting EGPA. Another situation is when my patient is having severe asthma, as you have been telling to me. So under these 2 circumstances, my mind will start thinking of EGPA. Then how do I go ahead? Let's make it very clear. There are 2 phases of the disease in EGPA. One phase where eosinophilia drives the disease. Another phase where vasculitis drives the disease. Pulmonary involvement, gastrointestinal involvement, or cardiac involvement occurs usually in the patients where the disease is not driven by the vasculitis.
Yeah.
So in most of our cases, the ANCA wouldn't be positive.
Okay.
And this is how...
I think you just echoed everything out here, but I think that if we have sensitized everyone today here, I think the major job has been done, because if you look at the data, you don't find data from India reporting EGPA. Why? The reason is because we see them in some way or the other, but I think we were not so sensitized that how to look at it. It may look nothing different than severe asthma actually. That's the part of patients which we are seeing. If they have a cardiac problem, they go to cardiologist. If they have a gastric problem, they go to gastroenterologist. If you have a neuro problem, they go to neurologist. And when they are breathless, they come to us. And that's the problem, because we are not able to connect the dots. I think very rightly you said, we are sitting on the hip, and especially now, because we are looking very closely at severe asthma, we don't want to miss it. That is very important.
So I think if you have a patient who has eosinophilia, you have to then start looking at outside the lung. You need to look at systemic manifestations. Remember, EGPA is a systemic disease, it's a small vessel vasculitis. What has happened is we get compartmentalized only to looking at the lung point of view. You should look for mononeuritis multiplex, if there's any GI disturbances, cardiac failure. If you don't look for it, you will definitely miss it. It's more of a clinical suspicion rather than looking at an ANCA positivity.
I think that is the crux, Randeep, you brought in. You are a severe asthma patient. He complains of any other system. Think of EGPA. That this may be that, rather than just referring it to the another consultant to go on for that. I think that's the message which we are trying to give it. And very beautifully, I think, shown that how benralizumab can be actually used, and it's non-severe, so that's perfectly fine. And I think Angira is already standing there. Angira and eosinophil is same. Two sides of the same coin.
Eosinophil.
Yeah.
I take it with full humor. So my is a suggestion, or rather I would invite comment, from the fact that we have all been talking about the price of these IL-5s, receptor blocker or not. One of the strategies, I'm not sure whether it should work, is to give the biologics to the patient as and when required. In rheumatology, we have been doing this for the when the joint symptoms come across, then we give the interleukin inhibitors, infliximab, you could give bevacizumab. But this habit has not come across to us, and we do not know the answer as well. So do you think it's a good suggestion or a bad one? It works or it doesn't
Can't
work?
hear. She must be closer to the mic.
Yeah, Professor Richard.
Yeah. So just to re-ask your question, you're saying one potential strategy for the use of biologics in this situation would be to use as required for our patients. And how does that work, and how to think about it? This is really a very interesting rethink of strategies that may really change the world of asthma. But I would be worried about EGPA, because EGPA as a systemic, potentially vasculitis end organ disease, using an as-needed approach would not switch off the drivers of what's going on. So that's a little bit of a worry in the context of EGPA only, okay? However, I would throw you one piece of information and evidence. So Professor Baffodel, who's speaking later on in a minute, led a piece of work called the ABRA study, which looked at the acute use of benralizumab in patients with COPD and asthma who had attacks. They came to hospital and they had eosinophilic disease. And we demonstrated in that study that the benralizumab acute treatment was better than oral steroids.
Right.
And so in that context, it may well be an approach that we could consider taking, but that's different to the EGPA.
Yeah, that's an acute exacerbation. For an acute attack.
Acute attack.
Yeah.
And again,
in fact, our center primarily picked up these patients because they were shifted from benralizumab once a month to once in 2 months, and something started getting wrong out there. And we thought that what's happening actually, we realized actually it was inadequate dose of benralizumab and unmasking which happened. Neeraj, I will ask one question to you. Did you see, because you see a lot of ABPA patients, I know that you have a lot of ABPA patients which you see, you have used omalizumab. So if their eosinophil counts are also high, have you seen that there is an overlap of ABPA as well as EGPA patient? Did you see this kind of a thing, scenario?
I have seen, I think, 1 or 2 such cases, and at this point of time, I will suggest that we always talk of systemic manifestation of COPD. It's the time actually we should suspect all asthmatic patients who manifest with other system disorders or symptoms, we should always look for vasculitis in these patients, because we can frequently miss these patients, and they may be devoid of adequate treatment for that.
This is an interesting question. Very recently, I saw a patient where I thought of having EZPA, ABPA overlap.
Okay.
The patient had severe asthma, ABPA markers positive, bilateral bronchiectasis, very high eosinophil to the range of 5,000. On late gadolinium enhanced MRI, the patient had the patchy uptake in the subendocardial region, highly suggestive of EZPA.
Right.
So, and the skin purpura, which came out to be the vasculitis. So it's
I think excellent comment, Madhukar.
Another clinical scenario, Deepak, when you have a patient of severe bronchial asthma, when you do a bronchoscopy in this patient, you look for eosinophils, that will be positive. You look for galactoman and as well as PCR, that will be positive. You have a very high eosinophilia.
Right.
There.
Actually,
so
my
we
patient...
need to decipher which one is the priority there. Whether you need to go for a biologics or you have to go for a steroids.
Correct.
My patient...
This goes, Professor Russell, actually you showed the spectrum. It can be hypereosinophilia, just bronchial asthma, hypereosinophilia, EGPA, ABPA, all kind of things which are possible in a patient which is going on. But we get stuck with the criteria of only one particular disease of this.
Which is why the rheumatologists, and when we did the combined guideline, said, have you got life-threatening disease? Have you got cardiac disease? Have you got neurological disease? And they take a much more aggressive approach then with cyclophosphamide up front rather than taking an IL-5 biologic. So that's really important.
So I think we'll also come to something like an overlap syndrome.
Correct.
Where
we might have to decide actually which is the driver which needs to be targeted in that particular situation. I'm sorry we will not be able to take questions here because we have to move on to the next cycle. But Indu, you were standing there to ask the question first and sat down. Short, crisp question.
Just a very simple question actually to you or anybody.
Every question is a simple question if you know the answer.
No, I don't. So basically we are talking about it's a complex disease and we need to pick it up early. So what are these early signs? I mean, of course, there could be purpura, there could be...
Okay, I think this is a very good question that in practice, I will straight go to this question to Professor Richard.
Because many times, sir, as you said, ANCA can be negative. There could be no
so
definite...
that I'm coming to that question. So we want to give a message to all these people sitting here. When you see a severe asthma patient, if you see these things, these are red flags to look for EGPA. I think that's the question.
So that is a
Thank you, Indu. You can have a seat.
That's a very simple question.
Your question has been taken.
But it's not easy because of the timelines of progression. And so I think we have to think about this in several ways. Firstly, when a patient presents to you with eosinophilic asthma, think EGPA, certainly. ANCA, negative, positive. If it's positive, it helps you. If it's negative, it doesn't. Obviously, look at that time for the comorbidities, the skin disease, check the renal function, etc. But then, significantly watch and follow those patients because the asthma prodrome can last for years before they then develop the vasculitis syndrome. And so ANCA does change over time, not checked every 6 months, but every few years or so, if that patient continues to have severe asthma problems. So I think it's something not to assume. The burden is on us to be aggressively thinking and looking at the whole system in that way. So I don't think there's any easy test to do.
I think I have taken the tagline, severe eosinophilic asthma, think EGPA. I think that's the tagline out here. Very beautifully said and very nicely to conclude this session. Thank you very much. And Randeep, we can carry on with the next one now. Thank you very much.
Thank you very much. I think we had a very interesting discussion on how to really approach and not miss the diagnosis of EGPA. I think it's still underdiagnosed in our country. We go on to the next session, which is more interesting. It's a case presentation by Indian experts. And we have the chest experts who are online, Dr. Ronald Bull and Professor Vishner, who are going to be online. And we have the PACS international experts, Dr. Richard Russell and Dr. Mona Bafedel, who will also be our panel experts. And I can ask them all to come onto the stage.
Professor Mona.
And we have the PACS expert, Dr. Rajbir Singh also.
And the first case is coming up with Dr. Rahul Sharma.
Good morning, everyone. And at the outset, I would like to thank Dr. Talwar sir and PACS team for this invitation. So I'll be very, very brief with a case of severe asthma. He was a 61-year-old man. History of asthma for last 10 years. Initially managed largely with SOS medication, but for the last 2 years, because of his symptoms, he was taking salmeterol, fluticasone 252 puff twice a day with tiotropium, theophylline and add-on therapies. Never smoker. Patient has a family history of asthma. There was no significant history of any other comorbidities, no major allergies or sinusitis. His BMI was on a little higher side. We could get a PFT of this patient, but it was not in the form of report, but it was written on the prescription as 45% predicted FEV1 with obstructive pattern with 20% bronchodilator reversibility. His FeNO we checked was 42 part per billion and IG was 127. So we could gather data from this that the variability is confirmed, type 2 inflammation is confirmed, and patient is taking controller therapy with ICS based therapy, and he had good technique and compliance. Right, but for the last 1 year was not that good to this patient. There was a history of exacerbation, 2 exacerbation patient managed at home with oral prednisolone 30 milligrams for 5 days, and the last one was a hospitalization which reported pneumonias. Patient's symptoms even persisted after recovering from the pneumonia for next 1 to 2 months. Despite nebulization form of formoterol, budesonide, anti-allergic, oral bronchodilators, and he is requiring some course of oral corticosteroid by himself because he has learned now that if the symptoms are not improving, steroid is probably the mainstay of treatment in such situation. We reassess the patient. There was a significant decline in the FEV1 ratio of this patient, which was FEV1 of 42% with absolute value 1.18. FeNO was still high despite patient was taking burst of oral corticosteroid and high dose inhaled corticosteroid. IG was also 117 and AC was 290. We did do the allergy profiling of this patient, and patient was found positive for house dust mite, and other things are negative in these patients. So then comes to the decision of severe asthma. We all confirm that this is a patient of severe asthma. Patient has recurrent exacerbations, persistent symptoms, signals showing type 2 inflammatory markers, and patient is increasingly having high dose of OCS exposures. We concluded that patient should be started on anti-IL-5 therapy, but patient lost to follow-up and subsequently started from omalizumab. Do we have any question here, or I should continue, sir? So
maybe we can ask the experts what would their choice have been. Would it been? I think we have Dr. Ronald Bull and Professor Vishnu also online.
Yeah.
So any comments in terms of what drug you would choose in this patient? Now, Professor Bull, Ronald Bull.
I'm sorry, I cannot see the slides. This is why I got only fragments of the case history.
So Rahul, just summarize
So
that.
if I can summarize this case to you, sir, it is a 62-year-old male, known case of bronchial asthma for last 10 years, on regular therapy with inhaled corticosteroids, high dose for the last 2 years, but still patient has 3 exacerbations, 2 requiring oral corticosteroid and 1 requiring hospitalization. And post-hospitalization also patient is having persistent symptoms requiring baseline oral corticosteroids. His PFT is showing moderate obstruction with FEV1 of 42%, with bronchodilator reversibility was there initially. FeNO was 35 part per billion, IG is 117 and AEC is 290. His allergy profile was also positive for house dust mite.
Yeah, but I mean, this is
imaging. Is there any imaging, X-ray or CT scan?
So
or
X-ray
anything
was
like that?
done initially. It was normal. If you can see these slides, I don't know whether these slides Axis is there with you, but X-ray was normal. We did CT later, and it was also normal. There was only air trapping and small airway disease in this patient.
You can show just quickly run through the X-ray.
X-ray.
We can't see the slides.
Yeah, so we can just.
Yeah.
So I think the question here is, what treatment strategy would we offer this patient who's had 3 exacerbations, 1 admission because of an exacerbation, has required oral corticosteroids, has borderline values as far as FeNO is concerned and IgE is concerned. Eosinophil is 290, FeNO is 35, IgE is 117. He was therefore subsequently lost to follow up, but he was given omalizumab outside, if I'm not mistaken.
Yes.
If all you have in India is anti-Ig and anti-IL-5, I would give anti-IL-5 at this point. But if you have access to anti-IL-4 or anti-TSLP, I would probably give one of those.
I agree. I mean, this is a late onset asthmatic, so my first choice would be anti-IL-5 before anti-IgE.
Right, and if you had dupilumab available, would you prefer that?
I would. The
FeNO is 35.
oxide is elevated, suggesting that there's an IL-13 mediated pathway. And so I would probably go with that, or I would most likely go if anti-TSLP was available, I would go with that.
Yeah.
Right. Okay.
So this
you
patient
can
was
continue with the case.
Yeah, so this patient was initially started with omalizumab therapy 4 weekly with inhaled corticosteroid and supportive therapy. Patient showed some improvement in terms of clinical, fewer exacerbation, still requiring SOS oral corticosteroid. But after 11 months, patient again had 2 relapse within a period of 2 months requiring oral corticosteroid followed by hospitalization, and patient returned to our center. We re-evaluated the patient and reassessed the patient. Patient was compliant to the therapy, technique was good. Low dose OCS was maintained in terms of omnacortical prednisone on 10 milligrams OD. ACT was 10, sleep screen suggestive of mild OSA, X-ray chest and penis was normal, and ABPA workup was negative. And this was the CT that we did. I'm not sure whether the quality is good or not. So it was showing only air trapping, no bronchiectasis, no nodules, no other features in this patient. Re-phenotyping of this patient again showed FeNO was on a higher side, 32 part per billion, AEC was 390, IG 152. Patient was on triple therapy in nebulized form. Along with this, he is also requiring oral corticosteroid. And during worsening, he is self-escalating now but most of the days he is requiring oral corticosteroids. So do we
Does he improve with oral corticosteroids?
Sorry?
He was on
Does
10
he improve with oral corticosteroids?
He was on 10 milligram of prednisolone.
Did he get better on the prednisolone?
Yes, so for the control of his symptoms, along with nebulizer, he is requiring oral corticosteroids.
So the biomarkers which you have shown is on steroids?
This is on steroids, sir.
So the biomarkers were on steroids. As Professor Bullet suggested, they did not stop steroids for 24 hours and then see the biomarkers again.
So we did the PFT of this patient at that particular time, but the lung function had, decreased significantly with FEV1 of only 22% with absolute value of 560 ml. So this is the time when we start thinking whether we should switch the biologics here, because patient has exacerbation, persistent symptoms, OCS dependence, type 2 signals are still there despite oral corticosteroids. There are inadequate control, so we started thinking that should we switch the molecule, and we started this patient on benralizumab later on. Again, the response was very good for the first 6 months. Slowly, the oral corticosteroid dose was tapered down and stopped. Patient ACT improved to 17, symptom improved. There was no exacerbation as far as the hospitalization is concerned, though he required 1 dose of oral corticosteroid in between. But his clinical picture or the physiological picture or the PFT remains the same even after 6 months. His FEV1 is to the tune of 21%, although with new criteria it is showing reversibility from 21 to 24, which is 15%. And the FeNO was still high, it is 36%. We do check these patients for other comorbidities, again, allergic rhinitis, sinusitis, nasal polyposis, GARD, there was a mild OSA, there was no bronchiectasis, IG, FeNO and AEC was still high. We did evaluate this patient for EGPA only by, ANCA profile. We were considering whether it is an overlap. Cardiac evaluation was also done, but patient now has developed diabetes and steroid toxicity because of the long-term therapy. So patient now developed new diabetes, bone pains, facial puffiness, cushigoid features, skin changes, and he came up with a research that can I have a lung transplant now because nothing is working which is available in India. And sir is smiling because sir and me is sharing this patient for the treatment, yes.
Actually, he's moved on to neurobiologicals.
Right.
You also know
so
that.
So the patient again find out that there was a trial going on in some hospital regarding tozorakimab on severe asthma, which was little surprising for me, but it was actually for severe asthma. But unfortunately, he was found unfit because of the recent PFT which was done in April, which showed again FEV1 of 18%. So again, patient came back that what to do now. He has explored the option outside also that there is dupilumab and there is other biological therapies which are available. We asked the patient to start on mepolizumab as a Swiss therapy because it is available in India, but he did not agree to this, that this is the same molecule as far as his own understanding that it is not going to do anything good to him. Somehow he managed to, procure this molecule from outside. This is tezepelumab, and we have given 2 doses of this molecule, although it is very early to decide whether the patient is getting response or not. But there are 2-3 things. Wheezing is mild, symptoms has markedly improved. His saturation, which was hovering around 93 to 94, is now 97. He's still using 10 milligram of oral corticosteroid. But 2 important things, I think, which is a bit of physical exercise. He enjoyed the marriage of his daughter. Sir and me attended that marriage also. And after this, when I was preparing this, I asked him for a PFT, but he was on vacation in an island. So probably the molecule is working good here, but we need to see further.
I think we need more data because he is now on tezepelumab. He's managed to get it from outside, and of course cost is a factor, but he can currently afford it.
So I think that's precisely tells us that if you do not pick up the right driver, you won't get the right answer, and then many drivers are not available in India. And this patient was exceptionally lucky that he could get this actually. I think on a compassionate grounds, it must have been brought into him. And it shows that actually, that there is a limitation, and very significant limitation, that the drugs are not available, which may be the more precisely placed for this particular kind of a patient. Dr. Rajbir Singh, any comment from you? Or you? Thank you, Rahul.
Thank you, sir.
We'll move on to the next before we take a comment from Dr. Rajbir Singh.
I think this is obviously a very terrible case of asthma. It doesn't seem to be responding to anything at all. And I think if we find that there is some clinical response to oral corticosteroids and the patient does feel better with that, we should document exactly what happens to his lung function then. Overall, there seems to be a decline over time. But I think at the time that he actually gets these higher doses of steroids, is there at least some improvement in lung function? I think that would tell us at least there is hope that some sort of medication would help. I don't know if that was documented while he was on, say, 40 or 50 milligrams of prednisolone every day.
So the patient is still on 10 milligram of prednisolone per day. So we haven't been able to get rid of oral prednisolone, and maybe the time will come for another new biologic which will be able to do this. We do not know right now. But I think that's a very important point which has been highlighted in this case, that how important is precision medicine, which requires choices like a buffet, which may not be available most of the times, and we have very limited choices in India. So I think our hands are tied. Many a times we are forced to use a biologic which may not be the most appropriate one, and end up with an incomplete or a partial response, which actually translates into loss of confidence among the treating physician itself that it's not up to the mark, right?
Right. I think we can move on to the next
Second case. Dr. Dhruv Talwar.
Good morning, everyone. So today I'll be presenting a case of a biological switch. The reason I chose this case is basically how should we decide when the biologic is not working, and what is the importance of phenotyping and seeing the comorbidities of our patient who are on biologics. So without wasting time, so I'm presenting a case of a 38-year-old male, obese, BMI 30, working in IT sector, never smoker, a resident of United States of America. And he was assessed in May 2023 for difficult to control asthma for 5 years. His history of mild bronchial asthma since childhood, and he used to take SOS treatment for the same. This family history of asthma in grandmother, history of prominent nasal obstruction, chronic rhinosinusitis with nasal polyposis. A high total nasal symptom score was there of 10. HRCT was done, it was normal. There was history of taking OCS burst for exacerbations with good response on the oral corticosteroids. He was staying indoors with worsening of symptoms during winters. The medications, he was on salmeterol with fluticasone twice a day with montelukast and levocetirizine during bedtime. He was also taking fluticasone nasal spray. He was using Asupra, that is salbutamol plus budesonide, 2 puffs almost 2 to 3 times in a week in a year. He was using 2 to 3 such inhalers a year. The indications of biologic, what we thought in this case was there was severe asthma with chronic rhinosinusitis. The patient was already on step 4 to 5 GINA. There was poor asthma control. The ACT was 19. So we did allergy workup. The serum IgE was 403 and the absolute eosinophil count was 390. ABPA was ruled out. SPT was done and it was positive for HDM, pollen and grasses. It was done in the United States. So this is a complete PFT which was done in 2023 for this patient, which showed a FEV1 by FVC of 70 and a FEV1 of 69% and a FVC of 82%. The DLCO was preserved and the TLC was preserved. There was some air trapping. So patient was actually on omalizumab now for 2 years and had 1 OCS burst this year for 7 days at 18 months after omalizumab. He was 80% better. He tolerated omalizumab well. Not much change in the nasal symptoms though. The total nasal symptom score was only reduced from 10 to 9. There was headache and heavy head trouble, much more, and interfering in his daytime work. There was history of 1 exacerbation as well. The lung functions were not checked in the last 2 years. So the baseline therapy was triple therapy twice a day using 2 to 3 times a week along with SOS short time therapy. And he was on nasal spray for his rhinosinusitis and now also on omalizumab. Now this is the repeat lung function and we can see the FEV1 has now improved to 84% from 69%. There's an improvement in the lung function and the FeNO has reduced from 140 to 36 over the course of 2 years. The IgE is still high, 673. So what are the unmet needs of this case? The patient wants actually no OCS usage and no life-threatening events. There's nasal symptoms continue to trouble him even after omalizumab. Subcutaneous immunotherapy, actually we thought of adding that, but the patient was also offered that, but he denied it. Omalizumab comes with the auto-injector, so it still goes to the ER taking injection twice a month. That was also an issue with him. But now the challenge in switching the biologics, first thing we thought was adding the sublingual immunotherapy or HDM therapy, which was denied. Now after that, we thought of switching the biologics. So which biological can match the patient's expectation? No adverse event requiring OCS. Only injection but no daily inhalers, which is complete remission without therapy after whatever period of biologics. Availability, prescribing indication and physician choice, these were the challenges. So the patient is actually from United States, so we even thought of dupilumab. Present status, the patient has a eosinophil count of 300, an IgE of 673, a FeNO of 36, FEV1 pre of 78% and the ratio of 72. This is after omalizumab. So the options which we had was IL-5 therapies, which are there in India, and dupilumab, which he can procure from the US because he's a resident there. So the patient was now actually advised to switch to dupilumab after 2 years of omalizumab with expectation of improving the nasal issues, no exacerbation, and a hope of remission. Complete remission of treatment was an unmet need of this patient. So why to switch biologic in this case? Partial response in the first biologic with chronic rhinosinusitis, which was unmet. Different mechanism of action of the anti-IgE versus the dupilumab. So we have already data from the Everest trial showing that dupilumab fared better than omalizumab in the nasal symptom scores and for the chronic rhinosinusitis, and that is what we have chosen. And the patient has been started on dupilumab and is currently in US and doing good. Dupilumab is very effective in T2 high with elevated pheno, which was also the phenotype of this patient, and also in omalizumab failed cases. And with low FEV1, patients also are a good responders to dupilumab. The patient also had associated atopy, which is also a predictor of good response. So that is what was chosen. So the lessons from this case is the suboptimal response to biologic is not failure, and differential effects on comorbidities need to be incorporated in the decision pathway to choose the biologics. Comorbid severe asthma with rhinosinusitis with nasal polyp is seen in severe asthma in 35 to 60% cases. Severe asthma patients continue to suffer despite good asthma control due to unaddressed comorbidities, which are a very important factor. Chronic rhinosinusitis with nasal polyposis in 45% of severe asthma is seen and leading to uncontrolled therapies with requiring frequent change in treatment.
So thank you, in a very interesting case, and luckily this patient was able to get dupilumab and had, of course, rhinitis which helped him, and there was initial switch therapy. So maybe just brief comments by Professor Wichner and Professor Bull. As do you think would you have followed any other approach?
I would have considered, since he's in the United States, tezepelumab, which I think would have worked just as well. And there's some indications that it could work better, but there's probably very little difference between the two. One of the benefits of tezepelumab is that it's monthly versus every 2 weeks. But I think either one would have been fine. The other component which I noticed, which we haven't talked about at all, was his BMI was 30. And we're seeing better and better outcomes in people with GLP inhibitors with weight loss that's benefiting their asthma. So that would have been another consideration on top of what you gave to treat the type 2 inflammation.
Yeah, but this case very nicely reflects also my clinical experience. We have a monthly ENT board with our ENT colleagues, and the feedback is very clear. If you have a dominating upper airway involvement, the two drugs which work best, as Mike says, is tezepelumab and dupilumab. So when we have dominant upper airway symptoms, we always consider dupi or tezepelumab.
Right. I think, thank you very much. Professor Rajveer Singh, any comments from your side?
I think to summarize, this patient has predominantly upper respiratory symptoms with asthma not being a problem. So he is on kind of intermittent treatment with inhaled medication, and he's on regular nasal spray. Did we see actually a CT scan of his paranasal sinuses?
Yeah, so CT scan of the
I don't remember seeing that. But if you did have that, and if it shows a lot of nasal polyposis and structural changes there, I don't see how we can avoid surgery. I mean, despite the biologics and topical steroid, you might still require some sort of intervention there.
Yeah.
Yes, I think this problem was related to the upper airways as much as to the lower airways. So I think a very interesting case and good learning. We'll move on to the next case now. Thank you very much. The next case is by Dr. Suresh Sagadevan.
I think this case which Dhruv just presented actually was very curious to us that, why omalizumab was only being given to this patient. So I do not know, is in the US system, if you are under an allergy specialist, you may be channelized into that kind of a practice. Does it happen that way?
No. You can see who you want. You'll either see a pulmonologist or an allergist, but I think in the United States now, allergists are just as likely to give a non-anti-IG therapy as a pulmonologist.
Yeah, very good afternoon to all. At the outset, I would like to thank PACS for the opportunity. So I think we have heard a couple of good biological switch. Today, I'll be talking about the most important things as the Indian perspective. As we all know that once you start the biologics, how long we need to continue the biologics. And I think not all Indian patients, they will be having insurance. So this particular case is actually, it's a farmer and he's a self-pay patient. So I convinced for the biologics for 6 months. And then later what happened, that's what I'm going to talk about. And moving forward, how we can improvise our day-to-day practice. I mean, in case if the patient doesn't have the insurance and other stuff. So without wasting much time, I'll move on to the case. So this is a 58-year-old gentleman who is a non-smoker and non-alcoholic. It's a farmer by an occupation. He's been bronchial asthma since last 25 years with a BMI of 26. So he's been frequently hospitalized with bronchial asthma, and the last bronchial asthma exacerbation also has happened 2 months ago. So his present history, if you look at the initial asthma, it was managed with only oral drugs with the mild symptoms, and sometimes you will often take some nebulized bronchodilator from the next door physicians. Since 2009, he had a recurrent asthma exacerbation and a course of OCS burst like almost 3 to 4 times per year. And if you all know that even some short burst of oral corticosteroid in a year, if you see that, even that also can cause a lot of steroid-related toxicity. And often he gets asthma precipitated by viral infections and then weather changes also. It's one of the major risk factors for this exacerbation. If you look at the drug compliance and the inhaler technique, it's an acceptable limit. And then he also had GERD symptoms. So if you look at the past history, since he has been last 10 years, he's requiring frequent burst of oral corticosteroid. Since last November 2024, he was started on oral low-dose Vizolone, 5 milligram per day as a maintenance dose. And obviously, once you start the steroid, what will happen? The patient will try to put a lot of weight. So patient was already is on single inhaler triple therapy. So indacaterol, glycopyrinum, mometasone combination along with montelukast and fexofenadine. And doxorubicin also has been started with oral prednisolone of 5 milligram once daily. If you look at the comorbid condition, since 2020, patient developed a diabetes, non-insulin dependent diabetes mellitus. And then patient also had a coronary artery disease in 2023. For that, patient underwent a PTCA. And because he's been taking oral corticosteroid for longer duration, patient also had severe osteoporosis. The DEXA scan also showed very, minus 3.9. And if you look at the quality of life, you know, the ACT score was only 11 to 15 despite on oral corticosteroid. And then he's having frequent hospitalization, and in the last 10 years, if you look at the hospitalization cost itself, it's going to huge compared to the biological cost in India. So he's been fully vaccinated with flu and pneumococcal. Even COVID-19 vaccine also has been done. CT chest showed mild bronchial wall thickening, and the echo also showed normal. And if you look at the eosinophil count, the almost absolute eosinophil count was 950 and IG was 890. We worked up for ABPA and everything was normal, and the HbA1c was 9.8 and ANCA negative. The PFT showed only a FE1 of 25% with a good reversibility of 20%, and the FeNO level showed 58. So the summary, so as we all know that I think we have been diagnosed as a severe adult onset of asthma with the T2 level was very high, FeNO also very high, and then with high serum eosinophil count and high IG level. So in this situation, I think of late, often we are seeing this kind of overlap in our day-to-day practice. In your experience, which is the ideal molecule to start this either you will go for omalizumab or benralizumab, sir?
I think the question is being addressed to Professor Richard. Okay.
So this, it's really interesting. The first case and this case have some similarities. And the key question, or the key problem here is that we are always trying now to play catch up, which with this case has moved on. This case is now is big problems. He's got comorbidities because of the oral steroids. He's developed multi-morbid disease, and his airways disease has continued to decline. And so, yes, I think he should receive biologic therapy. Yes, I think he's a good case for it. But I worry that we are too late because his lung function is now in such a bad way. The reversibility component, the reversible component, because of probably small airways, these gas trapping, and the development of microfibrosis that we see over time and airway thickening will be a massive problem, which biologics will not address. So yes, I absolutely agree, as a way of getting him off the steroids, preventing the comorbidities, and yes, improving his attack rate, benralizumab would be a great choice to start with and see where that goes. Again, I'm cautious, just like the first case. This is really difficult because it's now too late. And I think that's one of the really tricky things with someone who's been, I'm not going to say mismanaged, but not optimally managed for years before, and picked up too late probably as well from the very beginning. So that would be my thoughts.
So mepolizumab may be the answer in this question to start with. Benrali, okay.
So thank you, Suresh, for that nice presentation. My concern here is whether this patient really has had an adequate trial of inhaled steroids and inhaled medication, because from what I gather, I think initially he was on intermittent oral steroids and not really taking anything else. And I think
he was already on a single inhaler triple therapy, sir. He has already been taking inhaler for quite some time.
Was he taking it adequately? Was he regular? Was he taking an adequate dose?
Drug compliance and adherence good, sir.
And despite that, he needed those
Despite
oral
that,
steroids.
he is having a repeated exacerbation. Because being in a farmer, he exposed with a lot of dust and then other things. So often he will come up with the exacerbation risk. So that is where we were discussing about the biological. Because he don't have any insurance. So I convinced him for at least for a trial of biologics for 6 months. You can try with that. So I offered him for benralizumab.
Yes, usually what I find is that you need to be objective about the, you have to document the actual lung functions as he takes the treatment under direct supervision. It may be oral steroids or it may be inhaled steroid. We often find that people don't take the medication regularly or the technique is incorrect. I don't know whether he was using a spacer when he was using an inhaler, and all these things, there is some room for improvement in most of the cases. And if we have done all that and the patient is still not well enough, I think you're justified in considering the biologic. But it's prohibitively expensive in India, and I'm not sure if this man is going to continue with that beyond a few weeks.
Personally, I used to check for the inhaler technique for myself.
Of course.
Once I convinced, then only I can
Suresh,
change.
you have done that because it's in the standard protocol which you have done. Now, only question is, what are you going to look for in this patient? Like, what are the expectations? So, your expectations and patient's expectations. And that's what Professor Bull said.
Yes.
That it must match and it must follow it up. So, like, what he wanted and what you wanted.
So
for
basically, he already had a poor quality of life, and then he already is taking a lot of oral corticosteroid for so many years, and he has already put a lot of weight, and patient already developed a cardiovascular disease and also diabetes. So osteoporosis, the most important steroid-related side effect is osteoporosis. So these are the major concern for the patient is concerned. But now, how are we going to improve this quality of life with the currently available biologics? Since he's already having an overlap also. So we are just going for the benralizumab. So basically why I choose this slides.
Switch the screen, please. And in the meantime, okay.
Yeah. In November 2024, so I have been started this patient was on benralizumab. So patient that time he was taking 5 milligram per day for as an oral corticosteroid as a maintenance dose. So after starting benralizumab, the baseline FE1 was 59 and 0.79, and then FeNO was 58. So if you look at the 6 months down the line, it's continuing to take the oral corticosteroid and then they can able to reduce from 5 milligram to 2.5 milligram. And then FEV1 has been slightly increased. I would not be very convinced with the FEV1 because I think once, if you see this much FEV1 level low, so we may not able to appreciate the lung function. It's drastically will improve like other things. So at least if you can able to maintain the lung function, I think it's very good with the biologics as concerned. But now one concern is, so after 6 months, patient is exhausted. I mean, you don't want to continue because of you don't have insurance. So in that situation, patient also had one exacerbation with the viral infections. So that time he already missed 5 months of benralizumab dose. But now, how will you approach? So these kind of the patient has taken one course of biologics, and then due to cost factors, so he has stopped taking a biologics, and then patient already had some viral infection. That again is put oral corticosteroid rate also has been increased. So because these are the challenges we are facing in our day-to-day practice, because not like other Western countries where all the biologics will be covered under insurance, so patient may not be worried about the cost. But as Indians, so we have a lot of challenges and a lot of barriers to continue for quite some time. But again, I think we had a discussion with Talwar sir also during one of the biologicals meeting, because this particular patient, they have denied for insurance. So and then sir has given the one insurance company person. Then I personally have taken the effort to convince a patient for the insurance. Then again, patient has taken now insurance somehow. Now patient has been continuing to biologics. Now he has been again responding to the biologics, and the FEV1 has also been slightly improved from 0.79 to 1.02 liter. And the FeNO also has been continued to in the decreasing trend. So since, before yesterday also I given that biologics for that particular patient, and then only I flew back to Delhi. So now,
I think you brought such a beautiful case that these kind of situations, which in India are not explained rest of the world, basically, He gets it for 6 months, and then he goes bad, and he gets admitted, and he's refused, and then he restarts. So your patient is a responder. There's no doubt about it. Your expectations and his expectations are met. But the insurance expectations are not met. But I think in this hall, I would like to say this. Like this patient, we helped him out through the insurance, because insurance companies listen to when you talk to them. And we have a very good system in our setup where if any insurance is denied to the patient and they have a valid insurance, there are people who will walk from the backhand and get the insurance done like it was done for this. Thank you very much, but I'm telling you this thing very good. If patient has insurance, they must pay for it. There is no question of denial out there. We just accept that it is denied. It should not be denied. Why? Is it a disease for which he is supposed to suffer and get exacerbations? We explain them, the insurance companies, that if he gets admitted, the entire cost of the injections for 6 months will be there. You are ready to pay for that? They understand that. I think this is the time we need to really fight. Thank you, Suresh. You brought this a beautiful point, that insurance cover is there and still it is not covered for the patients. Like, what's the point? Right now, I can tell you, there is only one insurance in India which does not cover for biologicals in severe asthma. Rest, all of them do. And that one is already under the task being taken, and they will also be covering it very soon.
Is it a star insurance, sir?
Wonderful. It requires a big hand of applause for all the 3 case presenters who brought the difficulties. And every case had its own peculiarity.
Interesting cases which had their own challenges and also very much relating to what we see in our own country. So thank you very much to all the 3 case presenters for very, very interesting cases. But I think we've run out of time and we should move on to the next session. The next session is also very, very interesting because it's opening new frontiers as we look at managing our patients in chronic obstructive pulmonary disease, and that is biologics in COPD, evidence and the future. I think it's something very, very exciting and interesting, and to some people a little controversial as to should we move in this direction or not. And we have an excellent speaker for this, Professor Mona Bafadil, who is basically chair in respiratory medicine, King's College London. She is the director, King's Centre for Lung Health, and consultant respiratory medicine at Guy's and St. Thomas NHS Foundation Trust, UK. Internationally recognized in COPD, severe asthma, eosinophilic airway disease and biological therapies, and the recipient of the European Respiratory Society Gold Medal in COPD, and NHR research professor, and has done a lot of pioneering work on blood eosinophil as biomarkers in COPD, influencing international guidelines in biological therapies.
Thank you very much for the introduction and for the invitation. Unlike Richard, this is my first time to India, and Delhi has been wonderful, so thank you very much. So we're going to move from asthma to COPD, and I want to highlight one point before I start, is that this is really important. This is a real opportunity, and COPD is a much bigger problem than the population who have severe asthma that need biologics. So I think that this will be an opportunity for us to improve outcomes for our patients with COPD. And I know COPD, like the rest of the world in India, is indeed a very big problem. These are my disclosures. So maybe to start with the evolution of management of COPD across many decades, as clinicians in the room here, we will have seen this evolution of our treatments. But our treatment approaches, particularly with inhaled therapies, whether it's single inhaled therapies, bronchodilators, or dual bronchodilators, or indeed anti-inflammatories, our treatment approaches have been really about impacting on symptom control. And we've tried to prevent exacerbations with our treatments, and we've got some success with our inhaled therapies. But actually, we've still been focusing on symptoms for driving our therapies, as opposed to altering disease trajectories, as opposed to altering disease progression, and perhaps not being able to completely impact on premature mortality. So we've now got to the latter 21st, the latter years in our 21st century approach, and I think we're really in the space of where we can try and impact on these things with the advent of biologics in COPD. Our approaches are now about treating and targeting comorbidities like cardiovascular disease, which is incredibly important in patients with COPD. As I mentioned, we're trying to think about upstream pathways and biological approaches for altering disease trajectory. And by understanding inflammation and immunity in COPD, we can directly target underlying disease mechanisms. So I'll start off with why actually characterizing the endotype or the mechanism that may be driving the inflammation in COPD is important. Firstly, we know that not all COPD patients are the same. We have a label, which is a very big diagnostic portfolio of chronic obstructive pulmonary disease. But actually, intrinsically, there are multiple differences, even in the characteristics or the symptom presentations of a patient that presents. Our patients can actually have the same type of clinical phenotype, i.e. the clinical characteristics that we would see in clinic. But the underlying inflammation or biological mechanisms that might be driving the phenotype can be different. And so this endotyping allows us to think about how can we be much more precise, much more targeted in our approaches to improve clinical outcomes. So we first learned about endotyping the biology of COPD from what happens at COPD exacerbations. This is work now from over 15 years ago, that when we sampled the airway and we measured sputum eosinophil count, we measured sputum neutrophil count, and we measured serum sputum airway biomarkers, so cytokines and chemokines at the time of an exacerbation, we can see that there was an upregulation and much more inflammation going on. But we could characterize the exacerbation according to the majority of which inflammatory driver was predisposing this exacerbation. There's a large group of patients who have a lot of type 1 inflammation, a big driver from either a virus, for example, which we could see that was elevated in levels of interferon responses. We had exacerbations that had lots of TNF and a pro-inflammatory signal, our type 3 inflammation, which we could also detect that a few days later they would have bacterial cultures that were positive in their sputum. And then there was this group of exacerbations that also had type 2 inflammation. So high levels of IL-5 in the airway, higher levels of RANTES in the airway, and we can detect these by measuring the peripheral blood eosinophil count. So actually we learned about the airway biology of COPD was not all the same when we looked at the exacerbation features. And this has led us to now really understand that immunity in COPD is not all the same. And we've learned about type 1, type 2, and type 3 immunity. The most information we have at the moment is along the lines of the type 2 immune pathways for COPD. Why? Because we've got the targets, having handed them down from asthma, that we can therapeutically test in patients with COPD. So we've been studying biologics in COPD as a chronic maintenance treatment for quite a long time now, actually. It's not just in the last few years. And I'm going to just go over a few of the studies and how long we've been doing it for, and perhaps also give light as to why we've not been so successful. So I'd like to split this up into 3 eras. The pre-endotyping era, where we assumed every COPD patient was the same, therefore we used the biologics to treat them in the same way. Then there's the partial endotyping area, where we learned a little bit from asthma, but we didn't go full hog to really try and push our precision at the time of COPD treatment. And then there's our real current endotyping era, where we've got it almost right. So in the pre-endotyping era here, you can see that we've had studies from 2005, 2007 that have looked at different therapies, mainly targeting perhaps type 3 inflammation for COPD. They've all been in phase 2 trials. They've been largely negative for their primary outcomes. And actually, there's been no subgroup analysis in these trials to see, well, which group did the worst and which group did the best, so that we can learn more about this pathobiology of these mechanisms. These medicines may work, but we just haven't worked out who they may work in. And perhaps if we endotype them, we might get better success. And maybe there's a future where some of these medicines will get resurrected and be tested again in a precise endotyped way. The some endotyping area, well, here we took data from the asthma studies, and we proposed to do similar finding in the COPD studies. We started with a phase 2 early in 2014 using benralizumab, but we endotyped the group using sputum eosinophil counts. And we heard earlier that actually what happens in the airway in your sputum may not necessarily be the only driver of your eosinophilic inflammation. We had the mepolizumab studies, and we also had the benralizumab studies in phase 3 trials. And they were only partly endotyped, so the eosinophil count was not that high. And equally, not all the patients were already on maximal treatment. And unfortunately, this kind of halted our progress for many years, because as you can see in these large clinical trials, the phase 3 trials for mepolizumab and for benralizumab were negative, as was the phase 2 for benralizumab too. However, in post-hoc analyses, which we started to get smart about, we can see that there were a subgroup of people who had the best response to these biologics. Those on maximal inhaled therapy, still exacerbating, and with higher eosinophil counts. We had a pause of what to do for biologics, as the last study was negative and published in 2019. And now we get to the endotyping era. This is the era where we should really get really excited about. The dupilumab studies, Boreas and Notus, were the first to really just go for the group that were going to have the best response with COPD. Patients included had to have eosinophil counts of 300 or more in the blood. They had to have had 2 exacerbations with oral corticosteroid treatment or a severe hospitalization in the last 12 months. They had to be on maximal inhaled treatment, so triple therapy with dual bronchodilators and inhaled corticosteroids. And they wanted patients to have a chronic bronchitis type phenotype, but this was reported by the physician and patient reported, not a purely diagnostic format. And as we know, on average, for their primary endpoint of reducing in exacerbations, the Boreas and Notus studies on average reduced exacerbations by 30% over and above placebo on top of standard of care and maximal care. This is really exciting. And in the UK, we've only just had our national clinical provider allow us to prescribe dupilumab for eosinophilic COPD. On the back of the first two negative trials, the METRICS and METREO data for mepolizumab in 2017, we have the MATINEE study, also recently published last year, looking at mepolizumab, again in the similar population to the Boreas and Notus studies, eosinophil counts of over 300, at least 2 moderate exacerbations or 1 severe exacerbation on triple therapy of ICS, LABA and LAMA, and they had to have lung function between 20 and 80%. The MATINEE study also gives us 2-year data because they extended the data because this was all recruited during the pandemic and they wanted to reach the number of events. MATINEE was also positive for its primary outcome of reducing exacerbations. Unlike the dupilumab studies, MATINEE did not impact on the secondary outcomes like lung function and quality of life. In the UK, we have now just had approvals to prescribe mepolizumab for eosinophilic COPD. So this is really exciting in that we now have additional treatments for our population who is still exacerbating despite maximal and optimized clinical care. Now, we heard it earlier, I think Mike Veschler mentioned it. It was a little bit dismissive of eosinophils in COPD. I don't think we need to be dismissive of anything in COPD because our patients have a problem and our treatments don't always work. Eosinophilic COPD is an important endotype in COPD, and we have to be advocates for our patients with COPD, like the asthma clinicians are advocates for their patients with asthma. Is type 2 inflammation important in COPD, I guess is the question, because of the recent press release for the Resolute studies, which was a bigger trial looking at benralizumab in COPD with a similar features, eosinophils of 300, at least 2 moderate exacerbations or 1 severe, and at least triple therapy. Now, none of us have seen the publications for the Resolute studies as yet, but we know the press release said it was a negative study. I would say that type 2 inflammation is important in COPD. It just depends on when we give it to our patients with COPD. So here's a hypothesis for you that I've been thinking about. You can see here that in the dupilumab studies, the FEV1 was between 30 to 70%. So not very severe COPD. In the MATINEE studies, the FEV1 went down to 20%, and approximately 15 to 20% of the MATINEE population were very severe COPD. In the Resolute studies, their FEV1 was less than 65% predicted, which suggests to me that perhaps the majority of patients in the Resolute study were perhaps more severe and very severe COPD. Now, I think we're going at the right pathway, but maybe with Resolute, they went it too late. When there's too much damage, when there's things that you cannot reverse, then how are you going to get the benefits? And this is why we need to think about how do we go further higher? How do we push boundaries for disease progression and altering that trajectory in COPD? And that will be very important. So we await the Resolute data, but I would hypothesize it's going to be a group of very severe and severe patients, much more higher than in the MATINEE and the dupilumab studies. It's a little bit like saying as a diabetologist, I'm going to treat your diabetes, but only once you've had a vasculopathy and your leg has been amputated. We don't do that in other disciplines. We seem to think that that's the approach in COPD, and I'm not sure that's the right one. So as I said, in the UK, this is our license for dupilumab, and it's very similar for mepolizumab too. Patients on triple, high eosinophils of 300, and at least an exacerbation history. And similarly for mepolizumab. We now have decisions with our patients and shared decision making as to what their preference may be when we get these treatments provided. What else might be coming in COPD? Well, there is still a plethora of stuff to look at. We know that there's lots of studies, randomized clinical trials that have been looking at alarmins in COPD. So you will have seen the recent astegolimab publications, the ARNASA and ALNASA studies published in Lancet, which looked at the ST2 receptor blocker, which is kind of a little bit upstream of the IL-33 pathway. We have mixed signals for the astegolimab data set, with one phase 3 trial being positive, the other being negative. And they've not used any eosinophil count or endotyping biologically. They've used clinical phenotype to allocate population data sets. Ipilimumab, another IL-33, still in press release from a couple of years ago, the ERIFY-1 and ERIFY-2 study, also did not use an endotyping approach for their patient population, used a clinical phenotyping approach for their population to be included. Again, showed mixed, where one study was positive, one study was negative. And then we have the tozoricimab studies, which in press release earlier this year, a few months ago, said they were positive. We have not seen any of the data, and we believe they will be published in the ERS next month. So we will have a lot of information from the IL-33 pathways and programs in COPD. And I would hope that come next year, there will be another pathway of biologics as opposed to just type 2 inflammation for COPD patients. So another armory to our patient approach. And then if for interest, there's still more to be studied. And these are the following clinical trials that are currently open and recruiting globally for patients with COPD. And so we would hope that in the next 12 to 18 months, there will be more treatments and more data endpoints to be studied to work out which population, what treatment, and how we can really impact on improving outcomes and premature mortality in these patients. I would say that the COPD biologic pathway for us in the UK, and perhaps also closely here in India, is that really it's about shared program and decision making, identifying the right population, and ensuring that the other clinical features and the other programs of care are also optimized. And finally, I'm going to move on to exacerbations of COPD, because this is where it all started for me when we identified the eosinophil count as an important biomarker for COPD, which has led to all of these phase 2 and 3 clinical trials. We know exacerbations are a big problem. On average, there's one exacerbation every 20 seconds. In the UK, one person with COPD will die every 20 minutes. We treat exacerbations in very much the same way, antibiotics and steroids. No real patient selection, no endotyping, very much a one-size-fits-all approach. And we know that one-size-fits-all is not precision medicine. We haven't had any new treatments for COPD exacerbations for well over 50 years. And we know the oral corticosteroid burden is high, with the treatment effect of being very short. We heard earlier from the case histories of how much comorbidities repeated courses of corticosteroids do to patients in asthma. This is not any different to patients with COPD. And in fact, data now, epidemiological data, is showing that even 2 courses of corticosteroids in COPD increases the risk of mortality. And so this exacerbation and this precision of giving corticosteroids is really leading to more comorbidities and problems for our patients. We also know that a short course doesn't prevent you from having another exacerbation in 6, 12, 16 weeks, for example. So our treatment failure rates are high. So we thought, well, maybe we could think about moving to the 21st century for treatment of exacerbations, especially as now we've moved for biologics at chronic treatment. Maybe we could think about this in an acute treatment, learning from what has been done in terms of rheumatology, where we've stopped corticosteroids systemically for any acute rheumatoid flares, for example. Richard mentioned the ABRA study, which was published last year now, which was a proof of concept phase 2 trial, where patients who had eosinophilic inflammation at the time of an exacerbation were randomized to 3 arms, which included a biologic benralizumab arm alone, or a prednisolone alone arm, or a combination of both the biologic and the steroid. The biologic injection was given once, the steroids were given for 5 days. And we wanted to see how this would improve reducing treatment failures, so retreatment, new exacerbations, death, or improving symptoms as a co-primary endpoint. This proof of concept study was highly efficacious. We showed that we can significantly improve symptoms with a single injection of benralizumab compared to steroids, and we can improve treatment failure. So the time to next treatment failure was far longer when you had a biologic on board as a single injection compared to 5 days of steroids. This was a 4-fold improvement and has never been shown before, and actually allows us to think about perhaps the next thing, the next real focus point for treating COPD patients. And whilst this is a little bit small, you can see that all the points on the chart here are to the left, favoring benralizumab. It didn't matter how old you are, it didn't matter how bad or good your lung function was, it didn't matter whether you were a smoker or a current smoker, it didn't matter whether you had asthma or COPD or both. Benralizumab was better, the standard of care for acute treatments of exacerbations. Of course, this is all in a phase 2 trial, it's not a guideline approach, and actually what we need to do is we need to encourage our colleagues outside to think about pushing forward the next clinical trials so that we can really deliver better care for our patients with COPD. And finally, there have been other trials looking at biologics as an add-on to standard of care. So not comparison like ABRA, but adding it on after people are being discharged or after they've had their corticosteroids. And some of these studies are listed here, some have been published, some are still recruiting, and some are about to open. So this will be an area, I think, in the next 2, 3, 4 years that will start shaping and changing for our patients, and perhaps we can even consider stopping corticosteroids altogether. So to conclude, I'd like to say there really is a place for biologics in COPD at chronic treatments. The mixed efficacy that we've seen across the last 2 decades is because COPD is a complex disease. It's not because it doesn't work. It's not because the patients don't need it. It's because it's a complex disease. It's not asthma. Patients do have a problem with these pathways and this inflammation with COPD. We can see now from the trials that have been published so far, the dupilumab studies and the mepolizumab studies, that type 2 inflammation is a pathway that we can target. The resolute studies with benralizumab being negative only tell us, perhaps, that it's because we targeted them too late. And we will see what the results of the resolute population look like when that data set is published. We've got some information now about IL-33 and other pathways. We haven't got it all published yet. So awaited trials will shed further light into understanding the immunopathobiology of COPD and mechanisms. And I think the future has to be, how do we think about biologics at acute exacerbations? How do we think about type 1 and type 3 immunity, and what future potential targets do we have there? And then how do we really move the dial so that actually we can prevent exacerbations from happening and altering disease progression and disease trajectories? Thank you very much for your time.
Thank you very much. I think very, very exciting time and for COPD patients, and very interesting talk, both for patients who are not doing well and as a part of acute exacerbation of COPD, the role of biologicals. And I think that seems to be the way forward. And also the fact that starting early would probably make a better difference rather than waiting too late in our COPD patients.
For the panel, we'll request Dr. Pramod Dedish, Girish Agarwal, Dr. Rafi, Lansert Pinto, Pankaj Chabra, Dr. Rohit Kumar, Dr. Shafeen Babu, Dr. Gurpreet Singh. Now this is an exciting time. After a lot of discussion on asthma, now we are on COPD and we have a hope at the end of the tunnel. Mona has brought in a beautiful data today to suggest that one biologic at least we have right now, and another one is going to be added, and then maybe there is a brighter future out here. So I think excellent to start with the discussion. Over to you, Randeep.
So I think we have a lot of panelists and they have a huge experience in managing COPD. So maybe they would like to start off, maybe Nagarjun, who is basically our moderator, can really ask the panelists, and maybe we can start this talk as to what is their thought process in our setup in terms of using biologicals in our COPD patients. We have a huge burden of COPD, and we have a lot of non-smoking COPD also. So where do you think biologicals would fit in? Mepolizumab is already available in our country. So do you think we should start using it in our COPD patients who are not responding? And we have many such patients who, despite being on triple therapy, continue to come with exacerbation, are on steroids or need bursts of steroids. So we'll start with you, Dr. Nagarjun, you can then ask the others.
Thank you so much, sir. So as you had very rightly put it, so India is the capital for COPD. So we have a huge burden of people with COPD who are already on triple therapy, who would still be symptomatic, who would still be exacerbating, and who have basically no other option. So they are basically people who are waiting for some form of therapy which can make their lives better, something which stands between them and the lung transplantation. So that is why I think there is a scope, definitely a scope for biologics in COPD. But the problem which we see in our day-to-day practice is the number of people who are actually eligible for biologics. Because in India we don't have dupilumab, we only have Mepoli. And it is approved only in eosinophilic COPD, exacerbating COPD. So that is a small percentage of them. We have started using Mepoli in a subset of patients with eosinophilic COPD, and some of them did actually have a decrease in the number of exacerbations. But I would say our experience is very, very recent, and I think more Indian data is needed before we can strongly say. So I can request the panelists also to share their experience in managing COPD with biologics in our country.
And sir, one thing, I think in the morning it came up, and after the entire data which Mona has already presented, why benralizumab failed seems to be that it was a different subgroup of patients. Just clarify for people here, because they think that one is approved, the second one lost it. Due to what? So is it like the baseline fault or something else?
Yeah, I would say that whilst we haven't got the full data set yet, it's not been published. If you look at the clinicaltrials.gov where the protocols are listed, you can see that in that group, the FEV1 inclusion was less than 65%, which means they would have included people with less than 20%, less than 30%, less than 40%, less than 50%. Whereas actually the dupilumab studies were from 30 to 70, and from the mepolizumab studies from 20 to 80, which means it is likely, with all probabilities, that the population was just much more damaged in terms of FEV1 deficit. Because the biology is the same. It's just the damage maybe was too much. I mean, we will see this, but I think you're right, Deepak, in that it's the baseline inclusion criteria that probably was the problem.
Well, I think we need the data to really be able to show,
Correct.
because we don't know what was the mean FEV1 of the entire group. It's just the inclusion criteria that we're looking at as a cutoff. And so, Dr. Pinto, you wanted to say something. The other thing that I just wanted to ask the panelists was, how frequently do you look for eosinophil count in your COPD patients, and what is your feedback into what is the percentage of patients who you think you could phenotype into those who have high eosinophil? And we do that in asthma. How frequently do you do it now in COPD?
Regarding the first question which Nagarjun asked about experience of biologicals in COPD. So I remember I had a case and we have a discussion with Dr. Talwar sir. She was a mid-60s, 70 lady, bilateral bronchiectasis, and this time she was admitted with exacerbation, right? And it has been almost 2 to 3 weeks that we have been managing her exhibitions on NIV, antibiotics, steroid. Nothing was working. We were not able to wean her off NIV. That was the time we thought of biologicals. And we don't have choice in India. She was not eosinophilic. So I discussed with Dr. Talwar sir, and we got it from Dubai, tezepelumab. And we got a 2 vial of tezepelumab, 420. 210. And simultaneously, we also got 2 cough assist machine. One was the physio assist and one was the cough assist. So all these 3 we started on the same day. Fortunately, all these 3 arrived on the same day. And we gave her a shot of 420 tezepelumab, physio assist and cough assist. And I don't really know what worked, but within 48 hours, she was off NIV. So she, with the physio assist and cough assist, she produced and threw out many dirty sputum, and her inflammation got settled. So something worked, probably tezepelumab, probably the cough assist. There was another patient, again, old lady, and similarly, means she has been exhibiting a lot. We did everything, almost 2 to 3 weeks of exhibition. She had a eosinophil count of 250 around on steroid, which has been going on for the past 2 to 3 weeks. And there we tried bernalizumab. But we didn't give bernalizumab at a dose of 100 milligram. We just gave a 1 shot of 30 milligram, right? Because of many issues, financial issues and everything. But even 30 milligram worked. And her exacerbation got settled and she was subsequently discharged. Though 3 months later, she again got admitted with exacerbation. This time it didn't work. Right? So this is a 2 patient recent in the past 6 months which I had an experience of biologicals in COPD. Coming to your second question, yes, a COPD which is not responding to SITD, we do try to look at the eosinophil count. Yeah, we do. But one more question is, in asthma, which is a non-allergic eosinophilic asthma, the ICS doesn't respond as compared to the oral corticosteroid. But we do say that in eosinophilic COPD, which is a different inflammatory pathway, ICS responds, and the GOLD also recommend ICS in adding all those frequent exhibitors. So I think we don't know what actually we are dealing with in COPD eosinophilia.
So, yeah. Can I ask a couple of questions? Prof. Mona, thank you for an excellent overview. I had a couple of questions. So, there was an understanding from your talk that there is potentially something like a burnt out COPD where you're reacting too late, right? Given by the fact that the FEV1 was 65% in the study that failed. Do you think there are early biomarkers that could kind of predict so we could intervene early? So for example, a rapid decline in FEV1, for example, do you think that would be a useful predictor? So we just did a study in healthy adults in Mumbai, and we found that close to 60% of people are rapid decliners more than 60 mils per year, and these were normal subjects. So do you think there would be similar cutoffs for patients with COPD? And the second question is, do you think there are biomarkers that could guide us, for example, nitric oxide and eosinophils guide us for the type 2? But what about the non-type 2 COPD? Do you think there are any potential biomarkers we could look at?
Yeah, no, thank you very much for your questions. So in order to be able to alter the disease trajectory, I think we are stuck at the moment because we look for airflow obstruction. We've lost a huge amount of small airways. How do you reverse something when you've lost it? I don't know. I haven't worked that out yet. I don't think any of us can. So there has to be some other, we've got to start thinking a little bit outside the box. So we've got tools. We've got, oscillometry. We've got imaging. We've got multiple measures of FEV1 showing decline. All of these things I think we need to think about so that how do we direct our treatment earlier? Unfortunately, we're just limiting ourselves at the moment by saying we're going to look at exacerbations as a primary endpoint and we're going to look at the FEV1 for their inclusion. So you get a little bit stuck. You can't improve when the things that you're trying to improve means that someone's already damaged to start off with. So I think our thinking for COPD treatment and management needs to change. I think, when we look at GOLD, there is some little approaches to trying to change that, but it's not enough yet. I think as a community, we do need to think about that. To your second point, yes, we have the eosinophil count at the moment. I think to add, the eosinophils are not the same as they are in asthma with COPD. They are different. And we know there are subtypes of eosinophils. So we've still got to get that a little bit better too. Exhaled nitric oxide has been looked at in COPD. It's not routine as part of clinical care. And the data, we need more data. I would say for exhaled nitric oxide is that there probably is a place for it, but exhaled FeNO is lower the older you are, it's lower if you smoke, and it's lower if you have chronic infection, so colonization. So we just have to use these parameters in reflecting the understanding. It's not going to be the same as asthma. It's probably a lower threshold, and we'll work it out at some point. For type 1 and type 3 immunity, we haven't got there yet. And we're starting to look at maybe looking at the lymphocyte-neutrophil ratio. But I think we could go a little bit further once we do some more mechanism studies to understand that group. So my hope would be, yes, we need to do all the things you said.
Do you also think we need to lower the exacerbation threshold? Because GOLD has lowered it for defining an exacerbator. Do you think that threshold for biologics also maybe should go down?
Yeah, I mean, I think so. Listen, for data across the world shows there's a 10% mortality if you get admitted to hospital with a COPD exacerbation. The readmission rate after discharge within 90 days is like 50%. That's flicking a coin. That means our treatment is not really very good. People who have a moderate exacerbation in the community, they have a 5-fold risk increase of an MI within 30 days. Still increased risk after 1 year. So exacerbations are bad. We would never allow a person to have a heart attack before we started treatment. So I think we need to start thinking about these are things we need to eliminate. And that means treating better, diagnosis earlier, all of the things as we've heard today.
Thank you.
One question can I ask? In COPD patients, when you put them on biologics, what are the chances of remission in COPD? And for how long we will continue biologics? Because in asthma, we are witnessing that remission is there, and then patient discontinue the therapy biologics for 1 year, 2 years. Yeah. Again, we restart that. Yeah. But in COPD, it's a very, very difficult to expect that remission.
Yeah. I mean, it's a very important question. Unlike asthma, we haven't got definitions of remission yet. We haven't got definitions of clinical stability. We haven't really got that yet. There's work to be done on that, but at the moment, these are concepts for COPD, not like in asthma. I think we should start making sure that we frame it properly. But as I said, our problem starts with the fact that we diagnose it like when we're expecting half your volume, your small airways, to have been destroyed. So how do you get improvement in that? That's the question we need to keep thinking to ourselves. I suspect, maybe after we've all retired, COPD diagnosis is not just spirometry. But I would like it to happen before we retire, because there's a lot of patients to treat. Yeah?
Thank you.
So I'll just take it forward from the previous question about assessing response to a biologic in a patient of COPD. So when we talk about asthma, I think a 50% reduction is considered the bare minimum to call it as a partial response. But whereas in COPD, if you see the data, 20 to 30% is the max. So this is a very important thing which I think we have to understand, the patients also have to understand, that you don't expect a very magical response when we start a person of COPD on biologic. So this is a general discussion anybody can answer. So how do you say a biologic has worked in a patient of COPD when 20% is the max decrease in exacerbations?
Yeah, I mean, maybe if I come back to that point. Because a patient with COPD dies from an exacerbation, has a risk of dying, a much higher risk than in asthma. People with asthma rarely die, luckily. People with COPD frequently die. I think when the real world data comes out, when data is all pooled and collected, we're going to see the response is that we improve patient outcomes. And actually, some people will find a reduction of their exacerbations, maybe 20%, means that they can walk more, which means that their quality of life improves. So I think it's going to be a whole, a mixed effect model of what happens. I'm excited to see what that looks like, but we mustn't assume it should be exactly like asthma.
One more point I would like to make about biologicals in COPD. So whatever we are targeting, it's eosinophil in COPD, right? Now, when we look at asthma, with the eosinophilic allergic asthma and eosinophilic non-allergic asthma, when we try anti-IL-5 therapy in eosinophilic allergic asthma, it doesn't work. It is just a cosmetic therapy of reducing the eosinophil. So targeting COPD with eosinophilia with biologicals, is it also just a cosmetic therapy, and that's why we are not getting a significant remission percentage? Point number two, when we look into the eosinophil subtypes, there are a type of inflammatory eosinophil and non-inflammatory eosinophil, right? Though it is still a beginning of what we are looking at, the type of inflammatory and non-inflammatory eosinophil. But in a COPD patient, if we are targeting with biologicals and they are not responding as per the asthma, being the same inflammatory pathway of eosinophil, is it just a cosmetic therapy?
Yeah, I mean, I guess this comes back to assuming that the eosinophil inflammation in COPD is exactly the same as the eosinophil inflammation in asthma. I would say it's not. You know, we've got data that shows the subtypes in COPD is different to that in asthma. So therefore, that highlights that when we use, whilst we have the eosinophil count, the peripheral blood eosinophil count as our biomarker now, for the clinical trials and for clinical practice. It's still quite still like a hammer. It's not perfect. It's not the most sensitive. It doesn't tell you if you have inflammatory eosinophils or regulatory eosinophils. It doesn't tell you about type 1 or type 3 inflammation. So there's still a lot to do here. But at the moment, this is allowing us to find a group who might need biologics.
So I'll just have one question. We have Professor Bull also here. His experience and his, as far as biologicals in COPD is concerned.
Thank you for asking. And hi, Mona. Always a pleasure to be with you. Unfortunately, only 16 to 9. I fully agree with what you said. I think a key issue and a key difference between asthma and COPD is the fact that, at least to a large part, COPD is also a destructive lung disease. This is why if we lower the threshold, we increase the probability that patients have emphysema and some other destructive changes in the lungs. And in such a situation, you just cannot expect a response at the same level as what we have seen in asthma. This is what we always have to keep in mind. And this is why what you said is 100% correct. You have to select the right phenotype and the right endotype to expect a good response in COPD as well.
But I think that would also mean that you need to start your biologicals early in COPD rather than late, because the destruction, if it's happened, it becomes irreversible.
Correct.
So then would you say that our criteria for selecting biologicals in COPD should have a lower threshold than what we have in asthma?
Yeah, I mean, we probably need to think about, well, of those who are recruited into the clinical trials, exactly what number had emphysema. You know, we don't know that yet. All we have is clinician reported. So we don't even know the amount of damage that has been created before we entered them into the trials. Again, we've just used some very blunt tools. And so this is why it's not been as clear as it has been in asthma, because the asthma population younger, there hasn't had 40 years of damage. You've got less impact on comorbidities. It's you know, COPD is much more complex, and we've just made it. We've assumed it's not that complex, expecting the same result.
Any comment
Professor
from,
Vishal, you wanted to just say something.
Any comment from you, Professor Michael?
Yes, please go ahead.
It's mute. You are on mute.
You're mute, Professor.
No, I don't have much else to add. I think what Roland said about the fact that there is damage as opposed to active inflammation needs to be considered, but why? But there still is active inflammation, and that's what you want to target in these diseases. The major goal, I don't know how much we're going to be able to reverse, but the major goal is to prevent any further decline in lung function, to prevent the exacerbations from occurring.
Okay, we have one question from the audience, please.
Ma'am, Dr. Mona, ma'am, before labeling someone as a biologically eligible COPD, like how we do in the severe asthma evaluation, we do step by step. Is there any step-by-step practical checklist that you will follow at your center before you start giving the biologicals?
Just a minute. I saw the message. Dr. Vijay is here. Dr. Vijay Kumar Chalamchetti. Is he here? I didn't see you actually. So that's why please come. Please come. I'm so sorry actually. Forgive me. Please come. Please come. Please come.
I think you got my question.
Yeah, no, so I guess we've set up an MDT, so a multidisciplinary team. We have clinicians, physiotherapists, nurses, pharmacists discussing individual cases. And we talk about, we're talking about the people who are still exacerbating the high eosinophil counts on triple therapy. That's the starting group. And then we reflect the comorbidity burden, we reflect the exacerbation burden, and then we reflect on whether there's other things that we can improve on. And we make a decision that way in an MDT approach, which is suitable for biologics, yes, no. And then that's how we make it. So we try and stratify it according to burden, but actually the real world evidence will give us much more information from whether these people with other comorbidities work or not. Actually, the other thing we do is when someone reports to us this patient's having 10 exacerbations needing steroids, we ask, well, what is the driver of that exacerbation? It could be because they've got anxiety. Anxiety is never going to be treated by a biologic. So is the inflammation at that time point receptive to the biological therapy too? So we take these things into account practically.
So I think the issue is whether we have a protocol developed to really decide how do we go down the path of giving a biological in COPD.
Dr. Vijay, do you think that we have not reached where we should have been by so much of research going on COPD when it comes to biologics? Because we are only talking about even today on eosinophils. We are not talking about so many other pathways as well as the chemokines and the receptors, and so many other things are there. In fact, the data also was not very promising even date today. So what is your take, I think, on that?
Definitely. If you see in clinical practice, coming to COPD, as many stalwarts here mentioned very clearly, our aim is to decrease the exacerbation, and the identifiable and clearly visible pathway what we have right now is IL-5 pathway. And then it is working. As of now, I think we should identify this who are responders to ICS, and then initially they respond, and then they fail to show response in long term. Probably every COPD patient has to exacerbate. Our goal is, as said in oncology, PFS, progression-free survival. How long they will be survive without an exacerbation. So that's what is our goal. Probably, I think we have good number of patients who are COPD patients on anti-IL-5, and it's working.
So I think you have put in a very good word, exacerbation-free survival vis-a-vis the disease survival, which happens in cancer. So disease is actually progressive, but not the way cancer is, but it's a bad disease anyways, actually. But ultimately, is it that signal coming that early detection, early treatment, early management, early aggressive approach can actually lead to, one of them will be, of course, stop smoking altogether, which is the most important. But then there is a lot of related to environmental pollution also. So like, any comments on that? Its disease is so bad, we are not hitting where we really need to hit hard. What are the strategies to go for next couple of years?
Sir, unfortunately, we end up starting in these patients on biologics in very, when their pulmonary functions are, very at low level, probably around 20%, 25% of FE1, with hardly 40 ml, 50 ml of reversibility, what we see document kind of thing. And then overall quality of lives were also poor. So we should, I think, identify and then draw a consensus statement for our country at what point we should rightly initiate biologics for COPD. I think early initiation does work.
So Mona, what is your comment about it? Because you also showed that, when the lung functions were very bad at that point of time, where is the room for improvement actually? So I think, is there any signal to tell us that, perhaps it's too late when we are trying this kind of therapies?
It's all really about the diagnosis and the time of damage. The better and earlier we diagnose it, the better someone's outcomes. Even without biologics, the optimization of everything else should improve care. It's just that we've just not got it right in COPD in trying to take all the modalities. COPD is not, in the UK, for example, it's not sitting in hospital. It's sitting in the community. It's sitting in primary care. Our primary care colleagues cannot do spirometry. A patient wanders on and on and on and has lots of chronic bronchitis, needs antibiotics, needs steroids every winter. They get worse, more breathless. They think it's because they're getting older. So all of these things, we just need to put it into primary care so we can get better diagnostics there to improve the diagnosis earlier. And then we can start all our therapies earlier too. But to your point, COPD isn't just a smoking-related disease. And here in India, for example, we've got air pollution and biomass exposure. All of that is leading to all of these people having obstructive lung disease. And when we see them in secondary care, for me, I feel like I've failed when the patient I see, the only thing I can do is refer them for transplant. That's
Absolutely.
a failure of care.
So chance has to be given to the patient. It's on his side, very difficult. I think, Nagarjun, you have a couple of patients in which you tried.
I had a couple of questions just to take the discussion forward. So before the advent of biologics in COPD, for a person with frequent exacerbators, the only options we had were roflumilast and long-term macrolides. So I think Dr. Rafi can answer. So now, how would you position these two vis-a-vis a biologic? And if a person cannot afford a biologic, so you have an eosinophilic exacerbating COPD, but he cannot afford a biologic, would you still consider giving roflumilast or macrolide in them?
I think patient affordability is the issue which we are looking at when we are practicing, even in the COPD in Indian scenario. I think we are getting into the newer drugs as well, like, long-acting muscarinic agents as a nebulized form also is coming in as one of the treatment options. In that set, I think, as you said, any inhalational or nebulized drug still holds good for the stable COPDs. And, but I think I just wanted to draw one point, like our experience with the biologics is because we are limited because of the only IL-5 and then also what I understand is like we need to start in the early when you're picking up in the COPDs. So that means stable COPDs. You need to actually treat them, right? So, but as Dr. Deepak and then expert has actually mentioned, there is a lot of overlap, lot of scenarios where like non-smoking COPD and then other ones. So endotyping and diagnosing not just by just pure eosinophilic is what we are at a drawback, I think, in Indian scenario when we actually narrow the patient to actually pick up for the biologics. I think, but to come back to your question, I think nebulized and also inhalational still are the ones to bank on if it is in the stable COPD.
So Professor Mona, your opinions on macrolides, roflumilast and biologics in decreasing exacerbations in an exacerbating COPD? How would you go about it?
Yeah, I mean, there's a place for these other therapies. It's all about whether you think they're going to work, it's worth trying, whether you think there's too many side effects, whether patients can tolerate it. I don't think having biologics means that you can't have other things, and I don't think having these other things means you can't have biologics. It's all about response and evaluating your patients, I would say.
So I think it's a combination, and you need to sort of individualize your treatment as far as your patient is concerned, depending upon what he can afford, what will work and what may not work. And biologicals is something which is adding to our armamentarium as far as treatment is concerned, both for an acute situation and for our chronic COPD patients.
I mean, I think what's important to hear is cost is quite an important implicating and factor that is obstructions, I think. And there will be opportunities, I hope, that the cost becomes lower for sure.
So we have two questions from the audience. So quick questions, please.
Quick question by Dipesh.
Yes, because in a clinical practice, when you are sitting in front of a patient who has eosinophilia and you want to decide regarding a biological, and cost is the biggest barrier. So in the Boreas and Notus trial or in the Matinee, is there a cutoff of a absolute eosinophil count, maybe 450, 500, 600, that the definitive benefit is there?
So the study showed that the benefit increased the higher your eosinophils, and 300 and above was where the benefit sweet spot was.
But in that 300 above is just 30%. Is there any cutoff above like 600 where there is the when is more than 50%?
Yeah, but the number of populations that have above 600 is even less. So your sample size gets smaller and smaller and smaller. So the confidence intervals for that response is higher. But you know, the data has shown that 300 and more is why that cutoff is where it works the most, especially with the negative and mixed data before at 150 and 220. 300 is the point above, and it's likely that the higher it is, the greater the response. But that's because the higher it is, the more exacerbations they have anyway.
So we are getting thumbs up from Professor Bull that higher the count in that, it is more likely to be effective or better effective, at least that is there. So in eosinophil is a indicator. Yeah, Dr. Arora.
Do you
No,
Yes,
yes,
got
sir.
two quick questions. Do you see in near future, during the exacerbation, the biologicals will be replacing the steroids and other therapy first? Second important, when you need higher doses of steroids, is biologicals the choice during the acute exacerbation when it is life-threatening?
Yeah. So the phase 2 that I spoke about, the ABRA study, you know, that was a long labor of love. You know, the idea was 2015. The study doesn't read out in 2025. It takes 10 years for these things, right? We need to get the community to say treatment of acute problems needs to be the next thing we do. That's what we need as a whole community. And then we drive and shape that. Because our patients with eosinophilic inflammation, they respond the best to steroids at the time of an acute attack. But equally, they don't like these drugs. And some people can't be on them. And it messes up their diabetes, it messes up everything. So I think the future has to be about how we treat the acute event better.
So two more questions, yeah. One for Indu and ma'am, you please come
Just
come
a
forward.
short question. I mean, macrolides I feel are underutilized, though it works in the neutrophilic inflammation, like in bronchiectasis, it reduces the netosis. Does it work in the eosinophilic driver also? I mean, it's underutilized definitely, I feel, in India at least.
So I think the question is that if there is a poor man's drug, azithromycin, will it work even if it's a eosinophilic COPD?
Yeah, I mean, it's likely to work the best in people who've got mixed inflammation, and there is that group that have mixed airway neutrophilic inflammation and mixed airway eosinophilic inflammation. We think the people that where macrolides work the best are definitely those who've got Haemophilus chronic infection or colonization. So if you can find Haemophilus in your patients and they've got exacerbation burden, their eosinophil counts are not 300 exactly, but maybe a bit lower, maybe a bit higher, then macrolides are likely to have benefit. But not everyone can have macrolides.
But most of the times,
it's an excellent point. Take home. We identify H influenzae related exacerbations and they'll do better. I think we'll give a chance to her because we have to close the session now.
Good afternoon, ma'am. My question is that can the tests of measuring the small airway dysfunction, shouldn't they take precedence of using FEV1 first of all in the clinical trials for selecting patients who respond to biologics?
Yeah, I mean, I think, FEV1 isn't the best test for small airways disease, really. We've got newer tests now. I think tomorrow there's a session on small airways disease, which I'm presenting. So come to that and we'll talk about FOT then.
That's a very nice one. Okay, last from Dr. Dipender. Your only one question, Dipender, not three.
Just one question, sir. So this is a question from general physician. So he said that we have 200 pages gold guideline for COPD treatment and 200 pages for GINA guidelines. But if you look on the treatment of both the disease, ultimately it is eosinophil which is the treatment decision maker, not for only biologic but also the inhaled corticosteroid responsiveness. So I am favoring for the Dutch hypothesis rather than going for the British hypothesis because ultimately if you look on the whole these two diseases, if there is no eosinophil,
I think we have Dutch, we have British. I think we will have a big fight over that. It's a very tough call to say that are we really looking at the treatable traits which Mona has already spoken about, or we are just still trying to fight out two different diseases which are totally different and trying to put them into a separate boxes altogether. I think that's the question down the line because most of the physicians do feel that it is ultimately a triple therapy here and a triple therapy there. So I think that's basic last question which we are going to discuss. So Mona, can you give an answer? And I'll ask Dr. Bull and Professor Weisler also for just this small comment upon what is this basically which we are talking about today.
Whether COPD and asthma are two different diseases or you need to look at them as one basket with looking at treatable traits to focus more on the treatable traits. Dr. Mona.
Yeah, maybe I'll start. So inflammation can happen in anyone, whatever disease. So the inflammatory pathways can be similar, but they're likely not completely the same because of the complexity of the disease. Are asthma and COPD different? I would say yes. I don't refer anyone for a transplant or NIV who has asthma. I do for patients with COPD. They have a different disease process.
Dr. Bull?
I agree with what was said. I think in asthma you start in all patients with an inhaled corticosteroid on one side, and in COPD you always start with bronchodilators, LAMA on the other side. But there are many patients who need both, and if they still exacerbate, the next step would be a biologic.
Professor Weschler?
They are different diseases. And I think that one thing that we need to consider is what are the stimuli of the pathways that are involved. And they're very different. In asthma, I mean, there's overlap as well. And allergens can affect people with both asthma and COPD, but predominantly more in asthma. Smoking obviously is the major contributor along with biomass fuels to COPD. That's the different mechanism of disease. So there are different mechanisms, there's different biology and pathophysiology. I agree with what Roland said about the strategies for treatment. Usually inhaled steroids plus bronchodilators, and then bronchodilators plus inhaled steroids, all leading to biologics and or azithromycin?
So the aim is not let asthma reach that level where it looks like COPD and behave like COPD.
Remodeled.
And prevent it much upstream there. And this one, of course, is different. So,
Sir, will you be happy to use high dose ICS in T2 low asthma?
well, I am not using high dose inhaled steroid in any condition now. I'm trying to keep it at the medium dose only. After all the data which we are seeing, that it's really that medium dose is perhaps the only one which is acceptable. I think
I will say that these diseases, there's a spectrum, and there are some people who do benefit from higher doses. And yes, there is toxicity, but we have to recognize the spectrum of patients. We can't rely necessarily just on group mean data, and sometimes we have to personalize our approach to offer extra inhaled steroids for some patients.
So personalized approach and precision medicine is something which is going to be there. Maybe the next couple of years we'll be talking about that. Randeep, if there is any last burning question, we can take it. Otherwise, we will wind up the session.
So
and I
can
know
I
for
have-
Professor
There's
Wessler, it
one
will be
question.
middle of the night, I suppose. Middle of the night you are staying there.
We have just two questions from the panelists. We can just quickly ask them to
Yeah, it's just
short
a
questions.
comment. Very nice lecture by Dr. Mona, eye-opening, biologicals in COPD. We are using definitely in asthma. It's a precision medicine time, but definitely the basics should be followed. Pulmonary rehabilitation, very, very important, making a good nutritional choice for them. Exercise, vaccination, very, very important. And avoiding glucocorticosteroids, especially patients who are hospitalized or in ICU, because most of the mortality is related to infective exacerbations. So that
right.
Dr. Vijay.
Sir, two quick, sir. One thing is, recently we have come across one patient who grew Curvularia spicifera, who was on biologicals, very unusual fungus. Okay, what sort of infections that we need to watch for in patients with COPD on biologicals? That's first question, ma'am.
Yeah, so I think we haven't seen from any of the clinical trials what the effect of biologics are in the COPD airway microbiome, but the microbiome is going to be very important in COPD. And so I think with real-world evidence, as we collect the data, we're going to understand if there's a differential change in bacterium or the microbiome or the fungo in a patient airway.
And the second one is, so do we need to target, example, you have a patient with CTD ILD or any ILD with absolute eosinophil count of around 500, 600, he is exacerbating. Okay, what is your take? Do we need to, are we yet there in translating this amount of evidence what we have in COPD to other lung diseases?
Yeah, so I think there's going to be a session on ILD and biologics in ILD here, so I think it's worth listening to that one.
Be there tomorrow. She has a session on that. So that's the message, very clear. Thank you very much. I think I'll let Randeep close this session because we have crossed the time. Excellent day, excellent day.
Thank you
well
very much.
spent.
Thank you very much. I think we've had a very good session. I'd like to take this opportunity to thank all the international faculty. They've stayed up late in the night. Professor Vishner, Professor Ronald Bull, and of course the faculty who are here, Professor Mona Bafaldi and Professor Russell, and of course our Indian experts. Thank you very much, and also to the case presenters. I think we've had a very good session as far as biologicals are concerned. A lot of knowledge has been shared, and we've learned a lot as far as the use of biologicals are concerned in chronic respiratory diseases. Let me put it this way, that we are looking at biologicals not in asthma but in chronic respiratory diseases. Thank you very much.
Thank you. I would like everyone to scan their badges at least once at the entrance of this hall, because your certificates will be emailed to you, and that will be upon the scanning of your codes. So please get it scanned so that you get the certificates. Thank you.
ACCP chest certificate will be issued only if you scan the batch that you were attending this. So that's their rules. But before that, I would say that please come on the dais and have a group photograph of all of us here. Please requesting every one of you to come on the stage.
Uh, so we will continue with our workshops post lunch. Studio 4 will be having interventional pulmonology. Studio 6 will be having ILD. Studio 1 will be having allergy. Studio 3 NIV workshop, and Studio 5 will have mucus matrix.
So it's on the first floor, so you can go over there, take a lift, and then all the workshops are nearby only. So kindly proceed to the first floor for the other workshops. Thank you, everyone.
Is everyone there or are you waiting for someone? So we'll start. This is basically to develop a consensus statement on biologicals in severe asthma and COPD. And since we don't have voting pads, we'll go by a raise of hands and see, or you can give your comments. So there are 10 voting statements across 4 decision-making areas. One of them is identifying and phenotyping our patients in severe asthma, biological selection, broader acting biologicals in India, and treatment goals. So the first question is, an asthma patient receiving more than 2 courses of oral corticosteroids per year should trigger a mandatory severe asthma assessment and specialist referral, starting from 1, which is strongly disagree, to 5, which is strongly agree. So 5 EM. So let's have a raise of hand. If you go for whatever you vote, you can just raise it for 1, 2, 3, 4, 5, since we don't have voting pads. So I think the majority. Okay, that'll take a little longer time, but we can do that. So how many of you strongly agree with this statement? Let's have a raise of hands. Okay. And how many of you just agree with the statement that any patient who receives more than 2 courses of oral corticosteroids per year should have a mandatory severe asthma assessment and specialist referral? Neutral? So we have 1 vote which is neutral.
So I think we need to reword that statement to assessment for difficult asthma, not severe asthma, because you need to rule that out before going on to that. That's why I don't agree with this statement.
So I think
this question has primarily come in because we are all asthma specialists already doing it. So it's basically it's a consensus from us. It's not from the general respiratory physicians. So we already are doing that. So it is presumed that we are already doing that. So in
optimized treatment.
We are now using severe asthma term means all difficult to treat asthma has been taken out of it. Now, so if we in severe asthma, will you like this 2 OCS to be there? So that's the question I think out here.
Then I'll agree.
Agree.
So I think we all would agree that if you are sure that this is severe asthma, not difficult to treat asthma, you would really do a assessment and a specialist referral or look at now going to a new level of treatment, right?
Should we add a caveat for 1 course for 2 consecutive years or more or something like that?
Okay, you mean the duration, more than 2 oral corticosteroids per year. It's
Because
written 1
a
per
person
year.
would have
In
1 course every year.
2 OCS courses require, that means 2 exacerbations which require oral corticosteroids.
In 1
should
year.
have an assessment.
No, I completely agree with that, sir. I'm saying
Right.
in addition, if person has 2 OCS courses for 2 consecutive years, for example, it's once a year, but 2 consecutive years, should we also add that?
So I think the
So
issue
you
is
just
should
note
we
down that even if it is like every year 1 course, even that is bad. We know that already actually.
So I think the issue is should we add 1 exacerbation for 2 years as compared to 2 exacerbation for 1 year. Add that as a caveat. That's what you're trying to say.
So if a person, for example, consecutively every year has 1 course of OCS, they will be excluded out of this. So should we also add
that can be added as a caveat.
So one more thing, sir. Also, any exacerbation requiring admission. So I think that even one can trigger.
Is there a question on that? Hospitalized exacerbation? Archita, is there a question on that? Hospitalized exacerbation, because that would be in a different category altogether.
So I think this question needs to be a little bit reworded. 2 courses of oral corticosteroids per year or one admission
or
because of an acute exacerbation in a year should also trigger the same thing.
Done.
Right? Okay, let's move on. A minimum biomarker should precede biological initiation. Blood eosinophil count, FeNO, and total IG with allergen sensitization should be considered the minimum mandatory biomarker panel before initiating a biological in severe asthma. If you all agree, if you strongly agree, please raise your hands.
Yeah, okay.
So I think we have a 50-50 agreement here. So if you just agree with this statement, then you can raise your hands. Okay.
4.
So I would say maybe about 70% agree or strongly agree.
Sir, just a question. Is FeNO that important? Can it just be blood eosinophils and total IgA?
I didn't hear that.
I mean, FeNO, do
So,
we need to
like,
make it
is
mandatory?
FeNO so necessary? I think that's the question.
As of now, the data does suggest that FeNO should also be
Yes.
included. Yeah.
Although we don't have the answer for that because we don't have dupilumab.
So the problem is it's not for all biologicals. If we make this a very strong statement, it will make the availability of biologicals for those centers which do not have FeNO. In my center, we do FeNO regularly. But what about those centers who are not doing FeNO regularly? Would they not
So I think the point that you're trying to make is if FeNO is not available, does that mean that you cannot really?
Exactly. So if you put it at this,
FeNO
it makes
would be
FeNO
a
mandatory.
non-compliance detector.
So what is the general consensus? Should we have all the parameters or should we not?
Any two of the three may do.
No. You need FeNO because for follow-up of your patients, whether or not they're responding to, say, your patient is on Fasenra and your patient has a high FeNO despite being on Fasenra, this guy is not a candidate for, this biologic anymore. So it's not just about the diagnosis. The follow-up of all biologics now, the standard of care is the FeNO. So till last year or a couple of years back, it was okay to have FeNO or not. But for follow-up and for treatment, if the patient is already on biologic, you need FeNO.
I think we don't have a data from India to tell us what is the average FeNO of the patients in severe asthma in the various clinics, basically.
So we don't even have data. We tried to do a study long time back to look at what is the average FeNO in the normal population.
Correct.
And we had some people whose FeNO was more than 100 who were totally asymptomatic. One of our DM students did a thesis on this. I think Saurabh did it or something. And we found a very wide range of FeNO even in normal healthy people, and it varies a lot. But the issue here is not about what is the value. It's looking at biomarkers that you should have if you're trying to consider a biological. I think if you're considering a biological and considering the cost and the fact that you have to follow up these patients to see whether they're responder or non-responders, these markers should actually be included.
I think all other things matters. If eosinophil is not very good signal giving actually, in those situations you need the other markers. But if eosinophil is a very good numbers there, that itself is a marker basically.
No, but regardless, in the future we will have dupilumab as well, and it's best to classify these patients upfront if they are failing Benrali or MIPO, and we get Dupi in the next 6-12 months. We have that option. So you need a FeNO upfront because
Okay, so
biologicals
what we
will be
make
introduced
today,
in the Indian market.
What we make today is going to for
exactly the baseline
So
has
my take on this is that we should actually look for. I agree there are challenges in our country, but if we exclude it out, in the future we'll have problems in terms of not being able to do something.
Right.
So I think if you're looking at newer molecules coming in, FeNO should be added because most of the guidelines and most of the criteria do use FeNO.
So Randeep, you can take that strongly agreed were the rest. Only those who have just agreed, you can put the number there that so many people just agreed. That's all.
So that's
how
what
many?
I'm saying.
Five people are there. I think Archita, did you take the picture? How many are for the
So
just
we
agree?
can do that now after the discussion. How many of you strongly agree with this statement? You can raise your hands. Fair enough. How many of you agree with the statement? And anyone who disagrees or strongly disagrees? No. Okay, let's move forward. Now coming to the next question. Access to comprehensive phenotyping remains limited across much of India, particularly outside tertiary centers. And this constrains equitable biological prescribing. Do you agree with that? I think it's a profound statement, but it's a true statement. How many of us would say that what we were saying in the...
What is the statement? Just repeat.
Statement says that comprehensive phenotyping remains limited across much of India, outside tertiary centers, and this actually limits equitable biological prescription. If you go to tier 2, tier 3 cities, I don't think they have the bandwidth to give biologicals.
Sir,
and probably they will get used there, but not with the precision that it needs to be used.
Sir, here actually, Gina, everybody says that when it comes to biologic, they don't want everybody prescribing biologic. So the patient has to be referred to a center who is good in
No, but
managing
that center
their
doesn't have to be a tertiary care city.
So I think the basic question is that people who are in secondary centers, because they don't have access to biomarkers, they are not prescribing it, and the patients are not going to the tertiary care centers because everybody may not go.
Yeah, but the challenge is you may have patients who may, you may have physicians who may know about biomarkers, may know about biologicals, and may give them without doing the necessary screening.
But does that happen?
I don't know.
It happens. It happens.
It doesn't in, I've hardly seen it.
Sorry?
So, it doesn't happen in our practice. Have you
so
seen physicians giving biologics?
No.
So I would say there are...
Sorry, I didn't get it.
Physicians don't give biologics.
No.
Pulmonologists don't give it. Leave alone
No, I'm
physicians.
talking of...
Basically, you mean pulmonologist only, no?
Pulmonologists in Tier 2, Tier 3 cities will at times give omalizumab.
Yes, I think without anything they will use omalizumab because that's cheap. They can easily see and then withdraw if it doesn't work.
So that does happen.
And that too in very, very suboptimal dose, like just 150 milligrams. Like optically correct that something is being given.
So,
Agreed.
To the first part of statement, yes, comprehensive phenotyping is not been done properly. But to the second part of statement, that it is equitably constraining the use of biologics, that's something which is debatable or I don't agree upon, because I am seeing patients.
Appropriate biological hoga fir.
Sir, here
appropriate biological.
Sir,
because if you do not do a biomarkers and if you prescribe, then you are actually not using appropriate biologic, isn't it?
Sir, whatever the way we may put it, but the point what I am trying to say it, they may not be appropriate, or there may not be any need of it also.
Yeah, I agree. That's the point I was trying to make.
Both ways. Phenotyping is not restricting the use of biologicals. What I mean to say is.
Phenotyping is not restricting the use of biotype. Lack of knowledge and lack of other thing is restricting proper use of biologic. I'm not even saying restricting use of biologicals. The fear that I have is years down the line, you should not start saying that biologicals are being used X, Y, and Z.
They are being getting used.
Yeah, so that
but phenotyping, sir, is not in the domain of tier 1, tier 2, tier 3. Phenotyping is clinical. Apart from pheno, if you have a childhood onset of asthma with a high IgE, a high blood eosinophil, atopic comorbidities, all that is clinical. It is done in the OPD. And IgE and blood eosinophil is accessible to every nook and corner of the country. Only pheno is not available. So phenotyping is not in the domain of tier 1 cities and it is not in tier 3. It is across the board. So this statement is not true. Phenotyping can be done sitting in the clinic. Apart from pheno, we have access to all markers. And
so I think the statement would be more precise if we said that comprehensive awareness of how to phenotype a person.
Exactly. It's not there. I think that will be the better one.
So actually,
phenotyping is possible if you are knowledgeable.
Yes, it's awareness of how to phenotype and how to prescribe the biological in the right setting is what is needed as far as, let's say, outside tertiary care centers.
And obviously that is translating to poor penetration as well as maybe inappropriate use also. I think, I do not know, both words will be correct.
Yeah, so I think this question we can reframe because you're right, with the availability of a lot of labs, getting IgE level done, looking at eosinophil and having a good history may not be the constraint. But a lack of awareness of that would be more important. So do we agree that we need to reframe this question?
Yeah, I think the practical translation of this would be a patient saying that my doctor really wants to give me a biologic, but he doesn't have the test to prove that I can.
But that may not be correct. You may
that's
need,
not. So that
you will be able to get the basic test done even wherever you are. But if the doctor is aware of what are the tests that has to be done, how do you need to really look at that this is severe asthma, and how do you need to move forward in deciding which is the ideal biological for that patient?
Next.
Okay, so this needs to be reframed. So the next question is, omalizumab should be preferred as first-line biological in patients with severe allergic asthma and perennial aeroallergen sensitization, especially those with concomitant chronic rhinosinusitis with nasal polyposis and chronic spontaneous urticaria.
It is perfect actually, I suppose. This is
so
the
if
right
you strongly
indication
agree, please
for
raise your hands.
For O'Malley, this is a right indication actually. So I would definitely raise
So I think most of us would agree that at least at the first go you would give omalizumab. Fair enough. Anyone who disagrees?
So with nasal polyposis, first choice will be omalizumab. Even the background, it may represent a shift.
With this background with nasal polyposis.
Aeroallergen sensitization.
This is allergic asthma.
So this is IgE mediated.
This is IgE driven allergic asthma. So your first choice would probably be giving omalizumab.
So still my point is,
So this question has been, I think, framed to create a little bit of a confusion.
so sir, when we look at eosinophilic allergic asthma versus eosinophilic non-allergic asthma, right? So the first part of this Ig mediated severe allergic asthma, perennial aeroallergen sensitization fits well. But when we look at this chronic rhinosinusitis with nasal polyposis, here comes the mixed phenotyping of eosinophilic allergic versus eosinophilic non-allergic, right? And the problem is because it is a shift of the phenotype from allergic to non-allergic. Will just as the case Dhruv presented, right, about the use of omalizumab in this US guy.
So the issue, that's what I said. You're looking at your first choice of treatment. I'm not saying that is the only choice of treatment.
So, you know, later on you might have to shift, but at this moment that's the first choice.
That's what I'm trying to say. This is your first choice of treatment. You could later on shift because he is a patient who comes into that overlap sort of group.
I think even with the, at that point of time, we should check that what's actually driving the disease if there is overlap. So that can be sometimes confusing. The eosinophils is driving the asthma, severe asthma and exacerbation. And of course, he has Ig high also, but since overlap, the driver needs to be found out, and then so
Fair
maybe
enough.
I'll also agree on it, but not strongly.
Okay.
I think with the overlap, first line of treatment for patients who has aeroallergy and chronic spontaneous urticaria, this is the first choice.
I agree with that. I think we should hurry up, otherwise you
Yes,
not get
next,
I just wanted to add sir, like more dermatologists actually using than pulmonologists this because looking at urticaria and then other
Yes,
issues
yes,
with the so you would have to see about the skin manifestations also before you actually choosing this or wanted to evaluate for a higher biologic for this kind of group.
So
I
in
think
this
we just
question,
agree,
you want
not
to
like
say
strongly agree
or agree? So
Agree.
how many strongly agree? Strongly agree. How many? So now at least have a head count.
Okay.
Okay. Now how many agree only? Okay.
Fair enough. So we have majority agreeing or strongly agreeing. So let's go to the next question. Mopolizumab should be preferred in patients with severe eosinophilic asthma, eosinophil count more than 150, on oral corticosteroids or eosinophil count more than 300 of oral corticosteroids, and is appropriate as first line of therapy in coexisting EGPA.
I think this is a very tough question rather than it should have been an anti-IL-5 therapy. Why mepolizumab? Why mepolizumab?
So if there is no end organ damage, then yes.
Sir, in this 150 on ICS, 300 off ICS, has
Correct.
that been validated anywhere, sir? Because for Mepoli it was current 150, 300 in the past. That was the thing.
For EGPA, coexisting EGPA is the word.
So the
Even
whole thing
cutoffs
gets
which have
shifted
been
because the
used are
person,
not,
the patient also has EGPA.
EGPA.
Again, it's a pretty interesting question if you ask me.
So
But for
I also
EGPA,
fail to understand.
You don't need eosinophils to be high. If it is EGPA, the eosinophils might be suppressed because of the steroids. So the eosinophil count is not needed if you are labeling it as EGPA.
So that's all right. This is a question that if you have a patient with severe
Why do you
eosinophilic
need
asthma,
eosinophil count in EGPA?
Yes,
because
you don't
EGPA
need
diagnosis itself is the diagnosis.
Exactly, and the patient will be on steroids, so the eosinophils will be suppressed. So the count is immaterial.
So the questions are extremely focused on a very small subset of people, sir. I think we should probably make it a little broader. And
So what is
remove
the
EGPA
exact
there.
idea behind this? So Archita, if you can explain that so that we can reformulate the question accordingly.
So I think we can remove EGPA.
What is the idea behind?
We can remove EGPA and just put severe eosinophilic asthma.
Then in that
Then
case,
it's a
why will say
straightforward
MEPO?
question.
We will say any anti-IL-5.
then it becomes anti-IL-5. Even otherwise it will become anti-IL.
Anyway, it's anti-IL-5, sir.
I
but
think this mepolizumab word has to be changed to an anti-IL-5 drug. So that people will strongly agree. If it is only mepolizumab, then I think we will disagree on the point that why only one? Why this is the one? Why others are not? The other one
would have
is
to
not.
put it as an
I suppose that
anti-IL-5.
benralizumab does not have FDA approval. It is proven in a trial, but it doesn't have approval. That is why.
Approval for what?
EGP.
No, it is approved. FDA approved.
FDA approved?
Approved.
Then
Both HES as well as EGPA. Both the drugs, Benrali and Mepo, both are approved. So I think this question can be anti-IL-5 drug, and then you can have another question later on
So
for that.
the cutoffs also, I think this has not been used anywhere else, sir. On OCS 150, off OCS 300, to the best I am aware, has not been used.
I think we can check that, Archita, later on.
Because
And if
OCS
not required, we'll remove that.
So this is also not used anywhere.
So this
So
is a little bit of an arbitrary cutoff.
So
This
if it
is an
is
arbitrary which they have proposed.
No,
sir,
if
because
it
when
is
the
in the clinical
consensus-
trial on the basis of which the approval has happened, then it stands true. But if it was not there, it's not required. Anyways, we can check that. No problem.
So this
Mona is
question
not
needs
there.
modification.
Should have asked her.
But if you say anti-IL-5, would you agree with the? Would you
Yes,
strongly
yes,
agree and
yes,
agree?
yes.
Okay,
If
go
no
ahead.
EGPA, then
So we come to benralizumab. Benralizumab should be considered a first-line option in severe eosinophilic asthma, with its 8 weekly maintenance dose offering a meaningful adherence and convenience advantage.
So I will be the strongly agree because once in 2 months it goes. It makes the life easier. That's it. I will be strongly agree to that because once in 2 months make a difference.
It
So
has
that's why I will
a
say
convenience advantage, definitely.
Now
So
agree.
how many of you agree? Good. And are there any who are neutral?
Those who have strongly agreed cannot agree now.
so here the only
I'm not talking about you.
So anyone
we
who
have had
strongly
to-
disagrees?
Disagree, yes.
Disagrees or is neutral can raise their hands. If you agree or strongly agree, I think most of us have done that.
Next.
So if I can just
Sir, I
suggest,
just add
it might be useful to have a patient also on the panel who can then vouch that once in 2 months is better for them than once a month.
Yeah, most consensus statements now will have patient advocates also. We need to move in that direction for patient advocates also to be part of consensus
future we
statements.
might consider that also. But
Randeep
that
sir.
I think compliance does not allow at the moment in India. Is that right? I think we had a proposal of the patient. Harjeet's patient wanted to travel on his own from Ahmedabad to PACS just to talk about benralizumab and mepolizumab. And I asked them and they said that compliance doesn't approve, so that's why he has not come. But he wanted to come to tell everybody. Multi-millionaire guy, correct?
Okay, we go to the next question. Benralizumab offers a first-line option with dosing convenience. That is, question is, benralizumab should be considered a first-line option in severe eosinophilic asthma with its, I think we've done this.
This is done.
So let's go to the next question. A significant proportion of severe asthma patients in India remain inadequately controlled despite optimized inhaled therapy and currently available biological. So would you say this is severe asthma?
A lot of adjectives are being used, sir.
Exactly.
Comprehensive,
Not
significant. So when we use adjectives, it becomes very, very subjective.
Very
Correct.
So I
confusing
think
statement.
is the
What
question
do you
that-
mean by significant?
I see the question is trying to address that how much is the unmet need here. So are there people who are not getting it and they are still not controlled and they are getting other treatments?
So
and
I think the purpose of the question is, do we need to get in more biologics in India? So
Is it
even
that?
with the existing biologics, a significant proportion of our patients are not being adequately controlled. I think that is the intention, whether we need more biologics.
Then the question would have been,
That's what is there.
those
See-
patients who are receiving biologics.
See, exactly. See,
Okay,
and
that
biologics.
That's what the
currently
meaning is.
available biologics.
So despite biologics are a significant proportion of our people, so what is significant again is a bit.
No, but this, if it is
So I
that,
think the question is trying to say that we have significant portion of patients who have severe asthma. If you're not saying portion of asthma is severe in the population, but among the severe asthma population, we have significant number of patients in our country who, despite inhaled therapy, and currently available biologicals which they are not able to get
So this is
are not getting controlled.
Correct. It's an unmet need. So how many of us feel unmet need? Strongly agree. That's the first thing you're saying?
Currently
Okay,
we're
strongly
saying
agree.
severe asthma patients are getting, despite biologicals being available, are not being able to get those biologicals because of, let's say, cost factors.
So
there are two
it should be
parts of
framed
the-
like despite not receiving or receiving, sir. That was a big difference.
Available. They have written available.
So मिला
So-
नहीं मिला वो अलग बात है.
नहीं,
Available doesn't mean
अगर
that
वो
you're
उसको
getting it.
ठीक मिला ही नहीं तो कैसे होगा?
Available doesn't
Question
mean
is,
you're getting it.
available वाला ठीक होगा तो ठीक हुआ, नहीं हुआ तो हमारे पास क्या है?
No, sir. Here the question clearly says, despite optimized inhaled therapy and on biologics.
So
Available.
Available. Sir, is he using it or is he not using it because of finances?
We are presuming they are
Available
on
लिखा है. उन्होंने ये नहीं लिखा affordable.
So it could be a significant proportion.
No, they exactly, they are very clear. Sorry, this
adequately controlled with
available biologic. So
Yeah.
available biologic means which are available, and if they are used, it's not a question of not affording. It's a
they're
question
used
of affording. They are
after
used,
using,
but
yes.
not finding it effective.
Correct.
So I think the question is how many patients would be needing dupilumab and
Or
tezepelumab,
tezepelumab, exactly.
basically. That's the question. And I strongly agree that we don't have options, and there are significant number of patients. So that's what we need to raise hands. Strongly agree, can raise hands.
But sir, if you interpret it a little differently, super responders are only 30-40%. A large part of these patients are responders. So they are not controlled in the strictest of sense. They still have 50% oral steroid
Responders
use.
are controlled. They are
No,
3-point
sir,
control
if-
or 2-point
like
control or 4-point
Lance
control.
said, if you are on 10 milligram of prednisolone, you come to 5 milligram, you still are uncontrolled. You might be responder, but you are uncontrolled.
I think we will be getting into too much of
So a lot of our
nitty-gritties
patients
it.
will still be uncontrolled.
Okay, so let's say then you agree lots of patients are uncontrolled.
Yes, in the strictest definition of control.
So they might benefit from a better biologic.
number
That
और
is
ज़्यादा
what is
होगा.
the question.
So that means number is even higher.
Exactly.
Okay, so strongly agree again.
So we strongly agree.
So those who
Okay. Those who agree can raise their hands.
So I would agree only because sometimes we switch the biological. That's why, because they are not controlled. So not every patient on biological is controlled. So I will just agree on it, but not strongly.
Okay, fair enough. Can we move ahead?
everybody knows you.
Yeah, please.
No, we are not talking about that. No, Vishal, that's not the question. If we go for the affordability, it will be a separate question then. It will be a separate question. So that will be incomplete goals met. So we haven't met the complete goals. So that will be considered as not achieving exactly what you want, which some other biologic can do. So that's again uncontrolled ho gaya na, wo bhi to, that is in the same group only. But I think it's not affordability, because that should be a separate question. Affordability is a different, very big question itself.
So I think I personally feel we need to reframe this question a little bit. But currently there is a need for more biologicals because the control still is not good enough. That's what we're trying to say, right?
And in fact, people should take some kind of a work ahead where they will find that there is a big number of that, which are partially controlled,
partial
as you said,
responders
partially
or
controlled,
non-responders
not
to
fully
biological.
controlled, and they might, it looks like that phenotype, they will respond much better to the other biologics which are coming, which are not available.
So it
Perfect, I
sets
think.
the
So if
premise
we
to
have other
introduce new biologicals in the
Correct.
country.
Correct.
So if we are just trying to say we need more biologicals. Let's put it that way. So if we all agree to that, we can go to the next question. So where are we? I think we moved ahead. This is the next question. The requirement for detailed phenotyping and endotyping is a major barrier to biological access in India, compounded by overlapping biomarker profile and a high environmental trigger exposure, pollution and biomass.
This is again like two questions which have been jumped together. I think that Major, phenotyping and endotyping compounded by overlapping biomarker profiles, I think that is correct. But access, major barrier to access, isn't it? I think we don't know actually.
So let's look at it before the question, before the comma. The requirement for detailed phenotyping and endotyping is a major barrier to biological access in India. Do we think that is true?
I think overlapping phenotypes is a more barrier to use appropriate one, which we mostly find that there is a overlapping actually. I think you need to reframe this also. Overlapping is a more important word. And they showed 47% in their studies. We showed only 30%, but that was long ago. By now, I think things have changed completely.
Why are we saying there is a major barrier as far as phenotyping and endotyping is concerned?
So the thing is, even if there is an overlap, it is not a barrier for biologics.
That's what I'm trying to say.
Because we have IgE, we have anti-IL-5.
No, but then you're not able to actually get to that, whether this is the driver or that is the driver. Because invariably you start with A, if it doesn't work, you go to B, B doesn't work, then you go to C, which is not available.
No, that is because these,
it's not
let's
a
say,
barrier,
detailed
it is just a
phenotyping and
confusion.
endotyping is not available globally. Globally also this is there. If you have an overlap, you will go with one, and then if it doesn't respond, you go to the other. Is it unique to India, or is it something that we are finding globally? That there are overlapping endotypes
like they
and
showed,
phenotypes.
Randeep, that overlapping one is better with dupilumab, isn't it? That's the data they showed. So, like, we don't have dupilumab, in fact.
No, but we are talking of detailed phenotyping and endotyping. We are not talking about biologicals being available. We are saying that detailed phenotyping and endotyping is a major barrier to biological access.
So, I think major barrier is overlapping phenotype.
Yes.
Rather than the endotyping and phenotyping problem. I think, Archita, you can note down actually. Our problem is not phenotyping. Our top is that after phenotyping, it is the overlapping phenotype which comes, where many things have to be taken into account, that why to choose A or B or C. I think that is a problem.
That is the problem.
Okay.
It is a more of a problem with the COPD phenotypes than biologicals for asthmatics here.
Okay. Slides are moving on their own, so I'm just trying to figure out. Okay, we come to the next section. Is that the next section? Have we done with this? Yeah, okay, COPD. So, a substantial proportion of COPD patients continue to experience frequent exacerbation, persistent symptoms and impaired quality of life despite optimized triple therapy, representing a major unmet clinical need. If you agree, please raise your hand.
Those who are sitting on this bench actually will all have
So, we
this
all
problem.
agree, strongly agree with this statement. Chronic maintenance or repeated short-course systemic corticosteroids use is a marker of unmet need and should trigger consideration of biological therapy rather than continuous OCS reliance. This is in COPD, I presume.
So here also repeated has to be defined.
Yeah, repeated you need to say how many times.
More than or equal to 2 a year, at least for now.
2 or more.
Same as asthma, sir. 2 or more OCS, or?
I think 2 or more is right. But of course, I think that's as per the guidelines.
2 or more short course systemic corticosteroids use is a marker for unmet need and should trigger consideration of biological
But
therapy.
sir, 2 or more short course of steroid in COPD versus 2 or more short course of steroid in asthma, both has a different inflammatory.
We are talking about COPD now.
Exacerbation of COPD requiring antibiotics and steroid has many reasons, right? It may be infective, it may be per se disease worsening. So, 2 or more short course in non-eosinophilic COPD or 2 or more course of steroid in eosinophilic COPD changes the scenario for use of biologics. So, bluntly taking it 2 or more short course of steroid in COPD exacerbation, which may be because of n number of reasons.
No, but then it should trigger consideration. We are not saying should start biologicals.
And which one also has not said.
When you have a person who has exacerbation of COPD, it could be one which doesn't require steroids, although guidelines would say you give steroids also,
Yes, you
it
have
may
to
be
give.
just infective related. But what we're trying to say, if you're having such a patient, then you should consider that, should I consider this patient or trigger a consideration for biologics? I'm not saying you should give biologicals.
Got it, sir. But even before starting to consider it, we should first fulfill the criteria of consideration.
Correct.
So is it a eosinophilic exhibition or is it an infective exhibition?
There's no doubt about
For
that.
tomorrow, you might get for non-eosinophilic also.
Pardon?
Tomorrow you might get a drug for
So we are
non-eosinophilic. So
talking
that's the phenotyping, endotyping, that is
Yeah.
later.
Yeah.
But at the moment, should we considering is fine. Obviously, what else choice we have?
Or you could further frame it if you want, should trigger consideration of phenotyping your patients for biological
Further,
therapy.
So, but why are we defining it by oral systemic corticosteroids and not just exacerbations?
I didn't get that.
Why are we defining it by systemic steroids instead of just calling it exacerbations?
Yeah, we could just call it repeated two or more exacerbations.
Exacerbations despite being on triple therapy.
requiring OCS.
Yes, I think that will specify it better.
Yes.
That will specify it better.
No,
Another thing
we
we
can't
can
do that
use-
because according to the new gold guideline and Rome protocol, every COPD exacerbation is not a candidate for steroid.
Correct.
So moderate to severe will need steroid, mild will not need steroid. So steroid will indicate moderate to severe exacerbation.
So that is what I said, ki all exacerbation do not need steroids.
Exactly. So the only
what
thing
we-
is that for ICS use, gold specifies one moderate exacerbation. So for systemic steroid use, I'll need more than one, and then maybe I can think of a biologic. Because if it is just one moderate exacerbation, ICS becomes the norm.
So two
No,
or
no,
more.
one on triple therapy, Harjeet.
And can
You're
you
already
use
on
the
triple
term
therapy.
Considering is different now. Harjeet.
Yeah, but now you're saying you're
Harjeet.
already on triple therapy and they're having one moderate after
Dr.
that.
Harjeet,
After that.
considering and giving is totally different. You can consider and may still wait on it that let this patient be showing me more things before that. But
No.
if you say to give, means that you are saying only one
The
to give.
patient has to be on triple therapy. Then this statement is correct.
It is on-
Sir.
If the patient is not on triple therapy, then you have to add ICS.
So we could say patient on chronic maintain who despite being on triple therapy.
Despite being on triple therapy, needs 2 courses of steroids in a year. Consider.
So
Okay, we
I
can
think,
modify it
Archita, what
accordingly.
happened is that you use triple therapy in the last one, so it is considered that it is carrying on, but it's not clear in this, so better to add a triple therapy here.
So we can
itself.
add triple therapy
Yeah,
in the question.
that will be okay. Next.
The unmet need in COPD extends beyond the eosinophilic phenotype. There is a clear gap in therapies in non-T2, neutrophilic and mixed inflammatory phenotypes. Yeah, I think that goes without saying.
Everybody says yes.
All of us should agree to this. Fair enough. IL-33 is a key upstream epithelial alarmin driving both type 2 and non-type 2 inflammation in COPD, making it a biological rational therapeutic target. So I think that is also something that is evolving. This is actually looking at the future and molecules that it would be coming in the future. But do you all agree
This
with
question is for Tezo.
Yes.
So do you agree or don't you don't agree?
See, it's a target, yes, but whether it will
Type 2 and non-type.
No, we are saying
IL-33.
that is it a biologically rational therapeutic target? We're just saying a target. We're not saying it's effective or not.
target, yes.
The target is something you look at. The target may be effective or ineffective. That is a different thing later on.
It's a treatable
So if you look at the whole flow diagram of how the inflammation cascade goes, this is one of the.
Okay.
So it is a
Okay.
target.
Okay.
So we all agree
yes,
with
it
this.
is a target.
Yeah.
Whether it works or not, it's a target.
Correct. IL-33 signaling contributes to airway remodeling, mucus hyperexcision and impaired antiviral responses, providing a mechanistic rationale for exacerbation reduction in anti-IL-3 ST2 therapy. I think we need more data on this. I'm not sure about it.
This is published, no? This is with TOSA.
So this is published, but are we all agreeing with it? That we
Because it is published.
No, they've not, I mean, they have announced it, not published it yet.
No, the results are there.
results are
out.
there, both in terms of mucus hypersecretion and airway remodeling.
Theoretically, I think the statement is right, but
Theoretically, the statement is right. So we agree with this? If you agree, please raise your hand.
At least the data agrees with it. We don't have any experience.
So if you're neutral, raise your hand because I think a lot of people are going to be neutral in this.
Sir, if it's a consensus document, we should talk
Agree
about
only.
all biologics, not only IL-33.
No, but they have a
TSLP,
specific question because they have different things
So
in mind.
are you, if you agree or strongly agree, raise your hands.
Agree. Agree.
Agree. If you're neutral, raise your hands. Okay. And if you strongly disagree, you could raise your hand. Fair enough. Let's go to the next question.
If we strongly disagree, we won't be sitting here.
IL-33 pathway may be relevant across a broader COPD population than eosinophil-defined phenotypes, with particular promises in former smokers and patients currently ineligible for available biologicals. Again, a very loaded question. Based on data, I think it is something that you could agree on. It is.
Agree. Okay, Randeep, we agree. We agree. Not strongly agree, but we agree.
Agree, okay. Now we come to the next question. Mucus plugging is an under-recognized but clinically important contributor to airflow obstruction, exacerbation and mortality in COPD, and its presence on CT should be considered a marker of severe disease.
It is. Strongly.
I think this is something we all would agree with. Yeah.
Everybody.
Mucus plugging is mechanistically linked to type 2 inflammation, IL-13 signaling and goblet cell hyperplasia, providing a rationale for anti-IL-4RA and anti-IL-33 pathway therapies to reduce mucus burden.
खत्म हो गया यहाँ पे तो strongly agree.
This also we tend to strongly agree.
We are not seeing questions now anymore.
Oh, okay. Now it's come up.
So time out हो गया वहाँ पे.
Reduction in mucus plug burden should be recognized as a relevant clinical endpoint, alongside exacerbation and lung function when evaluating biological efficacy in COPD. So we're looking at mucus plug burden, which is something which is new, but also being considered more and more important. So yes, this is more theoretical, I agree with that. How many of us actually look at mucus burden in our day-to-day practice?
But I think it's a very question which is going to come in future because we are not able to have mucus plug counts, which they showed in the today's presentation.
So we are not using imaging biomarkers, and our radiologists are not trained to count mucus plugs.
So I think we need to develop a strategy where radiologically we can quantify the mucus plugging and then be able to say what is the burden of mucus plugging, which we are not doing right now. Not even in our bronchiectasis patients, let's put it that way. We are not doing it, but it's the future. We need to develop strategies.
It is the future.
And I think AI will help us in this.
Yes.
Sir, instead of saying mucus plug burden, we can make it more clinically relevant, reduction in sputum production bar mucus plug.
But if it's stuck, it doesn't mean it is going to come out and you can judge by that.
Sputum production doesn't always go hand in hand with mucus plug
sir,
burden. That is the main challenge.
That's why I said you can put both.
I think
clinical
instead
and
of mucus
radiological.
burden, if we just find on a CT scan that there are mucus plugs, I think that is good enough indication for us to say that there is something wrong out there which needs to be tackled.
But how do we quantify the mucus
Quantify
plugs?
is a problem. We don't have a AI to that.
And then how do you say that this is significant?
So we'll request AstraZeneca to provide us the AI.
software.
Okay, so how do we agree with this? Strongly agree? Neutral?
है? AI बताएगा?
Mucus has always been neglected in all the trials.
So agreed.
What happened?
So do we agree with this or not?
Agree.
Agree, okay. So we come to the last question then. Role of anti-TSLP in asthma in India.
Oh.
No, that slide is still being typed.
So what's the question?
The question is, do you strongly agree that anti-TSLP has a role as far as treatment of asthma in India is concerned?
Absolutely, strongly agree. Strongly.
So the same thing was indirectly asked in the previous question.
Yeah, so now they want to ask you directly.
Now it is very specific for, I think this is
So
perfectly
despite
right.
the existing biologics, how many feel there still need for new biologics?
This
So
one
is
is the right epithelial cytokine blocker, and this you really need because if you have a problem in endotyping, phenotyping, if you have a problem in overlapping endotyping, phenotyping, if you have a problem of failures, if you have those
Yeah, so
kind
this
of
is
patients
upstream,
who
it
do
will
not
take
fit.
care of everything. It may even help you as far as the T2 low asthma is also concerned to some extent.
So plenty of use basically.
Problem is that they're not able to get the approvals right now
Correct.
because
So-
they need some
so
Indian
maybe
data.
This is
Sir, the question is because we applied in the we applied with the regulatory and then it got rejected, right? So the whole idea is to get some Indian data out of this, whether there is an unmet need and all. Currently, the experts don't feel the need of NDTSLP in India. That's why if we have this consensus, then we can at least show this as a publication, scientific publication.
So I think this is a very good thing. And today, I think I'll come here with Randeep to talk about it. That in this forum itself, we were going to launch the severe asthma registry, which we are going to launch anyways. And we are going to reach with all of you with the performer and the data. And we start collecting the data. And I think maybe in 6 months to 1 year, we'll be able to have some data as to how much of our severe asthma patients belong to that unmet need group. And we can publish that. So I think that's the best thing. We have almost about 20-25 people out here. We'll be reaching out to you as soon as the meeting is over, PACS, and we will be coming up with not a huge page data, but a small one to collect that. Again, at this point, the phenoendotyping may be a little different than what we did in 2016, 2017. And we have more markers, and maybe we'll include something more like CT scan pictures itself. At least mucus plugs reported on the CT scan can be, air wall thickening can be added to that. So we'll have those data and then we will come back to that. So we will start this registry. PACS is going to take care of it. We have already decided. Performa is ready. I think Dhruv has already got the Performa. So we are going to finalize it and go ahead with it. Each one of you will be participating. I suppose we'll obviously asking for your consent to do that. And whatever number of patients we put it is all across India. People are from everywhere in India. So I think we can go ahead and do that. That's a good platform to produce the data so that you can show that this is exactly the situation. Randeep, your thoughts?
So I totally agree with that. Actually, the problem I think they have is more with the DCGI, because the experts there want clinical Indian data, and they also want data to suggest that this is an unmet need. Two things are the ones which are putting a barrier, if I'm not mistaken. One is there Indian data? I'm not sure if you look at international data, you'll probably have some Indian patients also. In international data, we have Indians all over the world, so there would be Indian patients recruited there also. But doing a study in India would be more challenging. And then, of course, what is the burden of disease, or what is the unmet need as far as severe asthma requiring anti-TSLP is concerned? That is, I think, the issue.
And this is the right platform because all our severe asthma specialists out here who are running severe asthma clinics, and the data can be easily collected. It won't be a big burden. And we can go ahead with it. Is that right? Everybody agrees to that? I think so. Perfect.
Okay. So that was the last question. Thank you very much.
Good. Thank you very much. Thank you, the experts who stayed back. We actually deprived them of their lunch. So please come now, have lunch, so that we can meet again at 3 o'clock. Rohit, you have to go to the mucus workshop. They'll be calling you in another 5 minutes. Yeah, let's go for the lunch.
I request Dr. Richa and Dr. Naved to be on the stage. We have been able to contact Dr. Dipender, and he's coming. He's coming. Dr. Dipender is coming. Okay. So, are we connected? Okay. तू बोलेगा कुछ? PACS, PGs, our priority. This is one of the features which are.
Good evening, everyone. Today, it's like immense pleasure for us, for PACS, because this PACS PG contest of Smart Minds, this is the first time happening, and more than 2,000, I guess, people participated, the students participated, and we are gathered to declare the results of this contest. And we'll be having the judges together, and then we'll be sharing and awarding all the students who have been selected, the top 5 students who have won this contest. And the expert with us will be Dr. Diego J. Marcelli. He's MD FCCP, Division of Chief Pulmonary Diseases and Critical Care Medicine, and Professor of Medicine at UT Health San Antonio. He serves as Medical Director of Respiratory Care and Medical Director of Severe Asthma Program at the University Health System at San Antonio. Completed residency in Internal Medicine and UT Health Houston, and fellowship in Pulmonary Disease and Critical Care Medicine. Founded the Severe Asthma Program at the University Health and UT Health in 2016. Internationally recognized researcher with 90 plus peer-reviewed publications focusing on severe asthma, non-cystic fibrosis, bronchiectasis, and COPD.
Professor Diego Marcelli is president of CHEST at the moment. He will be joining us online. This contest among the postgraduates was done under the flagship of ACCP CHEST, and as Kanishk said, 2,000 postgraduates across the India participated in it, and 5 of them who have excelled have been brought here, and it's our privilege at PACS to have them here. And today, first thing would be that this contest created so much of excitement that I can see that if 2,000 postgraduates participate in it, how important and how deep it has gone well with our postgraduates. We have our teachers, professors, head of the departments, evaluators who evaluated them, gave a lot of their time. We have Dr. Richa Gupta. I think she needs no introduction, but I must say the professor and head, Department of Pulmonary Medicine, CMC Vellore. We have Dr. Naved Nazir Shah, who is again the head of the Department of Chest Diseases at Chest Diseases Hospital, Srinagar. And Dr. Pratibha is representing from the Bombay Hospital, Dr. Amita Athawale, who was the judge. But yeah, so we want you to be here. We are waiting for Dr. Dipender also, and he just arrives in. He is the head of the Department of Pulmonary Sleep and Critical Care Medicine at AIIMS Patna. He has also judged all these postgraduates who participated in this quiz. So there were multiple choice questions, and some of them which were wrong by almost all or a lot of people, a lot of the postgraduates, are going to be discussed by Professor Diego Marcelli. We also have with us, there are 4 or 5? 5 smarter minds. 5 smarter minds who have made from 2000 to 1, 2, 3, 4, and 5. We have with us Dr. Akriti Bansal. Is she there? Yeah, please come on the stage. Please give her a big hand of applause. Dr. Pranav Menon. Please come on the dais. Dr. Rohita. Dr. Rohita, please come on the dais. And Dr. Tufan Behra. Welcome. And congratulations to all of you. Making first 5 out of 2000, I think it's a big achievement.
Big achievement.
So you forgive all of them done. Okay. So do we have... We don't have to stand actually. You all sit down. Please have a seat.
Are you missing someone?
Huh? Okay, we have one more. Dr. Tushar Sareen. Oh, yeah. Okay, Tushar Sareen. Okay. So do we have Professor Masali online?
Yeah, he's there.
He's there? Okay. Good evening here, Professor Basali.
How are you? Thank you so much for having me.
Thank you for coming up and supporting this young minds, smarter minds, and perhaps the smartest minds. And
thank you so much.
Thank you for the ACCP Chest to partner it with us to give this opportunity to the postgraduates in India. And I would hand over to you for further proceedings of today.
Thank you so much. Thank you so much for the opportunity. I'm gonna go ahead and share my screen here. Well, thank you so much for everyone. Hello, I'm from San Antonio. It's a pleasure to be here with everyone today. Thank you so much for the opportunity to participate. I was very impressed too with the amount of people that participated in the quiz. Like it was mentioned before, 2,000 people, that's incredible. And today we're gonna be reviewing some of the answers and really trying to congratulate those that had the highest score. So I was very impressed. Again, I would like to thank everyone for the opportunity to participate today in this wonderful academic initiative, Smarter Minds. My name is Diego Maselli. I'm a professor of medicine at the University of Texas in San Antonio, and I'm also the chief of our division, the director of our division. And I would like to say that it's very encouraging to see these collaborations, this great group of faculty, all the heads of the divisions that are present, all the students, all the postgraduate students, all the great faculty and the lecturers, and a great collaboration with everyone here, including CHEST, the American College of Chest Physicians. I think that programs like this with Smarter Minds, I think give a great, excellent opportunity for young clinicians to learn, for everyone to learn, old and young. I learned a lot too throughout the process as well, and to learn from each other and continue to grow academically. Really, in the end, what we want is to give the best care for our patients and continue to learn from each other, which I think it's a fantastic opportunity. And again, thank you so much for allowing me to participate today. So this is me. We already mentioned a little bit about myself, and we're gonna just jump right in, and we're gonna read some of the most challenging questions that we had. As it was mentioned before, these were the ones that people often had wrong, and we're gonna just revisit very briefly some of the key concepts about these questions, and then we're gonna go and announce the winners of these contests. So this is the first question. This is a 68-year-old man with a history of COPD, diabetes, who presented to clinic with a 2-day history of sudden onset of respiratory symptoms, aches, muscles, a dry cough, no chest pain, some shortness of breath. He has been compliant with his medications, included metformin for his diabetes, lung beta agonist, inhaled corticosteroids, and lung muscarinic antagonist, so triple therapy really for his COPD management. So we already know that this patient has likely advanced COPD. He stopped smoking, fortunately, 5 years ago, but did smoke for 30 years. Physical exams reveal a little bit of temperature, 38.6, respiratory rate 20, normal lung sounds, and the rapid influenza diagnostic test is positive for influenza A. So here are the options for what potential therapy we could give to this patient. And you can see the options there. And the right answer in this case is the baloxavir, which is currently the recommended treatment for non-severe influenza patients who are at risk for progression of severe disease, such as older adults, like in this case, in patients that have chronic conditions. And so we'll talk a little bit more about that. The conditions typically include older age, but also respiratory conditions like COPD, like in this case, cardiovascular disease is a big one, chronic kidney disease, chronic liver disease, and of course, asthma. So that's why this was the right answer for this question. What about, a little bit about baloxavir, and I think it's a relatively new medication. When I saw the question, my first guess was, okay, it's probably oseltamivir. But when you look at baloxavir, this medication is given just one time, and it's just one single dose versus 5 days of oseltamivir, and it is likely, better for compliance. It's just a single pill versus taking 5 days for the oseltamivir. And in general, we've seen that these medication can reduce the symptom duration and potentially may reduce the risk of hospitalization and high-risk patients, just like the one we had. Oseltamivir is good. It's a good medication. There's no doubt. We've used it extensively. But for patients that have non-severe flu-like infections, this is likely not going to really change the prognosis or the course of the disease. And so the World Health Organization really recommends against administering oseltamivir in these types of patients. So that's the reason why this answer was wrong. What about this zanamivir? And I have not used it often, because this is a medication that in our practice, because we see a lot of pulmonary patients, sometimes this medication has been linked to bronchospasm. It's a medication that's given via inhalation. So in this case, with a patient with COPD, potentially advanced disease, already on triple therapy, this was probably not the best choice. And then peramivir, which is a medication that also a neuroaminidase inhibitor, can be used, but this is intravenous, and intravenous in this case is likely not indicated. Typically, this is for patients that cannot tolerate PO or those that are very sick, very severe disease, and that's why this is not the right answer. So this is the key point for this question. Patients who are at high risk for non-severe influenza, the WHO guidelines recommend baloxavir as the right medication, and we talked about why this might be the best choice. Okay, let's move to question number 2. So this is another patient, again, with COPD. We see it often. 89-year-old woman presents with outpatient clinic for dyspnea. She has dyspnea. She smoked 2 packs for 30 years. She uses oxygen, so we know she's advanced. According to her pulse oximetry data, she's requiring oxygen. She's participating in pulmonary rehabilitation and has done a total of 12 sessions. And results from the pulmonary function testing showed a total lung capacity of 165%. So we already see some hyperinflation and residual capacity of 145%. You see already some air trapping. Typically when we see numbers above 120%, that's when we start thinking about this. Residual volume 155%, and FEV1 is 30%. And you can see the rest of the numbers. The LCO is also low. She's currently on fluticasone, meclidine, bilanterol, triple therapy, 1 puff every evening. She's already on roflumilast, so really advanced therapy, and albuterol as needed. And she remains very dyspneic. She has a lot of shortness of breath. And here we have the options of what can we consider as the best option for her. So we see, could we send her to lung transplant? Do we do endobronchial valve placement and lung volume reduction surgery? Or we just should give 20 milligrams of prednisone in this case. So what is the best answer here? The best answer here would have been endobronchial valve placement. This is a procedure that has gained a lot of popularity of late, of the past, I would say 5 to 6 years, maybe 8 years, I would say, has been used now more frequently. It's done endoscopically, it's less invasive, and has shown some improvements in our patients with dyspnea and really the quality of life. And you know, we already knew from the NET trial that volume reduction surgery can be beneficial in patients with COPD, but now with the valves and the data that continues to emerge, this is a non-invasive procedure, and in some studies it has been shown to have comparable results to surgery. So nowadays this is probably the best option for patients with COPD that have air trapping and hyperinflation and low FEV1, and it helps with their shortness of breath as well. In my practice here at the University of Texas, we do have a lung transplant program. We do have the ability of surgery, and we do have the valves. I think the vast majority of our patients are going to the valves, and whenever this disease is very severe, then we move to transplant. I have not referred many patients for surgery, at least in our practice here at the University of Texas. And lung transplant, well, she's 89, so she might be a poor candidate at this point for lung transplant, even though there's no age restriction, technically speaking. It used to be 65, then they pushed it to 70, then 75, but there's no age restriction, but 89 is potentially not the best option. And prednisone, as you know, with all these different options that we now have, including biologics, I know you had the very nice lecture on biologics and COPD, then this is now is a less preferred option for sure. So this is the key point, endobronchial valves for advanced COPD are less invasive than surgery and potentially equally effective, and it would be a good option in this patient. Okay, we're going to move on to our third question. We just have 4 questions, so this is the third question. This is a 55-year-old with asthma, returns for a follow-up evaluation. Patient status is maintained with triple combination therapy, not a triple therapy, high-dose ICS, LAVA-LAMA, and she's also on azithromycin 3 times a week, so really advanced therapy. 1 year ago, she became dependent on steroids, and dupilumab was started, and she had actually improvements because their prednisone was stopped. Since then, unfortunately, she has had multiple exacerbations that require oral steroids, and we checked and she's adherent to her medications, which is very important, no smoking, and FEV1 we already see that FEV1 is low, 50%, with an obstruction based on FEV1 FVC ratios. She has a positive bronchodilator response. We see now that her eosinophil counts are 100, IgE is 20, and FeNO in this case is 15. So we see low type 2 biomarkers, and a high resolution CT doesn't show any bronchiectasis, interstitial lung disease. We just see kind of like the typical signs. So here what should we do? So here they're asking us a very specific question. This was a challenging question, I will say, very challenging. They're asking us which agent should we consider in this patient. They're asking us actually to consider switching because she's already on dupilumab. So here we have these options: benralizumab, mepolizumab, rosalizumab. So A, B, C are IL-5 therapies, and tezepelumab is a anti-TSLP therapy, and that is, in this case, the right answer. This patient, again, this question was challenging, very challenging. When we see this patient, we see type 2, that she's a non-T2, at least at this point, she's non-T2. What do I mean by that? The biomarkers are low. I know that, again, you had the nice lectures from Dr. Weschler and Dr. Bull about severe asthma and the biologics and how important to do phenotyping. It seems like in this case, she has no features of type 2 inflammation, and we're assuming that this is not related to recent use of steroids. And as you know, asthma is very heterogeneous. The vast majority of our patients, I think, around 70% or so, have type 2 inflammation, but there are some that don't have type 2 inflammation. And I know that you already reviewed this extensively in the previous lectures, so I'm not going to talk too much about it, but just to remind us that we do have these biologics that block specifically these type of pathways. Today we saw on the question that they asked us about the rosalizumab, benralizumab, and mepolizumab that target IL-5. We now have the pemokimab, the ultra long acting, that also targets IL-5, and then dupilumab in this case that was used, and tezepelumab which targets TSLP. In this case, we have a non-T2 patient, and in the study, the Navigator study with tezepelumab, it didn't matter if you had high T2 or low T2. Patients that were treated with tezepelumab had reductions in exacerbations, and therefore is currently approved for those patients that have either T2 or non-T2 inflammation. So this is something that we have used in our practice in our patients that don't have low eosinophils, low FeNO, low allergy profile, and this has been beneficial. And I think it's one of those medications that you can use for any severe asthmatic, and it's tricky. In this case specifically, they ask us to switch. And I think one of the things, and again, there's a lot of debate about when to switch biologics. I think we most of the time wait 4 months. Some providers wait 6 months even, and before considering switching. But if your patient has had multiple exacerbations, particularly 2, 3, or even more, then you should definitely consider a switch because now we have so many options in the space of biologics. And you've seen this already in the previous slides. This is the targets. These are the treatable traits. And importantly, these medications have been approved for a lot of other diseases. You can see the list there. And when you look at tezepelumab, as you can see, no specific biomarker is needed. So, like in the patient that we talked about, this could have been an option to switch to that medication. Here's an overview of how we give these medications, and you can see that we have a lot of flexibility. At least in the United States, we have the home and clinic use in the vast majority of these. Rosalizumab, because it's IV, we have not used hardly. We have just a couple of patients. The majority of these patients get subcutaneous therapy at home, and some of them get it at clinic. So this is the key point: non-T2 asthmatics, defined by those that have no biomarkers, either low EOS, low exhaled nitric oxide, or low IgE, allergic profile that is low. Then those patients may be a candidate for tezepelumab. The patient was already on azithromycin, which is something that we use in these patients as well. So it's reasonable to switch in this case from dupilumab to tezepelumab. The last question, this is the last question before we announce the winners. This was what I thought also very challenging question. The sleep is a challenging field at least for me. I'm more of an asthma, COPD, bronchiectasis person, but this was I thought it was a challenging question too. This is a 55-year-old woman, history of moderate COPD, has concerns of difficulty initiating sleep for the past 3 years, so quite some time. COPD is well controlled, fortunately, with triple therapy, so we know already that she has some severe disease if she's on triple therapy. No risk factor for OSA, so BMI is low, suggesting that most likely she doesn't have OSA. No snoring, and we see the other markers that suggest that she has no risks. On further history, it's very interesting. She goes to bed at 8 p.m., so early, and really gets up and wakes up until 7 a.m., but really doesn't sleep well. Spends a lot of time in bed and really experiences a lot of awakening episodes each night. Given that she's taking 3 to 4 hours to fall asleep, she gradually moved her bedtime even earlier to try to see if she could sleep even more, but she hasn't been successful. So here are the challenging question, and is what should we do about this patient? Should we do sulpidem? Maybe perform really a sleep test, apnea test to see really what's going on in the evenings to rule out OSA, even though she has technically no risk factors. Reduce the time spent by going to bed later, 11 p.m., and then seeing how she feels, or in this case, start trazodone 50 milligrams at bedtime. I thought this was a challenging question for sure. And what is the answer? The answer is actually to reduce the time spent in bed by going to bed at 11 p.m. to midnight, and really going to bed only when sleepy, really. That is it. If you think about it, the patient's spending 11 hours in bed and can only sleep for only 7 hours. So this is something that would be recommended. Going to bed early when not feeling sleepy, it might be a maladaptive behavior and may perpetuate this chronic insomnia. And so at this point, that's what most likely would have been effective in this specific patient. Sleep restriction at bedtime is a behavioral intervention, and it's a component of this cognitive behavioral therapy for insomnia, CBTI, and it's really designed to reduce the time spent in bed and just become more effective in the time that the patient's actually resting. And bedtime and wake time are assigned based on the patient's personal preferences, so you can ask the patient what do they prefer. OSA, it's obviously something that we always worry, but typically there will be some form of, symptoms that she reports or something, but there's no risk. We talked about the fact that the BMI is not high, and we also felt like in this case, it's probably better to do an in-laboratory polysomnogram. That's the preferred modality, particularly if you're going to do it because the patient already has advanced lung disease and it's likely the best indication. Sulpidem can be used and is effective treatment for insomnia, but the patient in this case wouldn't be useful. The patients, I think, would better benefit from the other interventions. And then trazodone is used quite frequently for insomnia, but really for treatment initiation of sleep is not the best option. And currently, at least in the United States, is not approved for chronic insomnia. So I think the best intervention is to do some behavioral changes in her case. And this is the key point. And the final point, sleep or bedtime restriction, a component of this CBTI, is really an effective strategy. It has been shown to be effective to treat patients with chronic insomnia. And that's all I have, I think, for today. Before we announce the winners, as we culminate this Smarter Minds, I would like to really thank everyone for the opportunity to be here from San Antonio. It's really a pleasure to see this great activity and the culmination of this activity. I would like to really thank the partners really that have done a tremendous job in organizing this, particularly PACS, the PACS Foundation, Insignia Learning, CHEST, and all the faculty and the directors and the chiefs of the divisions that are present. It's really an honor to be with you. Also, definitely a special, very special acknowledgement for supporting the activity. This PG initiative to Glenmark Pharmaceuticals, who have really supported this and plan to keep on supporting this great initiative for learning. I think this platform has been really great for participation. 2,000 people answered the quiz, which was fantastic. I was very impressed about that. And I think this enhances the learning, the collaboration that we have. And again, the objective is for our patients to get the best treatment And thank you again for allowing me to participate today. Thank you so much.
Thank you so much, Professor Dr. Diego Marcelli. And now we have come to the end, and now it's time to present the awards to all the winners. For award distribution, I would hand over the mic to Dr. Deepak Prajapat.
Thank you, Kanishk. And it's a time for the felicitation. So I request Dr. Deepak Talwar sir to please be on the stage to join us. So we have 5 winners from each zone: the Central Zone, North Zone, West Zone, South Zone, and the East Zone. So I request all the judges to please be
Come on the center stage, sir, please.
Center of the
Please.
stage. Yeah. So the first winner is Dr. Akriti Bansal from Central Zone. It's our pleasure to felicitate the winners who did excel in the field of pulmonary medicine and they win the prize. So the next winner from the North Zone is Dr. Tushar Sareen. So this trophy is from the PACS side. And also, I would like to inform So, Dr. Akriti, please be with us. We have many more prizes. So please be with us on the stage. So the second winner is from the North Zone, Dr. Tushar Sareen. So Tushar is from KGME Lucknow. This is a proud moment for all the winners who facilitated on the PACS stage. So the third winner is from the West Zone, Dr. Pranav Menon. So Dr. Pranav Menon is from BJMC Hospital, Ahmedabad. So winner for the South Zone is Dr. Rohita. So Dr. Rohita is from GGH Hospital, Kakinada, Andhra Pradesh. So this is the first time when ACCP Chest doing the quiz with the PACS and so now from the East Zone we have Dr. Tofan Behra. So Dr. Tofan Behra is from MKCG Medical College, Brahmapur, Odisha. I request all the winners to join us on the center of the stage. All the winners with the trophies. Yes. So give a big round of applause for all the winners. And there are more exciting prizes for the winners from the PACS side. So they all are Excel, but the excellent is Dr. Akriti Bansal. There is a mega bumper prize for the winners, and for Dr. Akriti Bansal.
The surprise is not over. The first winner, the topper, Akriti Bansal, will get the grant for go and present her paper in Sri Lankan Chest Society meeting in February 2027. You will be a host from PACS to do your presentation there.
And for rest, all 4 winners, we are providing an Amazon voucher of 10,000 rupees each. So congratulations to all the winners. It's a proud moment for the family members also.
Message to all postgraduates across India. Contests will keep coming. Participate. Participate definitely to improve on every time you participate in one quiz. There is always a chance to win next time. So those who could not make it this year will definitely get a chance next year too. PACS is committed to postgraduates. You are the closest to the heart of PACS.
And this is not the end. Tomorrow we have one more quiz contest with the Boston Scientific Society, and that will be from PACS side also. The timing will be 7 to 8 p.m. So all please be with us tomorrow evening. That is going to be very exciting because there are 5 rounds of the quiz which will be live. So stay with us till tomorrow evening. Thank you.
Thank you, everyone. Now we officially declare that the dinner and the gala dinner is open. Everybody can have what they want, and let's have some lighter time. Lots of study has happened already during the daytime, but yes, keep yourself hydrated because tomorrow will be the main conference. Let's have some fun. Do we have Dr. Diego online? We wish to thank him. Can you see us? Dr. Diego, we are thanking Dr. Diego online, yeah. He is logged out. But anyways, you can see the recording then. We are very thankful to Dr. Diego for his time and effort. Thank you so much.